ओके सर एक सर ये
हेलो हेलो 1 2 3 4 5 6 7 हेलो चेक मनीष आवाज आ रही है अच्छे से अभी आवाज आ रही है लेकिन मैंने जो ऑक्स आउट दिया तुम लोगों ने एकदम फुल रखा मैंने लेकिन कल मैं 50% रखा था अभी आ रही है ओके अब वीडियो मेरा बराबर हो गया ठीक है तुम लोग का बैटरी मेरे पास पड़ा है क्या करना है ठीक है चलो ये ओटी का कैमरा हेलो नहीं वहां से मिक्सेस से किए 50-50 क्या है अरविंद जी
Hello, Arvind. Arvind from OT. Arvind. Manish, Arvind. फोन लगाना।
यस सर।
हाँ, उनको बोलो मैंने लोगो भेजा हुआ है, ठीक है?
ठीक है सर।
और बोलो कि उस पे लगा के चेक करके पूरा अपडेट करें मुझे।
ओके सर।
हाँ, आवाज आ रही है? हेलो हेलो, आ रही है ना? हाँ, इसको नहीं।
एक बार हाँ, ऑडियो वीडियो एक बार देखो।
ठीक है।
वीडियो चालू करके बैकग्राउंड में बैकग्राउंड देना पड़ेगा। ठीक है, मैं कर लूंगा।
पीछे ब्लर कर दो क्या?
नहीं, मैं करता हूँ। वर्चुअल बैकग्राउंड पे
हाँ।
कभी म्यूट करना रहेगा, कभी खाली बता दो सर।
म्यूट करना रहेगा ना।
ओपन रिसर्च भी करता है, टीचर भी करता है।
Yes, you are audible.
Okay. Okay, Arvind. Thank you. Namaskar. Namaskar, good morning, and welcome to one and all. Myself, Bhalchandra Joshi, I'm marketing head with Burgeon Nova Division, with makers of Joseph, Enzoflam, and Oxum. At the outset, I welcome you all to LAP Unlimited, 11th National Conclave on Laparoscopic Surgeries, in which we are going to see laparoscopic stalwarts performing their best. Let me take this opportunity to welcome Dr. Roy Patankar, who is Director of GI and Minimally Access Surgery, Zen Hospital, from where these surgeries are getting performed. I also welcome all the stalwarts in the field of laparoscopic surgeries like Dr. Palani Velu, Dr. Abhay Dalvi, Dr. Randeep Wadhwa, Dr. Niranjan Agarwal, Dr. Pavanendra Lal, Dr. Sendil Nathan, Dr. Tamonash Chaudhary, Dr. Rahul Mahadar, Dr. Ramana, Dr. Dilip Gode, Dr. Nitish, Dr. Sanjeev, Dr. Shishil, Dr. Suraj, and many more. I'm sure that this workshop is going to be a unique academic feast wherein it combines the art and science of laparoscopic surgeries and surely going to help us in knowledge and surgical skills development. This is basically a hybrid conference where 33 centers are streaming this conference live with almost 1,300 delegates, and more than that, 3,000 registered delegates are also going to see this live event. So with this, I hand over to Dr. Roy Patankar to take the agenda ahead. Thank you, Dr. Roy.
Many thanks, Mr. Joshi and Alchem Burgeon Nova for their support in making this conference possible in this COVID-affected year. Last year was the only year we haven't held our annual workshop, and this is the 11th time we're doing this. So this time we have a phygital event. We have 31 centers today, each of which will, including Mumbai, Thane, Srinagar, Indore, and many other centers, where 50 surgeons will see this sitting physically. And we have a number of medical colleges, including Surawadi Medical College in Dhaka, where my friend Dr. Mamoon is coordinating. We have more than 100 registrations from Bangladesh, Nepal, and Sri Lanka. With this, ladies and gentlemen, I welcome you to the 11th National Conclave on Laparoscopic Surgery. Our first two surgeries will be ventral X patch, demonstrated by my colleague in the Zen department, Dr. Vishakha Karikar, assisted by Dr. Ajit Mishra. The second OT, I have my friend Dr. Pramod Shinde from Nasik, who's going to demonstrate IPOM Plus for IPOM. We have a day full of surgery ahead of us. Just the flow of the program is such that the live surgery will get over at 5:30. At 7 o'clock, we have a symposium on fluorescent imaging, which will last for about an hour, where we have stalwarts in this new exciting field of fluorescent imaging talking to us about the recent advances in fluorescent imaging and how it's going to impact our surgical practice. At 8 o'clock, we have a faculty dinner with live music. For whoever is in Mumbai, Thane, Panvel, Vashi are invited for this. I look forward to interacting with all of you digitally, if not physically. And Dinesh, can we start live transmission from Dr. Vishakha's OT, OT1? The second screen will have OT3, Dinesh. So OT1 and OT3 on the live screen. Please feel free to ask your question through the moderator, which will be relayed to the surgeon, and the surgeon operating will answer this. And I look forward to interacting with all of you in the course of the day. Thank you very much.
बोलो क्या? Good morning, ladies and gentlemen. Am I audible?
Yes, ma'am.
Okay, all right. I'm Dr. Vishakha Karikar, and I welcome you all to our 11th Laparoscopy Unlimited workshop. My patient is a 50-year-old gentleman who has a swelling in the umbilical region. The defect is a centimeter in size with omental fat. He also complains of some pain because of the fat being there. The plan is to demonstrate a laparoscopic ventral X patch repair. I will show you what we have done till now. So I'm being assisted by Dr. Ajit Mishra, and on my head end at the anesthesia is Dr. Reena. What we do is, this is the umbilical defect. I start by taking a smiling incision, which is around 3 centimeters in size. And then we approach the defect through the anterior sheath. This is not how it is classically described by putting a 10 millimeter port through the defect. Once we put the 10 millimeter port through the defect, I put another 5 millimeter port at the palmer's point. I will just show you that. CO2 reduce a bit.
Dr. Vishaka, what size defect would you use this technique for?
We can use this technique for defects up to 2.5 to 3 centimeters in size, nothing more than that. So this
Can
is,
you tell us the Zen protocol? What size
Yes.
defect you do ventral X, what size you do IPOM plus, and what you do open repair?
so up to 3 centimeters, we do a ventral X. Between 3 and 6, we can do an IPOM. Anything
IPOM plus.
IPOM plus. Anything above that would probably require some sort of component separation. Whether you do it open or laparoscopic is a matter of choice, but we do it open here. Anything above 6, 7 centimeters, we can offer them a TAR or any component separation.
Take your camera out and show us the
Yes.
ports from outside. So using a Striker 1688 ICG enabled camera. I think in all the, we can see the 5mm port and a 10mm port which has gone through the umbilicus. We have an obese gentleman here.
In addition, you will see that I have taken 2 sutures of 1 number Ethylon on the anterior sheath. Now, this is to make my life easier, especially in obese patients where it becomes difficult to find the sheath once we have deployed the mesh. It doesn't make much of a difference in thinner patients, but it makes our life easier in slightly obese patients where the anterior sheath is held up by taking these 2 sutures. You can even take 4 at 12, 9, 6, and 3. But usually 2 sutures are enough to anchor the anterior sheath.
So all our sutures for the entire workshop are supported by Helvium. So we're using only Helvium sutures today. Thank you.
After putting the scope to the 5mm trocar, this is the defect that is seen.
So Dr. Vishaka, the conventional way doesn't mention a 5mm trocar. What is the line of thinking of putting an additional trocar on the side?
The line of thinking is that once the mesh is deployed, we get a good vision whether it is lying flat against the anterior abdominal wall. So at least later I am at peace knowing that the mesh is now sitting well and there is no crumpling or folding. Hence, we put the 5mm as an additional safety mechanism.
Absolutely. This is also born from our experience in a single patient where a loop of bowel had gone between the mesh and the anterior abdominal wall. So ever since that day, 4 years ago, we've been putting a 5mm scope, and we are extremely, what is the advantage of this over doing an open surgery? There are many senior surgeons who would say, why not do an onlay Prolene mesh for a 3 centimeter defect?
We can do one.
Person.
Yes, we can do one, but the disadvantage is that for a 3 centimeter defect, you'll have to do a lot of subcutaneous dissection for an onlay repair. Then the patient is going to have drains. The drains are going to be in place for up to 7 days. More chances of seroma. So it's better to avoid all of that. And this is a good repair. It's an easy procedure to do.
Yeah, excellent. So, we do these surgeries as a daycare surgery. You can do it early in the morning, send the patient home the same day. He has a subcuticular suture at the umbilicus and no drains. Is that correct, Dr. Vishaka?
Yes, absolutely correct.
We have now done more than 300-400 of these ventral X patches and extremely happy.
Yeah.
The only caution we have is we only use 8 centimeter patches.
Yes. So there are 2 sizes.
So can I ask you one question? Normally in IPOM, you say that you should have a 4 centimeter overlap.
Yes.
And here in a 3 centimeter defect, you are using 8 centimeter patch.
It's still a 4 centimeter overlap, and at the umbilical region, it doesn't matter because it matters lesser. It is okay, all the forces act there, so we can get away with that.
Can I ask Dr. Ankur Patel to show us that mesh that we are going to use? So we're using a patch. This is a circular patch, which is 8 centimeters in diameter.
So this is a circular patch, 8 centimeters in diameter. It is like a composite mesh, which has 2 sides, collagen and the proline. I will open, once Ankur opens it and I will take it, I will show you what are the components of the mesh. Another important thing is always change your gloves before handling the mesh and make sure no one else handles the mesh.
This point is extremely important. Only autoclaved instruments, only EPO sterilized plastics. Be very, very careful for any hernia, And particularly in a workshop setting, please make sure that there is no compromise. Can the cameraman zoom onto the mesh?
So this is a circular patch. This side is the collagen side, which will face intra-abdominally. And this one is towards the anterior abdominal wall.
And that is polypropylene.
Polypropylene. So it has two wings. The two wings get anchored to the anterior sheath. And it has two pockets here, if you can see. They are semicircular, which I will put my finger once the mesh is deployed to open it up.
So what is the use of these pockets?
So the pockets help to deploy the mesh, and that's how the mesh gets anchored flat against the anterior abdominal wall.
Yeah. So whenever inside you put your finger inside
Yes.
and make sure that it's flush to the wall.
Yes.
Excellent. So what are you doing now?
I'm just going to activate it in saline for around 10 to 15 seconds.
Collagen layer. So the collagen layer covering the proline gets activated by dipping it. Again, we make sure that we have a new bottle of normal saline, and Vishaka is activating the collagen by putting it in. Can you also show us how to fold this mesh?
Yes, I will.
There is a ring. Can you demonstrate a ring to us? And what is the use of this ring, Dr. Vishaka?
So this is the ring here. If you can see where my finger is pointing, a dark purple circle that you can see.
It well.
So this stabilizes the mesh so that the mesh doesn't get crumpled. That is the function of this. Now you fold the mesh into half. Don't fold it into four.
Why?
Otherwise it's going to break.
The ring breaks. Yes.
And hold it with an artery and deploy it inside.
Focus on mesh. बहुत बढ़िया. Mesh के ऊपर हाथ निकालता है left hand. Let them see the mesh going. Yeah, excellent. So you are avoiding contact of mesh with the skin.
Yes.
Folded it by 180 degrees and then inserting the mesh inside. While the two sutures are drawn erect by Dr. Ajit. The two wings remain outside. Is that correct?
The two wings remain outside, and we'll just hold them up till the mesh gets deployed.
Yes. Excellent. So now show us how your finger, the left hand is blocking. Show us how your finger goes into go inside the patch. So you can see Vishaka's index finger going into the pocket.
Yeah. So
taking out the mesh.
The finger makes sweeping movements like this.
Can we ask Dr. Pramod Shinde to start his case in the other OT? We are having on the second screen.
Okay. Yeah.
Good morning, sir. We have a question online. It's from Professor M.L. Saha from Kolkata. He wants to know if the gut is adherent to the sac, then how do we insert the first port?
What is adherent?
What is adherent to the sac?
The gut.
Sorry?
The bowel.
So first, that is how we take the incision on the skin and then dissect the sac, release the bowel, put it down, and then go further as planned.
I want to welcome Dr. Makhanlal Saha, who is one of the best known teachers in India. He's very well known for his role in surgical education. He's written a wonderful book, which is used by almost all postgraduates in Mumbai. Dr. Saha is head of department at the Bangur Hospital in Calcutta, where a large number of surgeons have collected watches. Saha sir, thank you for joining us. As Vishaka mentioned, you make a small incision, separate the bowel off the sac, and only then we'll deploy the mesh. So Vishaka, now we're seeing a mesh, the small fold in the mesh. Does that worry you?
It does worry me. I will see to it that it gets straightened.
So in our experience, we very often see this, and now you can see it is completely straightened out. So this is the reason of putting the 5mm telescope. We've seen almost in 20% of our ventral X patches, there is a fold in the mesh, which otherwise I think we would not have picked up.
Actually, Roy wanted me to show right from the viris. That's why I was waiting. You start? Okay. Where?
Then you can fix this. Yeah. So it's beautifully deployed. Now, can you show us what you do to the wings, Vishaka?
Yes, I will. Now we will take one suture through the wing and through the anterior sheath so that the wings get fixed on the anterior sheath.
Now, while you are doing this, I'm going to shift the audio to Dr. Pramod Shinde in OT3, who's going to demonstrate IPOM plus for a ventral hernia. Pramod, we are with you. Can you take us through this?
Yes, Roy, thanks for inviting me here, and very good morning to all our viewers. Now, this is a patient of a recurrent hernia where she's a middle-aged lady who has had an open hernioplasty for umbilical hernia. So we presume that maybe the details of the mesh are not there, but we can see a scar here and a bulge here. The umbilicus doesn't show any defect, but the CT scan is showing two defects. One is 3 centimeters and the other is 22 mm 2 centimeters. There's a limited divarication seen on the CT scan, and there is a scar infra-abdominally, but there is no defect palpable or seen on the CT scan. So the plan for this procedure is diagnostic laparoscopy followed by a laparoscopic IPOM plus. So like in a standard IPOM plus, we first do markings on the abdominal wall. We mark the midline, we mark the defect, and then we have tentative measurements marked all around, so we know that where to put our ports. So if we know that the minimum size of mesh that we'll be using is 15 by 15 and possibly 15 by 20 because there are 2 defects and we would want to cover both of them. So in order to have our ports not clash and come close to the mesh, we have already marked that area. Now these markings might change a little because these are non-distended abdomen. So after distension, we will get a little more distance. We can always break the table and get more distance between the costal margins and the hernia defects. So we have actually broken the table, but not as much as we do in an ETEP. It's just 5 or maybe 7 degrees, but we have an option. So now we have put in a VDs at the palmer's point.
So,
okay, we have checked it with.
Can we focus on the markings, please?
Okay, and now we are going to start insufflating. Now with me, Dr. Pranav is a surgeon from Indore, an alumni of Zen Hospital, and Roy, who himself does laparoscopic surgery in Indore. He has joined us for this workshop, and Anil is assisting me. So, yeah, Dr. Anshul and Dr. Dhruv are the anesthetist team, and we have an excellent system from Stryker 1688, and we also have. We are going to use a Megadyne, a smoke evacuation system from Johnson & Johnson for this case. So we'll see how it works nicely.
So we have a suggestion from Dr. Sachin Jama, sir. Can we focus on the markings, please?
Telescope telescope picture. Dinesh, give us telescope picture. Top down. Yeah, that's a good suggestion. Dr. Sachin Jama is professor of surgery at Solapur Ashwini Rural Medical College. Also a postgrad teacher. Sachin, thank you for coming.
See now, this is the midline mark, and this is the center. There's a defect here, and there's a limited divarication here. The second defect is not palpable actually. Okay, you can see the abdomen distending, and these are the markings we have made 5 and 10 centimeters. These are the 15 centimeters markings. So we know that we have to be away at least 5 centimeters for the working distance for the ports.
These markings are made in an undistended abdomen.
Okay. So we'll get additional 1 to 1.5 centimeters after distension. So we'll move further away. Now standard IPOM plus are generally done through lateral ports, but many of us use a triangular configuration with 1 port in the epigastrium, which we will decide later on once we have a look inside.
So for you, in a midline umbilical is always the viewing port is always left subcostal. Is that
left
correct?
subcostal, 1 epigastric, and 1 left anterioaxillary.
So extremely interesting because many people like me put 3 lateral ports.
Yeah.
Ergonomics, do you find that comfortable?
This becomes a little easier for suturing.
And would you ever stand on the head end of your patient, Pramod? Or always on the side?
Always on the side. Always on the side.
Because the GEM group stands at the head end of the patient and puts 3 horizontal ports in the epigastrium.
Yeah.
So it's horses for courses.
Yeah. Even if we put 3 ports like this, and we do that, we will need a 10 mm here, and that it makes it even more ergonomic.
Right.
So, but because we have got something here, so I don't know whether we'll be able to come up right up till here if you put 3 ports here.
So can I ask you what your choice is between scola in somebody who's got a umbilical hernia and divarication, a scola versus a ETEP versus a IPOM plus, a 3 centimeter defect with a divarication?
If it is a 3 centimeter defect with a divarication, my choice would more be towards an ETEP rather than scola. Although scola is a good procedure and it is an absolute valid choice for that, except that scola would involve subcutaneous dissection, and if the patient is not able to follow up with this, the seroma can be a little bit of a problem. So my personal preference is for ETEP if we have to repair a divarication.
So I think, are there any guidelines on this, Pramod? I'm not aware of any literature or guidelines on this. So what is your thinking? Which patients do you do scola? Which do you do ETEP? in your practice? Dr. Pramod Shinde is one of the best known surgeons in North Maharashtra. He's director of Kaushalya Hospital, a close friend of mine. And may I also add, standing for governing council from the state of Maharashtra. So I would encourage all the viewers watching this to support him in the upcoming ASI elections.
Yes. Yeah, thank you, Roy. And 3 centimeters and below, if it's a 2 centimeter defect, then E-tap would become too much of a dissection. So there we would do an IPOM plus. Any defect more than 3 centimeters, above 4 centimeters, we would go for an E-tap RS, because then, and especially if it is associated with divarication, we would go for an E-tap RS. Now, even in this distended abdomen, we can see that there is a bulge appearing above the umbilicus, which was not actually obvious clinically. There's a thinning seen in the CT scan. So our upper port, unless we have adequate distance, that we may not be able to do everything through the epigastric ports. We might have to do more work from the lateral ports.
So in your practice, IPOM plus is dead?
Not really, because we do get 2 centimeters, 1.5 centimeters.
Is there room for ventral X patch in that?
I personally have not done it. I would be little afraid of not having the mesh up on the abdominal wall, but I saw Vishaka put in a scope inside.
Correct.
So that would make that procedure safer. Right. And especially if the skin is thin, which you have any way I got to exercise, then ventral X patch.
So the jury is really out about choice of procedure in these patients who have a 3 centimeter defect with a divarication. Our own thinking is smaller defects with larger divarication, we do SCOLA. Restricted anything between 3 and 6 centimeters without divarication, we only do IPOM plus in Zen. And in patients who have small divarications and 3 centimeter defects, we would do E-taps. But I personally find it difficult to get my head around the fact that you do so much of midline crossover, extensive dissection for E-tap. But I may be in a small minority. So you see Dr. Pramod doing an OptiView insertion. Pramod, talk us through this. What layers, you are in subacute now?
Yeah. See, now we should first ensure that our scope is focused and the vision is excellent because of the system. And as we use slow twisting movement, we keep a gentle pressure with the right hand on the scope, and we use just twisting movements. Now we would like to be absolutely perpendicular. Sometimes we can ask an assistant to put a pressure here so that the pressure of the air column gets transmitted more towards the upper abdominal wall. So now we can see the fat layer being dissected. Okay, and as we go further, we will be able to see the muscle layers. Many times we are able to identify muscles layer by layer. Okay, so we can see the Scarpa's fascia, and as we go inside, the muscles will come into view. In an obese patient, sometimes you may not see the clear-cut fibers because every intermuscular plane is has got a fat. See, now we can see a white rim here, okay, and we have gone beyond that, and as we are going beyond that, further layers are coming into view, okay, and we will continue to twist, add pressure, okay. We can increase the speed because right now I can also feel the bouncing movements of the CO2, so I know that. Okay. Okay. So now you can see a red tinge and few capillary-like vessels, and you can see a.
What layer is this now, Pramod?
Now
the white that you're seeing now.
The white white is generally the aponeurosis of the external oblique. Beyond that, you can see that red tinge would be the muscle.
Beyond that, again, is there a white seen beyond the muscle?
Yeah, right now we are seeing the whites there, but generally we would expect all 2 muscles to be absolutely muscular in this area. Now you can see the muscle layer beyond that. Okay.
Beautiful image with this 1688 striker system.
We can again check with the focusing.
Yeah.
Okay. So after the white comes the red pink muscle layer. Okay, so sometimes we are already inside the peritoneal cavity. So internal oblique and transversus abdominis sometimes cannot be differentiated through the OptiView port. So external oblique, white aponeurosis, the 2 layers, and then we can see that we are inside the abdomen. But we need the cone to be inside. Okay. And we know now that there are no, so I'm slightly changing the direction, okay, so that I don't impinge on the omentum there. and then I have gone inside.
Completely inside.
Okay.
Excellent.
Now, so we are completely inside.
Yeah. So we just show us, then we'll shift the, in a minute, we'll shift to Dr. Vishaka, who is finishing her Ventralex patch.
Ye pakdo.
As you can see, the Ventralex patch, in spite of having a live demonstration, took her hardly 25 minutes to
Just
complete.
a check.
So we'll just see the internal picture and then shift audio in a minute to Dr. Vishaka's OT.
Yeah.
And in the meantime, the third OT with Dr. Satish Dharap is ready to demonstrate fluorescent imaging in lap coolie. Satish, focus.
Yes. Yeah.
Beautiful. Now you've seen the momentum entering the hernia.
Yes. And we can see that there's a big falciform ligament which will have to be taken down, and lower down we do not see any defects.
Excellent. So
Presently,
with your
we are able
permission,
to
now
see.
we'll shift the
Please
audio
do.
to Dr. Vishaka in OT1 Pramod.
Please do.
But by the time you can start your dissection, you are visible on the screen.
We'll change to a 30-degree. Okay.
So we have a question from Dr. Ashok Dhonde from Sangli. What are the chances for Dr. Vishaka? So what are the chances of skin necrosis in the ventral patch hernia repair?
Now, if we can increase the brake and reduce the pressure from 15 to 13 should be okay.
Hi, Aditya, am I audible?
Due to pressure.
So what are the chances of skin necrosis since we are injecting diluted adrenaline at the umbilicus site? So what are the chances of skin necrosis?
Diluted adrenaline at the umbilical site.
Okay. So, and secondly, sir wants to know, since we are piercing the mesh with a suture passer, does it have any effect on the mesh itself? Does it make it weak?
हाई फ्लो किया तो रहेगा ना, क्योंकि स्मोकी ब्रैकियोटमी भी लगा है ना.
To take these transfacial sutures, we use a 20-gauge spinal needle. So it's like the regular transfacial that we do in an IPOM plus. So the suture passer is not coming through the mesh. The suture passer is coming through the wall at the side of the mesh to pick up the suture.
अभी तो बहुत कुछ करते हो ना.
Only the 20-gauge spinal needle.
What would you do?
What I have done now is taken two transfacial sutures. You can take it at any point, 3 or 6 or 9 and 12. I've taken one at 9, one at 9 and one at 3
This would
o'clock.
make sense. If it is more here, then in fact,
All right, so this is an additional safety mechanism that is being done so that there is no space left for any bowel or omentum to enter in between the wall and the mesh. This is not given in the company protocol of putting the mesh. This we do as a matter of precaution so that the mesh sits well against the wall. And then I'm just going to tie these sutures, and that is the end of the surgery. If there are any other questions, I would like to take them. I'll just show you how it looks from the anterior abdominal wall side. So this is how it looks, two transfacial sutures which I will tighten. This is the smiling umbilicus. I will take subcutaneous vicryl sutures and then subcuticular rapid vicryl 30 to close the skin. So no chances of skin necrosis, no adrenaline has been injected, and that is what the procedure is done. I'll just show you once more the mesh from inside, and then I'm ready to log out from OT1.
I think excellent job, Dr. Vishaka and Dr. Ajit. I just want you, the camera, to show the smiling small incision that's been taken. So how are you going to close this? Is this going to be interrupted clips or what? Excellent. So you're going to put a waterproof dressing and the patient can have a bath tomorrow morning. So great job, Vishaka and Ajit. Well done. So can I shift the audio now to OT2 with Dr. Satish Dharap speaking, please. Dinesh, OT2.
What is your practice? You always put it in the bag
Yeah. OT2, can you hear me?
We can hear you, Dinesh. Is our audio clear there?
Yes, sir. Yes, sir. We can hear you.
Audience is seeing the history of the patient put up. She's a known asthmatic and hypertensive and has got multiple gallstones. I'm going to hand over the mic to Professor Satish Dharap, who is the professor and head of Department of Surgery at the Topiwala National Medical College and Nayar Hospital in Mumbai. A close friend of mine. In fact, I've learned a lot of surgery from Satish when he was my registrar and I was a houseman. Satish is also contesting for editor of the Indian Journal of Surgery in the upcoming ASI election. So I'd encourage he's an excellent academician. I've seen him at close quarters, an excellent surgeon and a very good human being. So over to you, Dr. Satish Dharap.
Thank you, Roy, for very nice words used by you. And thank you for giving me this opportunity. So we have this lady who is put under general anesthesia by able anesthetists, Dr. Kale and Dr. Nair and their team. And I have Dr. Sanatan assisting me. I have entered through open method of entry by subumbilical incision. Now, when I entered inside, there were a lot of adhesions of this omentum with this area, so which I had to excise so that I could put this lateral port. Though gallbladder looks distended, I am still able to hold it well with the trocar. Okay, so there are some omental adhesions which we need to separate. Okay, so today lap cholecystectomy is a very, very common operation, but basically major concern is preventable injuries which can happen, and that is bile duct injury and vascular injury. So we have to see and learn how we can prevent. And now what is the popular term is culture of safety in cholecystectomy, right? So we will see what should be our approach to have a safe cholecystectomy. So I am trying to hold the gallbladder a little away from the omentum adhesions. Okay, and we will elevate it and retract it up. Now, if gallbladder is too much distended, you may have to aspirate it. Yes, Roy?
I'm just going to interrupt you for a minute. Sanatan, just take out your telescope and show us the anesthetist monitor for a minute. I think extremely important that saaf nahi hai. Along with when you say good anesthesia, I think if you look at the monitor, the patient's heart rate is 64, her EtCO2 is 32, and the blood pressure is 67. I have with me Professor Kale. Put the scope back in while your Satish continues. I think I'm going to ask Kale sir to talk to us about what is our protocol for ensuring a good feel for the anesthetist. Cameraman.
Hello. Good morning, everybody. To talk about anesthesia for laparoscopic surgery, as Dr. Roy just now showed you the monitor and what techniques we use. Generally, what we follow over here is general anesthesia for all the laparoscopic surgery. Okay, I am not very fond of regional anesthesia, though people are right now doing these laparoscopic surgeries under a regional anesthesia. There are many controversies whether to do it under regional anesthesia or not. But what I follow is general anesthesia. And the golden rule for general anesthesia is general anesthesia with muscle relaxants, with controlled ventilation and monitoring of EtCO2. We are very much worried about pneumoperitoneum created when general anesthesia is given. And when pneumoperitoneum is created, there is a lot of sympathetic stimulation which causes tachycardia and hypertension, which may bother the surgeon and which may disturb your field of surgery. So what techniques we follow is good analgesia, good muscle relaxation, very good position whenever different surgeries are done under laparoscopic surgery, stiff head low position or stiff head high position, lateral position, all those things, proper positioning of the patient. And then the principle is hyperventilation and maybe some pharmacologic agent you have to use keeping your EtCO2 to around 30s. Like right now, you can see on the monitor, the EtCO2 is between 30 and 35. So that is how you need to ventilate the patient. You need to maintain that EtCO2 between 30 and 35 by adjusting your ventilation. Generally, what we do is low tidal volume and high rate, so that you can maintain your this thing, because there is a lot of intra-abdominal pressure which doesn't allow you to ventilate the patient with large tidal volumes. So ventilate the patient with low tidal volumes and high rate and maintain your EtCO2. And what we follow here is we use generally alpha agonist, that is clonidine. I am very happy with clonidine, though many people use dexmedetomidine for this also. But for laparoscopic surgery, I personally very happy with clonidine, because clonidine doesn't cause that much bradycardia, which, and if at all bradycardia happens, which responds to atropine, many times with dexmedetomidine it doesn't. And the hypotension caused by clonidine or controlled hypotension caused by clonidine is within control. Sometimes with dexmedetomidine, there is not much hypotension to our expected hypotension, rather, to that particular level or optimum which we want. Sometimes it cannot give good fields. So I am not very happy with dexmedetomidine, but I am very happy with clonidine. Plus, with use of clonidine, your post-operative analgesia and intraoperative analgesia also required is much more. My requirement of the analgesic like fentanyl or post-operatively, it goes down literally. So that is very how I use clonidine is, when we start IV line, first pint I give clonidine with 2 micrograms per kg of body weight. By the time they prepare for surgery and create pneumoperitoneum, my pint of clonidine is gone to the patient. A volume also goes around 500 cc, as well as clonidine 2 micrograms per kg is.
Dinesh, please show us the laparoscopic picture. Don't stop that.
So that 2 micrograms per kg clonidine, by the time the pneumoperitoneum is created, already gone. So your pulse rate, heart rate, or your blood pressure is nicely settled at that time, and the pneumoperitoneum doesn't affect much the field of the surgery as well as your hemodynamics. So that is how we follow it during these surgeries. Yeah.
Thank you, Kale sir. Dr. Kale and Dr. Nair have been heading our anesthesia department right through, and that's one of the reasons why we can hold all these successful workshops with a rapid turnover of cases that we show. Thank you, Kale sir and Vikas Nair. Back to you, Satish Dara.
So we have a question for Kale sir from Dr. Mahesh Thakkar from Bhuj. What's your call on the TAP block?
Yeah, TAP block for all those surgeries like we do IPOM and all. Post-operatively, yes, we give for post-operative analgesia. All the patients are given the TAP block.
So, Mahesh bhai, it is routine in our hospital, particularly for IPOMs. LAPCOLs, I think we tend to discharge within 24 hours. What Kale sir has not told you is that induction, we put 1 tramadol and 1 diclofenac suppository as a routine. We do preemptive anesthesia by infiltrating all the port sites with sensor cane, and again give a dose of sensor cane at the end of surgery. So they hardly have any pain, not requiring TAP block. But IPOM plus, which we do quite a lot, is a painful operation. And with Dr. Kale's team giving ultrasound guided TAP blocks, they have hardly any pain and can be discharged within 24 hours. So IPOM is extremely important to use a TAP block, as the question says. Back to you, Satish.
Yeah. So as you can see, this patient had a lot of adhesions with the fundus and body of the gallbladder, which we have separated. Now you can see the hilum, which is reasonably okay. Now, one of the things is to do posterior dissection. Now we are quite away from the hilum, and distal 1/3 of the gallbladder should be dissected, and then you have to give strong lateral traction so that it opens out the hepatocystic angle. We also have facility for ICG, so which has been injected half an hour before the surgery. So you can see the bile part is all green, and you can see entire liver, gallbladder, and the biliary system. Yeah, this seems to be the cystic node or Hartmann's. Yeah, so you can see it is. Okay. Hook. Keep clean करा नंतर.
Dinesh, shift the audio to OT3, where the other screen you're watching Dr. Pramod Shinde doing the adhesiolisis for the IPOM. OT3, please. Dinesh.
Okay,
audio
sir.
in OT3.
Okay, sir.
Hello, Roy.
Yes, sir. We can hear you, sir. Continue,
So,
sir.
Can you show this defect? So we can see a previous mesh here. Okay. And this mesh appears to be, there is almost like an intraperitoneal mesh, although it has been covered with omentum and there is a thin layer. And this is a defect. Okay. But the second defect is here. Okay. And this is absolutely little more difficult to approach from the lateral side now, because it is going higher up. It is about 3 to 5 centimeters above this primary defect. Okay. So it's, and there's this falciform and the fat is herniating through it. So we'll have to take down all the falciform. Can we withdraw the camera? Okay. So we'll have to take down all this falciform along with this fat, so that we'll be able to completely evacuate this defect. Okay. The defect has got a partially kind of a sliding content of the falciform fat. So we'll have to take off all this fat from the anterior abdominal wall. And now we can see that our port positions will have to be modified according to what we see inside. Because now this defect is pretty high up. And to deal with this defect, we'll have to, the epigastric port is not going to help here. Epigastric ports generally help in the umbilical part, below down. But if we have a supraumbilical defect, which is not close to the umbilicus and goes right on to almost an M2 level, then we will have to approach it from lateral and below. Okay. So rather than using an epigastric port, we'll have to do a 10 mm here and then go from below. There is a scar here, and we can see that the rectus sheath is deficient here, but the muscle is absolutely intact and there is no defect there.
So how do you want to cover that, or would you like to cover that or not cover that with the mesh? What is your thinking?
As long as the muscle layer is intact and abdominal wall is intact, we may, actually the rule is whenever there is a scar, a single scar, we would cover all the scar with a mesh. Now this is a separate scar which has not shown any defect, and just as, because here already the rectus sheath also would end at this level. This is the arcuate level. So if it is not covered with sheath, I would not really worry about this defect.
I'm going to be provocative. You have a 10 centimeter midline scar, and the upper part of the scar shows a 2 centimeter hernia. Are you going to cover the lower 8 centimeters with the mesh? Sorry, I'm being
tell me again.
So a 10 centimeter midline scar, upper 2 centimeters show hernia, lower 8 centimeters on laparoscopy doesn't show hernia. Would you still cover the lower 8 centimeters and go beyond that?
If it is a single scar, I would. If it is separate scar, I would not.
So some matter of controversy on this.
Yes.
I would beg to differ with my senior colleague. I would go 5 centimeters beyond, or look for any deficiencies, a scar or divarication or early hernia.
Yeah.
Definitely. But this, for example, I would not cover. But I would leave it to
because this is an absolutely well-healed scar, absolutely nicely seen muscles. There is nothing in the midline. So although there is a scar seen from outside, it has stood the test of the time also. It's a very old scar, and she has
Standing
not
behind
developed
Pramod
anything.
is Professorial Dr. Rajan Modi looking over his spectacles. Rajan, what is your comment on this?
And helping us also with his friendly comments.
Dr. Pramod will have to open this hernia now, the supraumbilical hernia, see how much is the defect, because to handle a very large mesh will be very difficult, Pramod.
True.
20 by 30 mesh if you handle here.
True.
Because the defect is very huge here.
True.
And as Roy said, I would agree that if the scar has stood the test of time, as you said,
True.
and there is no defect, then I would not try and cover that whole scar.
True. True. Yes. Yeah. Okay. Okay. So this will change, or we'll put an additional port here. We'll need a contralateral port to work on this. Okay. Which in any case for these mesh packing, we are going to need a contralateral port. Okay. So we will have to change our strategy to address an slightly more towards epigastrium defect, although the patient is not short statured. So it is still a supraumbilical hernia, not an actually epigastric hernia. It is just at the boundary of M2 and M3. So we know that 3 centimeters above and below is the umbilical area. This is about 4 centimeters up, 4 to 5 centimeters above. So this will be an M2, M3 kind of a hernia. If it was M1,
falciform down.
yeah, we will have to take the falciform down. So, and falciform taking it down will start laterally right from here and then go up. So this will automatically take up this instance.
Aditya, any questions for the surgeons? Please feel free to ask them. For the information of the audience, Dr. Aditya Oak and Dr. Abha Gune are monitoring the Mumbai center. Abha Gune is a senior surgeon. She'll demonstrate a case this afternoon. And Aditya Oak is an assistant professor of surgery at D.Y. Patil Medical College in Navi Mumbai.
Okay.
So we have a question for
this 5 mm proper to a 10 mm.
We are going to
proper.
change this to 10
Yeah, so that your camera will come in the midline
Center,
and you will
correct.
find it more easy to
Absolutely.
handle.
Absolutely. We have already taken a 10 mm port and we are going to change this to 10 mm.
Yeah, question please.
So
Hello.
now we'll put in a contralateral port here. Okay. So which will help us go it like this.
Aditya,
So,
is there any question for Pramod sir?
So yes, we have a question from Dr. Sachin Jama, sir. Now that there are these 2 defects that are there, is it better to do a ETEP RS instead of doing a IPOM plus in this case?
ETEP RS will be definitely a better procedure suited for this. Knife, please. ETEP RS would have helped this process better, because then all our ports would be within the linea 7 RS and closure and suturing would have been much better. I would agree with that.
Okay. So rather than using the port to a 10 mm one, can we
can use a 5 mm
5
telescope
mm
also.
30, so that gives you a little more flexibility to
That
change
is
between
the next option. If we have a good 5 mm 30, then definitely that's a good option, because we are going to need camera from different forces also. So we would like this port to be perpendicular and not torque it more. So the first, and we can use a little counter pressure also. Yes, yes. No
Can we, Dinesh, can we shift audio to OT2, Dr. Satish Dhara, OT2?
Okay. So,
Okay, sir. OT2, can you hear us?
So I do not know. There are 3 structures. Now this looks like a lymph node. This is probably the cystic artery and this is probably the cystic duct. Now can ICG help me to find out what is what? Okay, so you can see this is the cystic duct which has become stained. Cystic artery is not stained and even the lymph node is not stained. Right? So I would be safe putting the clip here. I may probably remove more fat from here so that it is bare. And generally, if your duct is too large, you know, if you have to put yellow clip, then probably you have to think twice before you now that the fat is away, I think you can see it nicely, the cystic duct. Huh? So now I lift up the fat over the CBD.
Go close, go close, go close. Go.
Yeah, you can see the CBD which is
Gain come here. Gain. You can see the junction.
Yeah, this is the CBD which is getting stained. Yeah, now I lift up the fat, you can see. This is the cystic duct, this is the gallbladder, this is the cystic artery which is lying on the lymph node there.
Excellent, Satish. Tell us about this critical view of safety, Satish.
Yes, so when you complete the dissection, when you retract the infundibulum laterally, you see the liver bed and the cystic duct. And there should be only two structures leading to a gallbladder, that is cystic artery and cystic duct. So that is considered as a safe view. But as you can see here the cystic artery is below the lymph node, and you can see this lymph node is also coming in the way. So in all such cases, there are different options. You can do intraoperative cholangiogram, which is obviously time consuming. You can have intraoperative ultrasound, which is again an expensive gadget to have. But if you have some advanced laparoscope which can permit ICG, then that can be really of help.
I think, to be honest, Satish, since we have ICG and fluorescent imaging, last 10 years, I have not done a single intraop cholangiogram. What is your experience in Nair Hospital and previously in Sion, where you were professor?
No, we don't have this luxury of
Have you done intraop cholangiograms? How many have you done in the last 10 years?
Less than half a dozen. It is very difficult because it's a time-consuming procedure. So unless you are really in doubt, you don't use it.
So I think, to me, now I'm being radical here. I think intraop cholangiogram is dead. Unless you have a bile duct injury. Any other ways for CBD stones or for identifying, to me, with fluorescent imaging coming in, and gradually I think this will become standard of care. I don't really see any role of intraop cholangiograms for safety. Unless you have a CBD injury which you're not sure of anatomy. Would you always take out all this fat? Is it always required? I think I do it as well, like you're doing, but I think we need
and here basically I am in doubt because this structure looks quite thick, but there is a cystic artery which has been dissected. So I would like that lymph node to go away.
So the lymph node belongs to the patient. That's what the people say. So if you're lateral to the node, you're usually good.
We have a question from Dr. Jitendra Singh Chauhan and Dr. Pratik Vishwas, one from Ambala and Mumbai. What is the dose or the dilution that ICG is injected in, and what is the time that it is given at?
Can I take that?
Yeah, sure.
So I think 2 milligrams of ICG. You have to remember that ICG is indocyanine green is an iodophore. It's an iodine containing drug. So it is our practice to routinely give a test dose to the patient an hour prior. We in fact delayed giving ICG today. If you had given ICG half an hour prior to induction, the green of the liver is not seen, and you only see the bile duct and the cystic duct. In a workshop setting, this can sometimes be a challenge, but in our routine practice, we will give ICG 2 milligrams intravenously after test dose, half an hour prior to induction. And the advantage of that is it gets completely cleared out by the liver. Now, the use of ICG for different organs is different. Like you will see a rectum being done tomorrow, and we will use ICG in that. There you will use ICG to see the vascularity of the anastomosis of both sides, and we'll inject it intraoperatively to actually check the vascularity of two ends of the bowel. If you're doing a liver resection, we inject for a hepatoma, we'll inject ICG 7 days prior to surgery, and because it's selectively picked up by the hepatoma. So the time of giving it, we are actually doing a study where for CS stomach, we endoscopically inject submucosal ICG 24 hours prior to see the central nodes and the lymphatic distribution. But for gallbladder, clearly it is 2 milligrams ICG to be given 45 minutes before induction. So in about 90 minutes, the liver clears the ICG completely, and you will see only the bile duct and cystic duct being stained.
Yeah. So another safety parameter is Rubius sulcus, and then the fourth lobe and the segment 4 and the fissure. So your dissection and clipping has to be on the right side of that. So as you can see now, this critical view of safety is achieved with the lymph node being dissected down. you have the cystic artery and the cystic duct. So I'll soon be clipping it.
Beautiful dissection, Satish. You can see what I tell my fellows is an elephant's head. Elephant with the trunk and a single tusk and nothing in between. Can we just check ICG once again after you finish this? Cut. See, now you can see the junction of CBD. This is particularly helpful for young surgeons. Pass me, Sanatan, pass me. Yeah. Beautiful. You'll see the CBD very, very clearly. If you had waited for another 20 minutes, the liver green will come down and you will see it even better. Back to Janan.
Yeah.
Satish, there are some surgeons who believe that we should tie the cystic duct. I personally clip it routinely, but what is your take? And
no, if it is dilated, then I tie it. But again, the first thing is you make sure that it is you are not actually injuring the CBD, because any dilated structures should be CBD. But yes, in some cases you do get dilated cystic duct. Only in such cases I like it, otherwise I clip.
Particularly in patients with gallstone pancreatitis, CBD stones, where you have wide cystic duct.
Yeah.
And the second, rule we need to tell the youngsters is never do sequential clipping. If your clip doesn't go across cystic duct, as Dr. Bharat mentioned, first check that it is cystic duct. If you're sure it is cystic duct, make sure the clip is well across, otherwise transfix or tie. Would you agree with that, Dr. Bharat?
Yes. Yeah. So here there is another thing going to the cystic duct. So we should have nicely narrow cystic duct to.
With me here is Dr. Abhay Upasni, who is a close friend and a colleague of mine from KEM Hospital. Abhay does all our manometries and 24-hour PHs. He is one of the reasons why we have been so successful in our anti-reflux surgery program.
You are very polite, Roy. You are very polite.
Okay. So I'm ready to clip now.
You think it's worth squeezing the cystic duct before you put a clip in case there is some?
Yeah. So I'm squeezing it because it's a bit dilated here.
Yeah.
Okay, so I'll be clipping it here. Okay. No.
Beautiful anatomy demonstrated by Dr. Bharat, very patiently and nicely done.
Thank you.
And the message for the postgraduates watching this is, do not look at the clock when you're doing dissection. You have one CBD injury in your life and you'll remember the patient's face all your life. Left.
Particular ICG? Yeah.
Sir, we have Dr. Rajendra Ganeriwal in our presence today here.
Yeah.
Welcome, Dr. Ganeriwal. Dr. Ganeriwal is a senior surgeon from Amravati, also president of the Maharashtra chapter of the Association of Surgeons of India. Welcome, Dr. Ganeriwal. Thank you for coming today.
And sir also gives compliments to the dissection.
Thank you, Dr.
Sir, na mic dena dara, Aditya.
Yes, sir.
Satish, how do you differentiate between LT300 and LT400 for a cystic duct, which is on the little wider side?
Good morning, sir. This is Dr. Ganeriwal.
Yeah.
Hello. Hello, Roy, sir. Good morning, sir. Dr. Ganeriwal here.
Thank you, sir. Thank you for being there.
It was my pleasure, sir, to be here.
Yeah.
Thank you so much, sir. Thank you so much. So the dissection is excellent.
Would you consider using a LT400, Satish, because your clips don't really come close another? The clips don't overly overlap. Would you consider LT400 in this, or you're happy with this?
It's okay, but I think your suggestion is well taken. I'll take one LT400. Yeah.
I'm scared of suggesting, Satish. You're my ex-boss.
That was long ago. You are now teacher of teachers. So. Bharat, ICG.
So this is something you can do. You can keep checking with ICG to make sure.
So this is the CBD which is quite away. So I can safely
not to leave a very big cystic duct stump. because we see increasing patients who come with cystic duct stones. So Satish has gone beautifully close to CBD, yet is very, very safe.
अजून एक आपलं 300 द्या. So I think this should suffice. Yeah.
Divide कर model shift कर.
Yeah.
Division झाला ना. Captain आरती की मैं audio promotion में.
Yeah.
So we have a question from Dr. Guladurti Sudarshan from Warangal. Is it necessary to skeletonize the cystic duct and the cystic artery every time?
See, usually there is, it depends how much fat is there. Now in this patient, unless I had removed fat, it would not have been possible to clearly delineate and put clips. If there is not much fat, probably you can, you need not do this much dissection. But yes, it is recommended that you have good clearance of fat from that area.
I think Satish answered this very politely. The same question was asked to Michael Eady, who is now in Australia. And somebody, I remember in a GEM conference in Coimbatore, asked him, can you clip the cystic artery and cystic duct together? So Michael Eady, in his own inimitable style, just waited for a second and said, I would only do it if you're a veterinarian, not a human being. So the answer is you can get hematobilia by doing this. So as far as possible, separate the two well, skeletonize them well, and then do it as. But Satish, in his own style, is very polite in answering that question. Thank you, Satish. I'm now going to ask Dinesh to switch the audio to OT3. Dinesh, OT3, Dr. Pramod Chinde. Dinesh, by OT3.
Yes, sir. We are shifting to OT3. OT3, can you hear us?
We have started taking down the falciform ligament. The field is little bloody, so I have requested Dr. Dhruv and to have a blood pressure was slightly on the lower side. So now this is the falciform and we have gone all the way like this. Can you see? Now the challenge here is to be in the pre-peritoneal plane and not break the rectus sheath and go into the retrorectus plane, because that is not our intention. Okay, that would make it like a TAM-like procedure if you do it. So we have first taken it down from here, okay, and this is easily dissectable now. Now from the left side and from the right side also we have taken this cut here and we have gone like this. Now what is limiting us is this is the hernia defect, okay, and we are using a 5 mm telescope now. So you can see this fat going inside the hernia defect, okay. So along with the falciform, all this fat is going to come out. Okay, so I'm going to reduce it now.
So with this 5 mm, the vision is very good, Dr. Pramod.
Yes, Dr. Rajan, in fact, he was keen that we use a 5 mm, so we have the flexibility rather than converting one port to 10 mm.
To 10 mm.
So, and Anil had already kept a 5 mm ready on the trolley. So that also shows that the team is pretty well trained. Okay, we didn't have to go hunting for the 5 mm. It was already kept ready on the trolley. So all that was done was change it. Okay. Current is on. Okay. So I'm going to use a tiny bit of current here. Now Roy has fantastic set of equipment. So we are using a Valley-Lab cautery, so we can use a cutting current and a coagulating current, so wherever it is indicated. So for tiny bits like this, we use a cutting current. If there's little vascular adhesions, then we would use a coagulating current. So yes, and a large amount of fat is likely to come out here. And we might discover one more defect also, is what I have of.
Yeah, there is a defect. And these are all pre-peritoneal fat which are.
So in an epigastric hernia, sometimes apart from the fat of the abdomen, there is a pre-peritoneal fat which herniates into the subcutaneous plane, which needs to be taken out. Now we can see a little change in color of the fat also.
The important rule for the youngsters watching this is never leave any fat on the anterabdominal wall It will prevent your mesh from adhering as well as hide defects below that. Would you agree, Dr. Pramod?
Absolutely, absolutely. So the abdominal wall should have a good bed for the mesh, because the tackers, if we use, their penetration will be only 5 mm, and the fat itself might take off all of that, and it will not really anchor it. Okay. थोड़ा दूर रहेंगे.
Increase the size of the defect by making it little bigger so that it comes out easily.
We can.
Yeah, it has come out.
Yeah.
Beautiful.
Okay. So now you can see a very clean cavity. Okay. And you can see a shining area there. Okay. Once we do our dissection, we will also go inside the cavity and check for any residual fat. Okay. So now this dissection, since we have done, this will become easier for us to go.
So when do you do an intraperitoneal suturing and when you do an extracorporeal suturing? What are your thoughts about that?
If we have only 2 ports, then sometimes sitting on the knot can be a little difficult. So for a defect, we would put in a needle from outside, do an intraperitoneal suturing, and again pull the tag outside. Okay. But for very long defects, sometimes, especially with the barbed sutures coming in, then intracorporeal is better. So for 2 or 3 centimeters, if we want to take just 2 or 3 sutures, okay, that is one. Secondly, if it is a recurrent hernia with previous mesh where the defect is a little more stiff and you need more strength to close it, to get it together, then pulling a suture from outside and tying it outside the abdominal wall becomes better. Okay. So in fact, this is kind of a tap plane where we could, for epigastric hernias, we could very well do a pre-peritoneal repair rather than IPOM plus. These are very, very tiny vessels, but still they are bleeding.
Do you use absorbable tackers or non-absorbable tackers? What is your thought?
Nowadays, I would prefer absorbable tackers. Okay.
The purchase
What
of
is your
non-absorbable
preference?
tacker is better in tissues.
That is true.
But most of the people, very few people are now using non-absorbable tacker in an IPOM plus. Most of them have switched over to absorbable tackers. Am I right,
Yes,
Dr. Pramod?
absolutely, absolutely. Basically, for the fear of having chronic pain, although there is no data as such to show that pain is less with non-absorbable tackers, clear cut, it is not an evidence-based guidelines that you have to use non-absorbable tackers. So, but definitely it makes sense that we have seen it in the inguinal space especially. And tackers have their own problems and complications like intestinal adhesions. Tackers can be a cause of intestinal fistulas also, though rare. So since absorbables are available, it makes sense. So what we are going to do is we'll have to check now how far we have gone. If we have gone beyond 5 to 7 centimeters, then we can stop. Okay. So for that, we will use a spinal needle. Can you give me a suction and a spinal needle so both works can be done, cleaning the field as well as a spinal needle?
In absorbable tackers also, you have the choice of using a fish hook type or the one which can be it goes through a screwing movement inside. So which one is your preference? Which one do you use for this?
The fish hook types, there is only one tacker which has got length which is more than 5.
Yes.
Okay. So in a thin patient, a simple any tacker should work.
Right.
But in a thick muscular male patient where you have got enough, the skin is not a very thin patient, then that 7 millimeters fish hook type would make sense.
Do you think any change in the pain also in postoperative period depending on the type of tackers you use in observable between the fish hook and the other one?
I have seen patients have a little more pain with the fish hook types actually. But that is an observation, it's not data. Okay, so that's the defect. We'll have to go a little more. Okay. Give me hook. इससे ना क्लियर नहीं कर पा रहे हैं, है ना? So this is home surgical soap. Are we using the smoke evacuator? This one.
What is the cause of this defect, supraumbilical defect, according to you, sir?
Now this is actually, it looks like a primary hernia because it is way beyond the actual umbilicus and surgery. So this is not really a secondary hernia. खाली बावल नहीं है ना, नीचे बावल नहीं है ना. There's one more defect also, ना. Okay, spinal needle. So that's the defect.
Yes.
That's 2.5 centimeters. That's 2.5 centimeters. Okay. Spinal needle. Can we put in one scale B inside also? इसको पकड़ सकते हो? इसको पकड़ सकते हो? Okay. So one. Okay. Scale ही बाहरची की आतली है.
So, Dr. Pranav, so from the
If
outside.
you touched it to the skin, we'll better take something outside.
So, Dr. Pramod has put 2 spinal needles and seeing how much is the size of the defect. It's approximately around 6.
This distance from the distance, this is
Between the
upper edge.
spinal
Yeah,
needles.
yeah. 5 centimeters above the defect edge. Okay. Now, can you put the scope inside? What do we have one more spinal needle? Okay. इसको ही डाल देते हैं. Okay. Yeah.
Regular needles are.
हाँ. इधर. So as Dr. Rajan was suggesting, we'll check the defect also, defect size also. इधर का डिफेक्ट है ना, ऊपर का किधर गया, ऊपर का. centimeters. Vertically, it is 3 centimeters. This was what was actually shown on the CT scan. Okay. So now the abhi lower defect will, which is simple needle है ना, ठीक है, this will go, yeah. नीचे वाला defect किधर है? So this is the upper defect. Okay. This is a small defect. Okay, we can see the mesh, and we'll go to the lower border of the umbilicus, which we will. This is the umbilicus. So that needle, can you give me that needle? Okay. So the upper defect, the smaller defect, and the umbilicus. Scale from outside. So 12 from outside, so it should be 10 or 11 from inside. Okay. So can you give me a marker pen? We will also have to mark what is the center, na? So that's 5.
Above and 5 below now. Dr. Pramod is marking. And then we will take the center of this whole.
That's 15. It's 20. Okay. So
10 centimeters.
That's actually the center. Okay.
How many stitches you take on the mesh, Dr. Pramod?
For a small mesh, we just take 2 stitches, 15 by 15 at 6 o'clock and 12 o'clock position. For a larger mesh, we might need to have at least 4.
At least 4.
So that it will help us lifting us up. Okay. So, and fifth suture is for the center. A 15 by 15 can be put without centering, but if we are, this will definitely need a 15 by 20 centimeters. So we will be putting a
central
stitch. Okay. So from the outside, okay. So this is a 5 centimeter overlap. There's the center. Okay. And again below the umbilicus. Okay. Okay. So that's the center. Okay. Sure. We'll close the defect. So now maybe since we have a length available to close, okay, we could use a barbed suture also, because we can not only close the defect, but there is a slight separation. Wheel-lock. So we'll do that. So we can start from a little above, okay, and continue the suture line right till below.
Like a slight
Divarication also, because this is a thinned out fascia as seen in the CT scan also. So let's use a barbed suture Wheelock 180. Either Wheelock 180 or Wheelock PBT 0. 3.5 metric 0 0 0. It's a 10 180. Fair enough. What is the needle size? Okay. Chalo.
What is the size of the needle for Wheelock?
This is a 37 mm.
37 mm.
Yeah. 40 is sometimes better, but 37 is
okay.
Sir, we have Dr. Randeep Wadhwan from New Delhi amongst us today.
Now we have an OptiView. We can put the needle through that OptiView, but If we want to save the port, then we should not.
Hello,
Sometimes
sir,
maybe
can you hear
some
us?
Yes, yes.
Yes. Continue, sir.
Padwan from New Delhi is amongst us today.
So we welcome Dr. Vadwan. Welcome to Zen Hospital.
Give my.
Thank you very much.
The pressure is going down.
मेरे को एक forceps लगेगा ना इधर से.
We don't need this.
We don't need this now. We already have our markings. Yeah. Okay, because of the torque, the pressure was going down. Okay. इधर से मेरी लाइन चलेगा. हाँ. ये ज्यादा कंफर्टेबल रहेगा, यहाँ से रीच होता है कि नहीं.
So you want the monitor shifted?
Actually, it should have been here, but now.
Sir, any particular tip for taking this suture which you are going to take now? Because suturing sometimes at the roof of the abdomen, it becomes very difficult for the beginners.
True.
Any particular thing you want to suggest? Whatever, because sometimes we have to shift the ports, like you have put one on the other side, and we are making changes as far as this telescope is going inside. So what is the most convenient way for doing a suturing? Because for you, it is very easy to do it in any direction.
Yeah.
But for people who have started doing it now, any particular tips you would suggest
See,
in such
for
cases?
suturing, triangulation helps you.
Right.
Okay. So whenever we see a defect and which is going to need suturing, we should have a triangular configuration. So that will make it easy for us to suturing. Ipsilateral suturing is more difficult and it requires more practice. So that's why now you can see that I have one port on the right, one port on the left, and we are using a triangulation. Now at this point, if I find that the suturing from here is going to be difficult,
right.
Another thing that can be done is you could put a midline port from here. So that will make life easy.
It is more easy.
Yeah. Okay. So.
So we have a question from Dr. Nitin Joshi from Ambernath. If there are two defects that are widely spaced and we do not have the mesh of the adequate size available with us, can we put two different meshes instead of one?
We could use a polypropylene mesh in an extraperitoneal space. Sometimes we do that for lower abdominal hernias, where the entire bladder flap and cave of Retzius gives us a large space where a polypropylene mesh can be placed. And then dual mesh, you can overlap that, the upper border of the mesh, and come up. So part of the mesh, the extraperitoneal part, becomes covered by a polypropylene mesh. That is acceptable. Okay. So now this is the first defect. We can see that there is some divarication here. Okay. So we could very well start slightly up. Now, if you look at here, these are the two recti from here till here. Okay. So we could start slightly higher up and then, okay. Now the suturing on the roof also requires a little bit of practice. So, and if you have a coaxial handle, it rotates in your hands. Okay. So I'll first see camera clean hai kya? Okay. So if you can get the camera clean. Okay. Okay. कर दो
एक बार वाइट बैलेंस को कर लेना लिटिल रेड
वाइट बैलेंस
एक बार वाइट बैलेंस
needle नीचे है थोड़ा सा। Swing the needle.
So we have a question from Dr. Abhilash from Hyderabad. How do we measure the?
First, let us check there is no locking. Okay. So are we clean? Yeah, we are clean. Okay. So
yeah, go ahead. Ask the question.
Yeah. So how do we measure the defect? Is it to be measured intraperitoneally or on the skin?
Correct.
And if it is measured on the skin, then is there any impact of the panaliculus that is formed in obese patients?
Beg your pardon. Can you again repeat the question?
How do we measure the defect? Is it intraperitoneally or on the skin? And if we measure it from the skin, then is there any impact of the panaliculus that is formed in obese patients when measured on the skin?
See, the measurement from outside are not very accurate. So if we have a large defect where measuring is important, we put the spinal needles from outside, but we put in a scale from inside and we measure it from inside. The intracorporeal distance from peritoneal side is more accurate. Okay, and that too, we also have to take into account that this measurement is happening in a distended abdomen. But since we would not mind a bigger overlap rather than smaller. Okay, when the measurement needs to be accurate, we have to take down the pressure to 8. We have to put spinal needles and we have to actually measure it inside. Can you show me the defect? Okay, we have to actually measure it inside. But here the defect is not very large. So even measuring from outside will give us 1 centimeter to 1.5 centimeter larger overlap, not lesser. So if it is erring towards the larger side, then it's okay. If that measurement from outside is going to lead to a smaller overlap, then that is not right. So in that case where the overlap is critical, then we have to measure it from inside only. Okay. See now, is the camera clean? Okay. So now this is a barbed suture which will lock itself. Okay. All that we need to do is look at the suture, see that it is straight, and this needle the ergonomics would be slightly better for an E-tap. Okay. I might need another needle holder on this side. Okay. So first, holding the needle is important. Once we have held it right side, then this rotational movements will do all the trick. That is one. Secondly, we have to have an assistant standing on my side. So Anil, you will have to come here and hold this because this will slide down. If you can give me another needle holder, that will be even better. Okay. So, okay. So what we are going to do is now, the other trick that we use, yes.
Can we shift to OT1 for a bit? So starting a bilateral TAPP.
Absolutely no problem.
Dinesh, can we shift to audio and video to OT1, please? And Shinde
Yes.
team will be running in PIP on the other side.
Yes, ma'am. OT1 we can see.
Okay.
OT1, can you hear us?
Loud and clear, Dinesh. Can you hear me? Okay.
Done, sir.
So
Thank you,
what we
sir.
do is we press from outside.
Can you hear me, Dinesh?
Yes, sir. I can hear you, sir.
Okay.
So we are, is our picture also visible to audience?
Yes, sir. We can see the 67 years.
Yeah, sure.
We can see the PPT, sir.
Perfect.
और
So you can stop the PPT and come to the laparoscopic image and then you start.
We'll have to change the
Okay, sir.
So I just want to take the audience through the anatomy, particularly for the youngsters in the audience. This is the defect on the right hand side. You can see the vas turning medially here. This is the common iliac vessels and the cord structures here. The so-called triangle of doom. You can see the pulsations of the common iliac vein. The left side is a very small hernia, but ultrasound wise it's picked up a hernia. Patient is keen to have it done. This is the medial umbilical ligament and this is the median umbilical ligament. Is that clear? Harit, you have good vision? I have assisting
Yes,
me
sir.
Dr. Ankur Patel, who has had the misfortune of working with me in the past. And I take, just to take, Ankur show them ports. So these are my ports that I have placed. I have placed the umbilical port above the umbilicus section, the midline port, and this is the reason for doing this is that we tend to suture the peritoneum. If the viewing port is at the umbilicus, then suturing can be a problem. Two working ports on both sides, 5 millimeter, and this is Dr. Ankur Patel who is assisting me with Dr. Asta in the background giving anesthesia. I'm working with a Striker 1688 camera. We have absolutely superb picture. We will show you ICG in various cases and followed by imaging on fluorescence surgery this evening. So my cut is slightly above now, and I am aware that a lot of postgraduates have joined us. So normally you will make an incision here, but when I teach my fellows and postgraduates, I tend to ask them to make a cut slightly higher up. And the reason is if you make a mistake in that, then you have a chance to change your port and come into a lower plane as is required.
So first, Roy, you need to use a 30-degree scope or a 0-degree scope for TAPP.
So only 10 mm 30-degree scope. So I'm in the wrong plane, Rajan. Can you see what? I have a bare rectus. So I'm in a TP plane. I can actually go down this plane also. Nothing happens. The second thing is don't allow any of this oozing to occur. Very important that you stop the bleed right away because it will smudge your field and spoil it. So I now need to get the posterior sheath up. Can you see this? I've entered a very thin patient. So I've actually entered the posterior plane. So let me see if I can make a cut and change the plane. So I'm actually entering the posterior sheath and lifting that. So this is the advantage of actually going into a slightly higher plane than normal. So it gives you the ability as you go down towards the arcuate line to change your plane. So I'm lifting the posterior sheath up till I have only peritoneum now. You can actually continue down the plane also. Nothing happens. You will be in a TP plane, but I am in a workshop situation. Please, as a
there are many people who take first port through the umbilicus in a TAPP, but to work at a higher position,
correct,
it is much better and more ergonomically comfortable to take suturing.
Thank you, Rajan. Dr. Rajan Modi is a very well-known surgeon in Mumbai. He's part of our team. He, along with Dr. Vishakha, do most of our abdominal wall reconstruction. I think between two of them, they have now done more than 100 TAR procedures and do a lot of ETEPs and complex abdominal wall hernias in Zen.
So very well, 2 layers of fascia, Roy's we are able to appreciate, and this is the right plane according to you when you do a TAPP.
Please hold on. You're absolutely right. I think I keep telling my fellows it's teasing the tissue apart. If you're needing to use a cautery and using a lot of scissor, lot of hook, I never use a harmonic for this. Just a simple scissor and a grasper. You can see the hernia sac going in there. I'm not particularly fussed whether we go for the midline or lateral. I'll just keep on dissecting as long as the loose areolar tissue is the surgeon's friend.
So in TEP, you need to mark out the anatomical details. While in TAPP, you can start either medially or laterally, whenever one is comfortable.
Absolutely correct, Rajan. I think I always compare TAP, TEP versus different between and cable on top. Different between a business class and a economy class. Here I have a lot of space to work. I'm going to ask Ankur to come out now. Just come out and see. If you haven't doubt, I can just go outside, just see the hernia, see where the peritoneum goes in, and then come in again. Just clean your lens. So this is the advantage of TAP, and I must admit, though we do both E-TAP, TAP and TAP here, I am heavily biased towards TAPP. All the available literature show that the morbidity and the results of both are exactly the same. I just think this is a much easier operation to do for everyone. It has definitely a lower seroma rate, at least in our hands. And I would say 70% of operations here are done TAPP. I think Rajan and Vishakha are keen on TAPs, and I am a TAP fan.
The advantage of doing TAPP is that you are able to show all the anatomical landmarks.
So Rajan, I think I show you also anatomical landmarks doing TAPP also.
No, TAPP. I'm talking about TAPP.
Yes.
The anatomical landmarks are there seen. While here in TEP, you need to start showing all the spaces.
Correct.
The advantage of TAPP is that once you are in the intraperitoneal cavity, you learn these planes very nicely. And if you can see, Roy is showing that with minimal dissection and you being in the right plane, it looks very easy. It looks very easy. Believe me, it's difficult when you start doing it.
I think it is a much shorter learning curve, Rajan, having said this, compared to
I fully
TAP.
agree with you. TAPP has a very short learning curve.
You can see the midline, the so-called lighthouse is called. I always tend to dissect a bit beyond the midline. This is the pubic symphysis. I'm now exposing the iliopubic tract, and then I'll do my dissection laterally. Now, this is the only place when I'm opening the Bogros space, I will make a sharp cut, because I find that it's easier to enter this space if you make a sharp cut here. Once you're into the Bogros space, then you can again go back to your. So there are different kinds of surgeons. There are the cutters, there are the teasers, and there are the burners. I am unabashedly a teaser. I like to tease in life also and in surgery also. So I'm teasing the tissue apart. I always feel that this is an embryological plane. Now, you see here, I'm beginning to see some rectus muscle. I don't like that. So I go into a slightly lower plane to leave a little bit of this loose areolar tissue on the rectus. So my plane was here. I changed to this plane. And the idea is that if I have the mesh placed on bare rectus, some patients do complain of dragging, dull pain almost for a month or two, and that's called meshalgia. And one of the reasons is there is a proline mesh directly on the rectus. So you see this, I'm leaving this loose areolar tissue on the rectus muscle.
These are lateral muscles.
Yeah, correct. Not rectus, sorry, I beg your pardon. Lateral abdominal wall muscles. You're absolutely right, Rajan. So I make a lot more plane, a lot more space, and a lot more dissection than many people. I actually feel the success of this operation is dissection. You see the psoas? This is the psoas major and the nerves on it. Never open the fascia on the psoas. Just appreciate the nerves and the psoas. It's like your angry wife. You should know where she's in the background, but don't go too close to her when she's angry. That's enough. So make this space laterally more than is required. So the mesh will lie easily there. Now I'm going to do a little bit of dissection on the sac. You see the inferior epigastric here. So this is an indirect sac. You see the pseudo sac here. It's a direct hernia being medial to the inferior epigastric. So my right hand pulls down, my left hand holds it. You can see the pseudo sac there.
Nicely, the pseudo sac is seen, and it also is dissected with blunt dissection.
Like I said, I'm a teaser, Rajan.
Yes.
If only it doesn't yield to me, then I will cut. I always feel that if you're on a good plane, you should be able to push it away completely, and no cautery should be used at all unless there is oozing.
The important thing is that bleeding should be less. If in this plane it starts bleeding, then it makes your life a little difficult.
I agree.
Of course, with good camera 1688, it makes a little less difficult. But in lower cameras, I think, Roy, the bloody field makes your life more difficult.
Rajan, I must say that hernia is not a simple operation. Hernia is an advanced surgery. There's no doubt in my mind that it is not equivalent to a gallbladder or appendix. Nice, Prashant. Workshop मध्ये असं होतंय तुझं.
So two important things according to Roy is, one is your instrument should always be autoclaved.
So we have a question from.
To have a very good camera system.
So we have a question from Dr. Suneet from Nagpur. How far above the umbilicus is the camera port, and does it change with the patient abdominal anatomy?
So the camera port, Dr. Sunil, is about 3 centimeters above the umbilicus. I think we used to initially in the early we used to use it at the umbilicus, and then we found that if you're using tacker, that's okay. But I'm going to show you how you can. Prashant. If you're going to suture the peritoneum, then you need to have a little bit of distance above it, so the suturing is easy. And by putting your viewing port above the umbilicus, it doesn't really matter. You're just dissecting a few centimeters more. And like I said, like in my situation where I had a difficulty in, I made a mistake in the original plane, it's very easy to correct yourself.
You can see the vase there, keep on the right. So as a rule, we do not hold the vase. Now this patient is an elderly gentleman still. Holding the vase means possibly injuring the cilia lining the vase. So I'll leave some tissue on the vase and just make a plane between the vase and the cord. You see this, deliberately I'm leaving some tissue on the vase, but I'm a fan of making a window between the vase and the cord, because only then the vase gets fully mobilized. At no point you should hold your vase. It is simply unacceptable to hold a vase. Even an elderly person, you get into the habit of not holding the vase. Now the key issue here is, and this is where most laparoscopic hernias fail, is because of inadequate dissection here, the so-called medialization of the vase. So make sure that you are actually dissecting adequately here and you see the vase distinctly turning medially. So remember, all recurrences come in the Hesselbach triangle in the medial part, never near the psoas. The next thing is, there are these sling fibers. Can you appreciate this sling? The sling fibers are always seen, which hold the vase back, and these always tend to ooze a little bit. So always tend to give a little small buzz on this sling fibers to release the vase, and you can see the vase getting pushed away very easily now. So this is extremely important, and you must overdo this. You see this how, and anything that is in this area is going to prevent your mesh from. See, basic rule is the myopectial orifice of Frouchard must completely be covered by your mesh. It's extremely important that you do this well. Make sure the vase turns well. Overdo your dissection. I always tell my fellows that you have a recurrence in a inguinal hernia is disaster in practice. You have a recurrence in a hiatus hernia, that's okay, because not many people around you are going to do large volumes of that. But never in your simple surgeries, patients will always compare your results with that of open inguinal hernia. And there are many surgeons who will do open inguinal hernia under local anesthesia at lower cost than you. So it's very clear that your morbidity should be low and your recurrences must be low. There are no two things. You can see the edge of the peritoneum. You need to work on this. The peritoneum must go down completely. I always like to create a groove between the cord structures and the peritoneum. And the logic of that is the mesh will remain flat there. Just go on advancing your left hand down. Anything that is vertical must be taken away. There must be nothing between the mesh and the posterior wall. Like I said, many surgeons would stop at this level, but I would recommend to you that you do more dissection than is required so that your mesh is absolutely fat. Whether you fix it well, doesn't matter. It should never cause. This is how the peritoneum gets tethered to the posterior wall, and all this must be taken out. This is extremely important. Are there any questions apart from what you already asked me?
Sir, Dr. Khiljan from Kharghar wants to know the ideal port placements for the TAPP.
So, doctor, there is no ideal port placement. What works well for you is the ideal port placement. I am a tall and fat man with long arms, so doing this laterally is also easy. If I suppose there are many people who would say that umbilical port is as good. So basically, what works well in your hands is a good technique. I'm merely showing you what I do, and after some time, I'll ask Ankur to again show you the port position once again. But Ankur, in fact, put in the ports before I came, and
I would say by and large, there are only 3 ports which you need to do. The 2 lateral ports are at the level of the umbilicus, and 1 port, the midline port, you take one above the umbilicus, 3 centimeters away, as Roy has said. You can lateralize your 5 mm ports little away. So if you are a short man, your 5 mm port should be little nearer you. Otherwise, you have developed shoulder pain and all kind of things.
Rajan, what is your take on lipomas that you see? Lipomas and lymph nodes. This is a common question that often juniors ask me.
Lipomas of the cord are always to be taken down, while lymph nodes, you can leave them behind. Lymph nodes, you should not tackle them. That's my personal opinion, because otherwise then they start bleeding and you'll end up in a more mess. So I would say lipoma of the cord should always be removed. What do you say?
Completely agree with you, Rajan. Never take out lymph nodes, but always you don't need to remove lipoma in open surgery. But whether TAP or TAP, lipomas must be taken out. They are going to cause trouble post-op.
Because they give a pseudo recurrence also. The patient feels that there is impulse on cough. So one always needs to be aware and remove all the lipomas, especially in indirect hernias.
Quite right. I agree with you, Rajan.
So we have a question from Dr. Naresh from Surat. How do you deal with large indirect hernias, and how do you take care of the seroma?
So Naresh, point extremely well made. It's important to try and remove as much of the distal sac as you can. If it's an inguinoscrotal hernia, then what I do is I remove as much as I can, and the distal part of the sac that I leave behind, I actually slit it open at 12 o'clock position and cauterize the edge. And to be honest, we hardly see seromas after TAP. I'm biased, but whatever seromas I see are usually after TEP. In even large hernias after TAP, if you do it well, we also believe in strapping. Send her home in 24 hours, patients in 24 hours, but always strap the groin for 24 hours. So just to show you, another trick for large direct hernias like this one is to pull see, this is a big sac. If you leave this sac behind, you will invariably get a seroma. So what you'll see me doing in a minute is pulling in the sac after I finish my dissection and tacking it to the Coopers. So this is my midline. This is the area of the femoral and the obturator hernias. So I've removed enough to make sure there's no hernia there. You do see sometimes nodes in this area, but never take out the nodes. Never go hunting for the obturator area. Obturator now. This is the triangle of doom. Medially is the vas, laterally is the cord, below is the peritoneum. Do this adequately so that I'm now joined in OT by Dr. Pavanendra Lal, close friend of mine, who is the professor of surgery at Maulana Azad Medical College in Delhi, also executive director of National Board of Examinations. Welcome, Pavan. Thank you for coming from Delhi.
Thank you very much. Just is it working?
Yeah.
Okay, it's great. Thank you for this kind invitation, and as always, pleasure to be at your institution. And the whole workshop is turning out to be very interesting. Great. Many congratulations.
We just had a question asked to us, and I replied what I thought was appropriate. But the famous question, how do you prevent seromas after TAP and TEP? What is your take in Delhi?
Right. So basically, seroma forms because you create a potential space where none existed. And when you withdraw the sac and separate it out from the transversalis fascia, there is that potential space of dissection that has happened. So there are two methods that are now being used. One is where the transversalis fascia is tagged to the Coopers by drawing it inwards, like maybe you are doing it now.
Yeah.
So Roy is showing that. Even before I was telling.
I got a hint, Pawan.
And then the other one is, which we use in our center, is simply to put local pressure with a dyna, and that serves to do the same job. The whole idea is to obliterate this space, and
how many days you give the dressing?
So 24 to 48 hours is what we keep. We had preferred to have it unremoved for 48 hours. And once we do that, then our seroma rates are very, very low and quite acceptable to any other technique.
So we have a question from Dr. Apurva Srivastava from Indore. Is there any role of suturing this defect?
Now that Dr. Pavan Lal is here, he's going to answer questions. I'm going to quietly operate. Thank you, Pavan, for being here. But I don't personally close the defect. I know there are people who do this. I don't think it's required. I just simply tag this sac as you see me doing. Normally we suture this, but since I think Bard has been kind enough to give us tackers, I'm going to use a tacker on this. Pavan, do you suture defects?
Not at all. So there is no need to suture the direct defect or the indirect defect in inguinal hernia, because we are putting a very large mesh and it is going to nicely cover up the space And various studies where they have tried to do suturing also, they have not shown any benefits. For the myopectineal orifice, the clear message is that just have a nice overlap, good sized mesh, and cover all the potential defects, and do not try to suture. Also, it's a tricky area, and you may always sometimes land up into a situation where you enter a vessel or something like that. So it can become it's an unnecessary, kind of a.
So the second question, Pawan, that I want your opinion. I actually answered that. They asked me, what would you do for an inguinal scrotal hernia with a big direct sac? And I said, I remove as much as possible. Then I slit open the sac and burn the edge and leave it.
Yes. So there is no reason to struggle with the complete reduction of an indirect sac. In fact, in the younger people who have not yet completed their family, which is one question that we ask every person when we do, is not to, kind of fiddle about too much. And when you do this reduction of the sac, you definitely play about around the vas, around the spermatic vessels. And we don't want to do that. We want to stay clear, and therefore just leave the distal sac and make sure that the edges which are divided, they are not bleeding, they are not oozing, so that there is no hematoma, and that's about it. Very rarely you will have a residual, you may get a hydrocele, something like that, which may come in few years later. And that's a very small thing to have. It doesn't have anything to do with the hernia per se.
Now, he's ready to put the catheter? Yeah. Now, I'm going to request my colleague in the department, Dr. Abhay Upasni, to show you the concept of esophageal manometry in a patient who Dr. Lal will be doing a DAWS fundoplication. But I think it is absolutely crucial that every surgeon doing an anti-reflux surgery must understand. I'm also going to ask Dr. Lal to contribute to that discussion to make sure to understand choosing which operation is appropriate for which patient. So Dr. Upasni will first show you a esophageal manometry, and Dr. Lal will demonstrate a DAWS fundoplication. 10:30 बजे पलनी वेलू है. We are in time.
Hello.
Dinesh, can we switch over to OD2, please?
Yeah.
Will
I be able to hear the audience as well?
Dinesh, can you switch over to OD2?
I can't hear the audience.
Yes, sir. Yes, sir.
Thank you.
Am I audible now? I am Dr. Upasni. Am I audible there?
Yes, sir. Yes, sir.
Oh, great. So we'll just quickly see, there is a patient in front of me. He's a 30-year-old male patient complaining of regurgitation, retrosternal burning, and sour taste in the mouth. So his endoscopy showed a small hiatus hernia with a lax lower esophageal sphincter, no esophagitis, and the rest, everything was normal. So since his symptoms are there for a very long time, Dr. Roy thought of doing a fundoplication because this patient was a PPI responder, and as soon as he used to stop taking PPIs, his symptoms used to recur. So pre-operatively, we did his manometry, and I'm just doing it again to show you, what is the importance of manometry and how do we do it. It's a standard protocol here in Zen Hospital, that all patients who undergo fundoplication have to have a prior manometry done, and those patients who have non-GI symptoms or non-esophageal symptoms of reflux disease, we compulsorily do pH impedance test on them. So I'll come to that test later on. First, I'll just show you how we do the manometry. It's a very simple thing and a quick thing. I have already, focus the camera here. I have already inserted this manometric catheter. It has 16 openings, and each opening is connected to a pressure transducer here in this machine. Can you all see this? So these are 16 channels. This is a water perfused manometry system from Australia, Royal Melbourne Hospital. this is a processor here. It processes the pressure signals from this equipment, and these pressure signals are transmitted in a picturesque manner on this monitor. So this is how this machine works. This down here you can see a water perfused jar, rather pressure jar, air and water. So air is forced onto the water. The pressure is 15 pounds per square inch, and that pressure is forced through these channels, and water flows through all those 16 holes which I have mentioned earlier. So there is a pressure from within, and there will be a pressure from outside when we give patient to swallow water. So the resistance at the interface is depicted by these pressure transducers and is shown on the monitor. So 10 such wet swallows are given. Each swallow is 5 ml of room temperature water. So I will just quickly show you. Now if you look at the monitor here, this upper horizontal line is the upper esophageal sphincter. The lower horizontal line is the lower esophageal sphincter. And if you can appreciate, actually the sphincter is here, and down here during each inspiration, you can see diaphragmatic contractions. It's a very small hiatus hernia. That means what? That the sphincter is in the chest, little bit in the chest, and the diaphragm is little bit below. So this is how we can diagnose hiatus hernia on manometry. It is not always that we can find it, but okay, endoscopy says there is a hiatus hernia. Sometimes we can't find it here. It is, as I said, it is not a diagnostic test either for hiatus hernia or for GERD, but it is an important pre-operative investigation when you plan a fundoplication. First, I will show you how we do it, and then we'll go on to the discussion as to why is it important to do manometry before surgery. And I have with me Dr. Lal here from Maulana Azad Medical College. He is a great surgeon from Delhi. I'm right. But I'm meeting him for the first time. I'm a small person, and these big guys, they meet, not too often. Anyway, so I will just give the patient little water to swallow. Beta, tula pani गिळायचं आहे. कर. Spoon tap. Now look at the monitor here. There is a bridge in the upper esophageal sphincter. The pressure has dropped to 0. And this is how the swallow has progressed. So there is pre-swallow relaxation of the sphincter and post-swallow augmentation in the pressure of the lower esophageal sphincter, and eventually it relaxes. So this is how the manometry tells you. Now 10 such wet swallows are given. Now with the kind permission from Dr. Papilkar and Dr. Nair, who are heading this anesthesia of this patient, I am able to give water to the patient pre-operatively. Otherwise, people usually don't allow. But thanks to them. So can I give second swallow and show them again? Yes, please open the mouth. Now look at the screen, please. Patient has already swallowed there. There is a drop in the upper esophageal sphincter pressure. He has swallowed twice. It doesn't matter. But now he has not swallowed properly. But second time, usually there has to be a gap of 30 seconds between two swallows, because the lower two-thirds of the esophagus is a smooth muscle and it requires repolarization, so that is why the duration is important. Yeah, but this is not a correct thing. Aramat piya beta. Ha, aakar. Peon tak. In one go. The first, yeah. Now he has swallowed it perfectly. So this is a normal pressure wave here. This is a normal peristaltic wave. And so what do we find here? Every color has its own pressure. The lighter the color, the less is the pressure. This is esophageal pressure. This is upper sphincter. This is lower sphincter. And outside the esophagus is the lung pressure. And you can see whenever the patient is breathing, the lung pressure is dropping further down and the color is becoming dark blue. It has no significance in our manometry, but what is important is whether the upper sphincter is relaxing or not, how is the peristaltic wave pattern in the esophageal body, and what are the pressures at the lower esophageal sphincter. So this information we get, and after giving 10 swallows, the percentage of abnormal waves in those 10 swallows, that is classified into a motility disorder if at all the patient has. Now, this is how we do the manometry. Now, as I said, have you got the pH machine? Yeah. Huh. I will quickly show you the pH machine. As I said, this equipment is from Australia. The pH impedance machine that we use is from Canada. It is Sandel company. And that, as I said, that is important in patients who have non-esophageal symptoms of reflux disease. Now, Dr. Lal, would you like to comment on whatever I have said so far?
So I think, yeah, thank you very much. I think it's a great opportunity and a great learning for all of you here to see this high resolution manometry, which is the standard of care. And as it has already been elaborated that manometry is a must before you do any surgery on the esophagus for reflux disease. And it is the first step to do a 24-hour pH metry because you need to know the upper border of the lower esophageal sphincter. And the lower end of the pH metry probe has to be 5 centimeters above the upper border.
Perfect.
So unless you know the location of the upper border of the lower esophageal sphincter, you cannot place the pH metry probe.
Perfect.
So that is the reason for all of you to understand that when you say that you need to do a pH metry, you will also need to understand that you must do a manometry before that. So there are two purposes of the manometry. One, to know the length of the lower esophageal sphincter, the strength of the contractions, the intra-abdominal length of the LES, and the upper border, location of the upper border of the LES, so that you are able to place the probe 5 centimeters above that. And secondly, very importantly, as the word says, manometry, to find out any motility disorder, because the surgery for hiatus is going to increase the pressure at the lower end of the esophagus. So if you increase the pressure and there is a motility problem in the esophagus, you are compounding the problem for the patient, and this needs to be studied preoperatively. There can be broken down contractions, there could be a non-sequential contractilities. So as it was shown in the graph that there is a proper sequence, there is a relaxation of the upper esophageal sphincter, and then the sequential contraction of the esophagus is seen by the color of the thing. So the pink that you saw here on the graph was the high pressure area, and the lesser color like white was the relaxation phase. So it needs to come that the pink is coming down like that, and then the LES opens up and then allows the bolus to pass through, and then the LES pressure comes back to normal. So all that is part of it, and it's a great opportunity that you, with your vast experience of more than 2 decades now, are there in this. There are very few people, sir. I think I must compliment you.
No, thank you very much.
People counted on fingers in the whole country who
Yeah.
do and understand manometry and pH metry.
Yes, basically they have
opportunity for Mumbaikars and all the people here who have the combination of the best of surgery and the best of
Physiology.
work of physiology. Yes, functional physiology of
Yeah,
the
yeah.
esophagus. So I'll leave you now to tell them about the pH metry probe if you're ready with it.
Yeah, no, just to add to what Dr. Lal said, manometry gives us exclusion criteria. He tells you when to not to operate. So when will you not operate a patient? You have diagnosed the patient that he has gastroesophageal reflux disease. You have done endoscopy. It shows relaxed sphincter, and then you plan a fundoplication, you do a manometry, and if you find diffuse esophageal spasm, nutcracker esophagus, or nowadays it is called as a jackhammer esophagus or hypercontractile esophagus, when the peristaltic pattern is normal but the esophageal body pressures are too high, and there is a term called as distal contractile integral. That means the contraction pressure in the distal esophagus is more than 180 to 200 millimeters of mercury. And it is that DCI is calculated in thousands. More than 8 to 10,000 is taken as a case of jackhammer esophagus. And so, as I said, diffuse esophageal spasm hypercontractile esophagus or jackhammer esophagus, then normotensive lower esophageal sphincter, rather the study is normal, the sphincter has normal pressures and the esophageal body is normal, then you have to rethink about your diagnosis, and maybe then you can do pH metry and prove whether the patient really has GERD or the symptoms are due to something else. So apart from these early cases of achalasia cardia, you will be surprised. A patient comes to you with dysphagia, you do an endoscopy, initially you feel your scope has, unless your mind thinks, your eyes will not see. And same way, your hands will not sense. So in a very early stage, the endoscopy is reported as normal. Patient keeps on complaining of intermittent dysphagia. And some people, they plan fundoplication because in initial stages, patient has typical symptoms like regurgitation, food coming in the mouth. There may be burning because of esophagitis, because of the stasis of the food. So whatever it is, you do a manometry and you find patient has achalasia. So you can imagine the surgery shifts from one end to the other end. So that is how it is important. And lastly, cases of scleroderma. Now these patients also have gross symptoms of reflux disease. And apart from the other signs and symptoms, you do an endoscopy, you see severe esophagitis, very lax esophagus, you think this is typical GERD, and again, you plan a fundoplication, and when we do a manometry, we see that only upper 1/3 of the esophagus, which generalized failure of peristalsis as seen in achalasia. But in achalasia, the LES is hypertensive, whereas in scleroderma, the lower esophageal sphincter is grossly hypotensive. So manometry leads you to the diagnosis of scleroderma. So this is what is the importance of manometry prior to the surgery. Now I'll quickly show you the pH equipment.
Dr. Upasni,
Yeah.
We'll just check to OT1.
I'll just show them I'm just showing the instrument, that's it. So this is the pH impedance equipment, and it looks very small, but it costs more than 10 lakh rupees. And the probe. Yeah, sure. And this is the impedance probe. And this probe, what is the difference or importance of impedance with pH? pH will tell you only about acid refluxes. But impedance, when impedance came into vogue, impedance gives you the bolus transit time. It gives you whether there are reflux events occurring and how many of them are occurring, may it be acid, non-acid or alkaline. So you can categorize the patients accordingly. And basically, reflux is not only acid reflux, it can be alkaline reflux, but ultimately or still it is a reflux disease. So that is what the importance of impedance is. Even if the patient is on PPI, you can document the reflux events. And the other point, Dr. Lal, you said, I am forgetting with the flow of talk regarding impedance.
So basically, impedance is, classically the pH metry measures the fall in pH within the esophageal lumen below 4 or more than 4% of the time in a 24-hour period. That is the classical definition of an acid reflux. Now, what about alkaline refluxes or refluxers which are not reaching this pH? These were all missed. So what impedance will do is, impedance will come to know any fluid coming into the esophagus, and normally air which is there in the absence of any liquid acts as an impedance. Impedance is resistance. Correct. So there is a resistance shown. As soon there is a fluid coming back, the resistance falls because it's a good conductor, and the fall in resistance, fall in impedance is picked up by the machine. That means some liquid has come in from somewhere, and therefore we are able to pick up alkaline reflux as well. So this is the state of the art, and now the beauty of this new machine is both, sir.
Both.
Multi-channel, intraluminal impedance manometry with pH monitoring.
Correct.
So you will need to come to know not only the pH but also the impedance fall. So it is the best, it covers the entire range of acid and alkaline reflux.
Yeah, it gives us a Demister score, which is normal up to 14.6.
Correct.
Anything more than that is taken as a positive for reflux.
Thank you
I
very
think
much.
we are done here. Thank you
Yeah.
all of you.
Thank you.
We'll shift to
Hi,
Dr.
hi,
Roy
sir.
sir's OPD.
Sir, can you hear us?
Yes, I can hear you.
Which sir you are talking
Please
about?
go to OT1 with Dr. Roy.
Ganesh, can you hear me? I am from OT1.
Yes, sir. I can hear you. Continue, sir.
Great. So this is where I've already put in one mesh which you have seen. Can the camera focus on this, please?
Thank you, sir.
So this is how I roll my mesh. This is a simple technique. I open 120 vehicle. Dekho de packet. Ye dekho. So we open 120 vehicle packet
All the best.
and
All
use
very
the same
interesting.
to suture a mesh as well as to
एक बार
fix
वो तुम्हारी लग जाने
close
तो
the
points
peritoneum
भूल
as well as
जाते
close the sheath. The mesh that I'm using here is a flat polypropylene mesh, normal pore density. I don't use lightweight, nothing. I use a simple 15 by 15 centimeter macroporous heavyweight mesh. The way of now, camera can focus on the trocar. I have worn a second pair of gloves. Like I discussed in the morning during the IPOM, we are very, very careful about asepsis, particularly in a workshop setting. I don't allow anyone to hold the mesh except myself. And now I'm pushing in the mesh through the umbilical port. I have already put in the left-sided mesh because I think we are really short of time. We have a whole host of wonderful cases after this, a hepaticojejunostomy, then a completion proctectomy, ileoanal pouch. And I will just show you how the mesh is deployed, and then you can go across and see how Dr. Pramod is putting up his IPOM mesh while Dr. Parnendra Lal gets ready for his fundoplication.
So what is the size of the mesh?
So I routinely take a 15 by 15 mesh, Dr. Rajan, and I will tailor it based on the height of the patient. Like I said, overdo your mesh. Most times failure is because of inadequate dissection or of inadequate size of mesh. So overlap it in the midline. So I'm very, very clear that do not compromise on asepsis because you're in a workshop setting. Everything has to be autoclaved. You will use only ETO sterilized material. Change your gloves before handling the mesh and don't allow anyone to touch the mesh. So as I showed you, while I think Dr. Upasti and Dr. Lal were talking in the next OT, I put in the mesh on the left side because we are short of time. We have a lot of interesting cases after this. But this little technique of suturing the mesh, like I showed you when I'm doing it, especially in your first 50 cases, you fold the mesh and put in a vical suture. So in the interest of economy, we open 120 vical, use it to suture the mesh, as well as to fix the, normally we would fix the mesh to the Cooper's ligament, but I think this workshop is part sponsored by BARD. Now, what am I doing? I'm looking at the midline. The previous mesh had a smaller hernia on the other side, so I overlap more from there. So this is my midline. You see the tackers there. This is the sac that I have tacked here. This is my triangle of doom. This is where my corona mortis is going to come. So I don't want to put tacks in this area. This is my triangle of doom. What I do with the left hand is pull the bladder and the peritoneum back. Make sure the mesh is got well deployed beyond that. And this is the value of doing a lot of dissection, little more than necessary. And this is my psoas major in the background. You see this? This is my psoas. The fascia over that is intact. The nerves are below that. So the mesh must at least be up to the psoas. So I'm happy with this mesh deployment. I will, before I cut the stitch, I put a tack on this. Now in a TEP, we don't tack because that is a small limited area. But in a TAPP, you either need to suture or you need to tack. One of this is the midline. Again, I'm going to reconfirm where I am. This is where my corona mortis will be. I'm quite okay. Now, I don't put it on the bone. I put it slightly above the bone. Now that the mesh is fixed, I am now okay to cut the stitch and unroll the mesh. I always think people make a song and dance about floor or the mesh or roof of the mesh. You do what is comfortable for you. Usually I will do it on the roof in a tap and other way around a TP, but I don't think that really matters. I think what matters for your success is your dissection. Make enough space and be put in an adequate size mesh. Nothing can go wrong with this operation. So if you look after the principles like I told you, the triangle of doom and the triangle of pain, you cannot go wrong with this operation. So unfolding then becomes easy because the mesh stops moving. I don't want the mesh to come outside the peritoneum. So I'm going to overlap slightly in the midline like you see me here. If necessary, I will fold the mesh, but there should be no fold the mesh in the distal part. Do not allow any folds to appear during the mesh. I apply some counter pressure and then tack the mesh. Now let's again look at the anatomy. This is the triangle of doom. This is the triangle of pain. So never put tacks in this square centimeter. Never ever go in that area. Neither suture nor tack. Now this mesh is slightly coming outside. So what I'm going to do is just yeah, Dr. Lal is suggesting just pull the peritoneum. So that's another easy suggestion. But I don't need a mesh there. I'm just going to fold the mesh and tack it here. I'm quite happy to. Sorry. So Pawan is saying, let me try and do that. So you can easily just pull this as he's suggesting. I'm just pulling the peritoneum, so that I'm getting a little more space in the peritoneum on this side, proximally. So the point is well made. Just as he said, take a just pull the peritoneum proximally and sorry.
Yeah, so we have a question from Rashmi Ranjan Sahu from Bhuvaneshwar. What is your take of TAPP in an irreducible hernia?
So Dr. Sahu, that point is well made. As I was discussing earlier, one of the reasons where TAPP is better than TEP, or the only way of doing this, is to, in an irreducible hernia, put in your scope, reduce the hernia completely, and then proceed. Sometimes you have a situation where there is incarcerated omentum in the scrotum, which simply does not come out, where you may need to do a small hybrid approach, that is to make a small opening in the groin, and take out the omentum through the groin, and then proceed with a tap. So that point is extremely well made, Dr. Sahu. I appreciate that. So one of the reasons of doing this very large inguinal scrotal hernias, so let me just go to the other side to show you what I've done this side. So that is my midline. This mesh is overlapping that. This is the area of the corona mortis. This is, if you can see the psoas here. So I put this mesh a little bit more medially because it was a smaller size. Now, while Dr. Lal is going to start the fundoplication that side. Now, the point I want to make is this always comes easily. I never need to reduce the pressure. I never need to do anything. If there is a small tear in the peritoneum, however, you must close the peritoneum because you don't want the proline mesh to be exposed to the bowel. In a minute, I will use a 2-0 vicryl to close this. And I would suggest another small trick in the early part of your career is before you close the peritoneum, what you do is you desufflate the abdomen. So now I'm going to ask my assistant to desufflate the abdomen just to show you, we don't want a small loop of bowel or peritoneum to go between the mesh and the posterior wall. So I'm completely desufflating the abdomen and then re-insufflating. This is particularly important in TEP. So for the youngsters in the audience, the first 50 TEPs or TAPs you do this exercise. Before closing the peritoneum or before withdrawing your ports in TEP, desufflate completely and then re-insufflate. Now I'm going to start the insufflation again and let's see what happens to the sac. Left side like that.
We have a question from Dr. Alam from Bangladesh. What is your take on occult hernia explored on laparoscopy on the opposite side?
Dr. Alam, the point is extremely well made. One of the advantages of doing TAPP is you often find a hernia on the opposite side, and I would always correct. So when I counsel these patients in the outpatient clinic, Dr. Alam, I would always tell them that if I find a hernia on the other side, I will fix it for you. Obviously, what I ask our team members to do is to take a picture, show it to the relatives so they're in the loop, and then confirm there is consent before proceeding. But I am not a fan of doing a prophylactic bilateral hernia. That is slightly controversial to me. We would not do a bilateral in all patients. So this is, you can see here that the peritoneum, the mesh is well deployed. I'm happy with this. Pawan, there's a group in Delhi who does prophylactic bilateral hernias. What is your take on that?
Good you asked me that because we have the first publication in the world for prophylactic from our own center.
Oh, really? No,
yeah,
sorry.
In surgical endoscopy, and that too in 2010. So because there was a large number of people actually deploying, but they were not documenting. So, well, it has to be done with consent, and it has to be done only when you find that there are direct defects and there is kind of potential, but potential for development of a hernia. And while you are already there and you've already dissected the opposite side, there is not too much left to dissect on the opposite side. Normally when we do a unilateral TEP, a large amount of our dissection goes to the opposite side also. So in our own publication, we were able to show that high volume centers with experience in situations where the training of the surgeon and the team is such that their morbidity of the procedure is far lower than the the chance of any new complications. It is possible to do, and without any increase in complaints or symptoms at all. And there was a fair degree of a 20% people we were able to detect occult hernias on the opposite side.
Is that a recommendation, Pawan?
No, it's not a recommendation because it's not a. It's got many variables to it. I would say the way it is picked up, the bulge, there are many things which have not yet been defined as to what can be an occult hernia, because ideally you need to do from the TAPP side, you need to see that there was a sac there, but when you do a TEP, which was what we were doing, it is only when you see the sac going beyond the internal ring.
Right.
So there are many variables, and comparative studies are not there. But yes, there is now data to show, at least through our publication, that high volume centers in situations with consent can perform this without additional morbidity.
To say a patient who has indirect hernia on one side, will you tell him to, if he asks?
Well, what we do is we take consent that we will explore on the opposite side, and if we find that there is a weakness or if he's agreeable, we'll put it. So obviously that was done under a research setting, but we were able to at least give data to the world that there is no increased morbidity. However, for all the trainee surgeons here, it is not a recommendation. The recommendation is that you do it only when there is bilateral hernia, or there is bilateral is the way to go. Otherwise it's only a unilateral symptomatic hernia on the same side.
I think we need to shift now to OT3, where Dr. Shinde is ready to deploy his mesh. Dinesh, can we shift audio to OT3 to Dr. Shinde for the IPOM?
Right.
And in ladies and gentlemen, in 20 minutes, the next patient on is a laparoscopic door fundoplication. And in about 15 minutes, we'll also have Dr. Palanivelu coming online with his distal pancreatectomy.
Yeah, OT3, your audio is on.
Yes.
Yeah.
So I'm sure you must have seen the suturing. We did not. We did a lot of suturing a little unexpectedly. Looking at it, we thought that one vlog should be sufficient, but then we closed the abdominal defect right from above. Do I need to show it once again? I'll just show the deployment of the mesh because we have seen the suturing. Na? Do you want me to bring down the mesh and show it once again?
No.
Not necessary, I believe.
Aditya?
No, sir.
Yeah, you could see that in PIP, right? Throughout.
We have done a lot of. We have closed. We have done the abdominal wall closure of the defect and the divarication and all the defects right from above to bottom. Okay. So we have used 2 vlogs. Okay. And now we have put in a spinal needle just to check that we are on the right track. Our pressures are 10 at the moment. Even the suture and closure, we did it at 10. Okay. Sometimes we do all this with a pressure of 8. Okay. So I'm going to lift up the transfacial sutures. Okay. So this is a center one. We have already marked them from outside as well as inside, and we have centered the mesh. Okay. So the mesh is being held up by the center suture, and I am trying to take absolutely perpendicular route, adjusting it, changing the direction. When I'm inside, you'll have to come out, you'll have to come out, you'll have to come out, you'll have to come out. You have to come out because this. Okay. From the other side. So we are leaving a gap of about 5 millimeters between the two sutures. Okay. You can use a counter pressure there. You can see that there is a gap there. Again, we are changing the direction to take it away from the bowel. Okay. Actually, we have one port there which we can use for help. Okay. So once we have the mesh up, then things will become a little easy. Okay. Come out a little. That's the inferior suture. We have not taken the lateral sutures transfacially. We will do them intracorporeally. So we know that we have marked the midline from outside. Okay. We are again checking whether the mesh is flat. Okay. Okay. So now we can leave the mesh down. Stab knife. No. Port closure. Thank you.
Aditya, is there any question for sir? Aditya.
Sir?
Is there any question for Pramod sir?
Okay.
Aditya, can you hear me?
Yes, sir, we can hear you right now.
All right. Is there any
Okay.
question for Pramod sir is what I am asking.
Nothing as of now, sir.
All right.
It's a straightforward procedure. So I'm sure everybody is aware of this. And so now what we are doing is we are trying to leave that 5 mm border between the two. Okay. So once we know that we are pointing in the right direction, then we change the direction so that we are away. Okay. So now once we have the mesh lifted up, we have a center stitch here. We have the 2 stitches here. So now we will lift the mesh up and start tacking. So we are going to use the capsule now.
Okay. So we have a question, Dr. Apurva Chaudhary from Indore.
Yes.
How far should we place the knots or the tackers from the mesh sides due to the mesh resorption?
From the mesh edge or mesh side?
From the mesh edges.
Edges.
As the mesh gets
if we place it here, then there is a large area left behind. So about 5 millimeters to 1 centimeter, because we don't want anything to go between the mesh and the abdominal wall. Okay. So what we do is we hold the mesh up tight. We look at where we are. Is the mesh flat on both the sides? Can you show me left also? Okay. So right now the mesh is looking absolutely flat. So generally I would tack 5 to 7 millimeters inside. Okay.
So is there any possibility of mesh resorption?
Mesh does contract. Okay. The mesh will contract. Okay. And But if, see now, already there is, this mesh should not get lifted up. If we place it here, then there's a large area where for the bowel to go inside. Okay. So that's why we should be 5 to 7 millimeters inside.
So do you tighten the transfacial sutures before you start taking these packers? Because sometimes, you know, it can get pushed on the other side if there is no traction on that.
True, true. I don't do it. We generally do it at the end. But there's nothing wrong in doing that also, and you have a point there.
So we have a question from Dr. Sanjay Kolte from Pune.
Yes.
Any tips and any tips or tricks in inserting the mesh in the abdominal cavity? Large mesh.
Large mesh, the disposable ports help. Okay. And basically, the pushing should be done that the polypropylene part of the mesh should be outside and the coated mesh part should be inside. That is how the mesh should be rolled, so that this thin layer does not get damaged. Secondly, we use a larger port. The mesh generally does not go through so easily through a metallic port. So a disposable port, we already have an OptiView. Thirdly, we can remove that housing, that upper housing of it, which Anil did for me. So that will, that once that upper housing which gives the resistance is removed and only the trocar part is kept, then the mesh will go easily. Fourthly, sometimes we could use roll the mesh in a plastic. Okay, we can roll the mesh in a sterile plastic and remove the port and put it through a port by using, because the plastic will make it happen easily. Sanjay himself, Sanjay Kolte, doctor, he himself does a lot of surgeries, so maybe he might also have some tricks up his sleeve. Okay, so now that we have done it on this side, we will come to the contralateral side. We have a port from the other side also. Okay, right side up, please. Are you okay there, or you would like to come here? So Dr. Pranav is helping me with the camera. Okay. So the tacker itself helps you retract. Now this mesh is not yet completely fixed. That's why you will see that it is rolling a bit. Okay. We will again check where we are. Check our bearings. You're not able to see them, huh? नीचे जाना है ऊपर आके. Okay. Okay. Okay, so at least we have one tack in place on this side.
So many times you find it difficult to do it on ipsilateral side, I mean, from where we have put the port in.
True.
So do you always put a contralateral port on the other side, or there is any other way to do it?
12 करो तो थोड़ा सा pressure just to show it, and then we can reduce it again. Now it's 10. तुम्हाला तिकडनं अजून एक पोर्ट हा जर टाकता आला ना, just you can use this one, use this. So that will hold the mesh up. So we are using, Anil is going to assist. How is the camera? It's not looking all that great, huh? Okay. Okay. थोड़ा तुम्हारा करना
So you always put the contralateral port.
Yeah. For a small umbilical defect, if we use epigastric ports, then just 2 ports are sufficient. We don't have to put in a contralateral port. Okay. But for a large port, you should put a contralateral port. For an umbilical defect, if you're doing it from above down, you will not need a contralateral port.
Okay.
I think it slipped.
So you fire the tracker and sir, there's bleeding come. So what you will do, in sake of the audience, I want to know from you. So
I would take a figure of 8 suture there.
Okay.
From inside.
Directly
There are simple, see, what we do is first we just put pressure of the same tacker,
okay,
wait for 5 minutes and see. Then we look at for where are we at the site. If it is just an abdominal wall bleeding from a unnamed capillary or branch, then a pressure should suffice. If we find that we have gone close to the inferior epigastric artery and we have, although with pressure that bleeding will also stop, but then I would prefer to actually put a figure of 8.
Excellent job, Pramod. You have shown exactly how you should patiently do these hernias and how unpleasant surprises can come on table, and you need to adapt your strategy according to that.
Yes.
I want to welcome Dr. Madhav Garale, who is Associate Professor of Surgery in KEM Hospital and a close friend of mine. Dr. Garale is well known for his work in endocrine surgery and thyroid. I also want to welcome Dr. Palni Velu from Coimbatore. I think as soon as this IPOM is over, we will be showing, sir will be showing a laparoscopic distal pancreatectomy. I have requested him to show this laparoscopically rather than robotically. And in a few minutes, as soon as the IPOM is over, you will have a feed from Coimbatore in one screen. And one screen will be Dr. Pawanendra Lal operating in Zen Hospital, showing you a laparoscopic door fundoplication. Dinesh, can you coordinate with GEM Coimbatore to make sure you have PIP of distal pancreas?
Yes, sir.
And then
Yes, sir.
as soon as sir's mesh is fixed,
almost.
So then you can get afterwards. Dr. Palnivilu can be in main screen, and IPOM or the door can be on the PIP.
Okay, sir. Okay. Coimbatore team, kindly on your camera.
Yeah, we can see the feed from GEM Hospital. Will they be able to hear our audio, Dinesh?
Yeah, no. GEM Hospital, can you hear us?
Yeah, we are getting your audio.
Yes, done. Thank you so
Sir,
much.
good afternoon, sir. This is Roy Patankar.
Yeah, congratulations, Roy, for making a wonderful program. I'm sorry that I could not make it to Bombay. I love to be there, and previous meetings I was there, and you made it every annual program. So wish you all the best.
Thank you, sir, and thank you for showing this case live. Sir, you are our mentor in laparoscopy, and what we have learned today is because of you. I remember I have been to your GEM laparoscopic conference every year for almost 10 years when you used to hold it in Coimbatore, and we are all very, very grateful for your teaching and guidance over the years, sir.
Thank you very much, Roy. Thank you very much.
Can you get one fellow of yours to tell us about this patient, sir? Some details about the patient, sir?
Yeah, this is a patient. Oh, we'll show the CT. No, go to CT and come back. I'll show the CT. This patient has got between 6 and 7 centimeters tumor in the distal part of the body of the pancreas.
Can the cameraman zoom onto the CT, sir?
You can appreciate the CT picture. I will show you.
Yes, sir. We can see it. Cystic tumor of pancreas, sir. Yes, sir.
Yes. Yeah. Papillary cyst adenoma of the pancreas.
Yes, sir.
And once attempted, I don't know why endo ultrasound aspiration done, and the patient has come to us. Such big tube, always go for resection, and the patient was requesting me if it's possible to do a spleen preserving. If not, she also gave a consent to go for a splenectomy, combined distal pancreatectomy. Okay,
Yes,
let me
yes.
start now. And in between, moderators want to ask anytime, don't hesitate to talk, and I'll be continuing this technique while talking myself. You can appreciate. So now,
Yes, sir.
You can look at, we're starting now. And this is a pneumoperitoneum created with using Virus needle. And I'm making a 10 mm trocar subumbilical.
So we have excellent audio and video.
Umbilicus. And
Yes,
if
sir.
it's a distal, then we go to the umbilicus only because we can. Now, 10 mm scope, angled scope, I speak fast. We are looking inside, you can have great momentum, that is the stomach. And slightly tilt of the left side has been done, and if necessary, we can make it more. Right side, liver normal, gallbladder.
See, actually, without
Even a
using
benign
contrast
cyst,
report also,
sometimes,
if
may
the proper
misguide us
estimate
with the tumor. Always intraperitoneal examination is most important before proceeding it. And look at, and now I'm making the right hand working trocar. And this is 5 mm.
that's now falciform ligament. We want to put it up.
Sir, along with me is Dr. Madhav Garale, sir, Associate Professor of Surgery at KM Hospital.
Ah, Madhav, I know him. Yeah, very nice.
Yes, sir.
And the other side, Paul is starting surgery. I'm not able to see him. After that, I will surgery over. I love to talk to him. Okay, nice. And now see this trocar, I made it such a way that right hand surgery is performed standing between the two legs. And cameraman to the left of me and the staff nurse standing on the right side.
We have
Now the left hand trocar, I'm making it in the midline, crossing to the calcium ligament.
मध्ये पण गावाला जाऊन बसू शकतो ना.
Never hesitate put 1 or 2 extra trocars, but this particular case we finished with the 4 port, and I'll be keeping 12 mm trocar. I will make it later on for stapling the pancreas. Now you can appreciate that the grammar we are taking off, looking at the colon, splenic flexure. Particularly, we have to see the sister given a ligature, but I have to see the mesocolon. So I get another ball graph.
Someone land up giving you different cases. Yeah, every time. That's true. But nice. Especially this. Suturing chance.
Now you can appreciate that the tumor seen through the mesocolon, the left of the middle colic, left colic.
Oh.
Now you can see even the kidney is visualized.
Yes, sir.
And DJ flexure. That is the tumor seen inferior, infracolic.
Yes.
And look at the gastrocolic omentum, other areas. Sometimes you may look for spleneculae and peritoneal deposits. Many size any tumor 5 centimeter beyond, and suspicion of malignancy you always should keep in mind. So that way we have to always rule out.
Wonderful.
Now look at that is a tumor. Colon trying to pull out. It's not infiltrating. That is where I'm checking. It is not infiltrating. Otherwise, I have to make it a circumferential incision mesocolon, including with the tumor. Now we are going for starting with the dissection. And tilt left side up, you can appreciate the tumor. That is a spleneculae.
Open करू नका हा.
Sir, any role of doing a preoperative US guided FNA to see the CA 19-9?
It can be seen. Doubt is there 3 centimeters, 4 centimeters. I love to have, because if I want to do and spleen preserving or limited, careful. But otherwise, resectable tumors I don't recommend biopsy. If at all, we are going to keep margin. And facial involvement. And
is there a tacker?
Aspiration biopsy is not going to help us. Now I'm
actually
now we are looking at the pancreatic tumor, tail and the body. This is a gastrocolic, splenic, and the gastrocolic.
Can you show the other side? Yes, I think we can just let it go.
Yes. So we have more than 3,500 people online at more than 41 locations. People are watching in various medical colleges and surgical societies, sir.
Wonderful, wonderful. All your organizational capacity making it.
So because of you joining us, sir.
So this is a gastrical momentum. I am going towards the right side. Between the stomach.
You can
and
put
the
off my
colon.
transmission. Go ahead.
See, look at it. It is a facial plane. We have to go carefully. Further dissection towards the right side. Now this mesocolon is dissected down and to enter the retropancreatic plane. Now look at that. I am dissecting the mesocolon, and at this level, DJ flexure will be there. Care must be taken not to injure. It is very closely related to pancreas. Now I am taking this, and I am going towards this. That you can appreciate that is the anterior capsule of the lesser sac covering the pancreas, making the lesser sac entry. And anyway, we are going to take it out the serous layer of the pancreas. Now we'll divide some of the short gastric vessels, make it wide exposure. And this is particular procedure, minimal invasive, is a very good indication, and it can be done very well than open. Open getting at this exposure is very difficult. Now look at that pancreas visualized and the tumor also is fully. We have to go to the right side till the normal pancreas. We may need at least 4 centimeters to keep it so that 2 centimeters will come normal margin with the tumor. That is the left gastroeploic and the short gastric vessels we continue to divide. If one is decided to preserve the spleen, then must be careful keeping the short gastric vessels not to divide at this stage. And see, now you can see splenic arteries seen the beyond. Now that is the stomach, and we are able to reach the hilum that side.
Very good, sir.
Yeah, that is the pulsation short gastric scene. That is the first wall of the stomach. I'm with the left hand, I'm just tilting up. Further division of the short gastric.
So you're going to do the spleen preserving?
I'm going to attempt it. Let me see. And
plan according to your.
Yeah, it is for findings, and we cannot be because the vein size, vein and artery should be free if at all we do. So consent should be for both. Okay. And if it is vessels are free by imaging investigation, then we can commit the patient will do it. In fact, and 2 days back we did spleen preserving. I had 2 cases this week. One finished spleen preserving, nice case. That case.
Yes, very good.
Now look at, I'm going posterior to the retropancreatic dissection. While doing it, I'm just mesocolon with the fat dissecting down along with the DJ flexure down. You can look at. Never breach the capsule of the tumor. That is very, very important, and it's careful. Now you look at, that is a gap in the mesocolon. You can see the opening. It is okay, but the opening happens better rather than injuring the tumor capsule. Very important. Now see inferior border of the pancreas, and the serosal line we divide it to enter the plane between the mesocolon and the pancreas. Now I'll go posteriorly, taking down geratus fascia, and if it is involved, and that means it is a cancerous, that means the facial plane goes well. But in this particular case, geratus fascia is free, so we include with the tumor. And see, geratus fascia posteriorly, pancreatic capsule goes up. This dissection will go cranially as much as possible before going to the artery and the spine separate dissection. I told the patient it is a remote chances, but still I will attempt. That's what the spleen I told the patient. And the patient has given already vaccination for this. But of course, after 10 years, that is not essential. But still, patients, they will be very confident. Otherwise, lifetime they'll have fear of lung infection, something like. You give vaccine, okay, they have, we have protection like. So now you can see I'm going beyond, reaching the upper border of the pancreas. And left side, medially, will go up to the crus. And left celiac axis and the vessels. And now you can see I reached almost upper border. Alternatively, no, and it can be upper border of pancreas or posterior. Alternately, one can do it.
So, which energy source you are using in
This is
the audience?
ligation. This is a very nice instrument with the coagulation, sealing, and cutting it together. But harmonic is also whichever it is good enough. But if I take one energy source, I'll finish with that energy source, and we can add more cost. Now look at, I'm going on the right side. That part of the body of the pancreas is normal parenchyma. See, now that is the body of the pancreas. We go between the, see, dissecting it. Because the tumor, the angulation of the body looks. Now you can see the vessels coming. And posteriorly, I'll take the fibrofatty tissues. While doing this, at this level, always we have to look for adrenal gland. It will come. Now you can see that is adrenal gland.
Yes, sir.
If it is involved, then that fascia, gelatinous fascia involved, then I'll go posterior to this, including the adrenal gland, take it out with the distal pancreatectomy. So facial plane can change either in this level, this is a type 1, if including the adrenal type 2, and if it is a kidney is involved, also including kidney, we'll go for a still further, including the kidney. That way, individual patients can be decided depending on this one. This is looks like a benign, but little more vascularity. I don't know because of endoaspiration made it color looking like, but still I was very careful. See, look at, I'm going to be taking all the perinephric fat, adrenal gland, and kidney down, looking towards the right side, and this is splenocolic renal ligament.
So, if there is a mesocolic invasion, then what we will do?
I'll take the mesocolon with the tumor.
Okay.
And even colon involved, yes, including colon, you can take it out. So that way, it is there's a margin of resection includes depending on the stage of the tumor. Now the inferior pole of the spleen, I am releasing it free. Splenocolic or splenorenal, both that will come. See, this is a peritoneal covering. When you release, then the spleen also will become. Even spleen preserving, this complete dissection must be done before going to the vessel. Otherwise, it starts bleeding, then it becomes a problem at that level to manage it. Now look at, that is inferior to the hilum of the spleen by dividing it. And we can keep some attachment to the upper pole of spleen. Now not release, otherwise retraction is very difficult. Now look at, I'm using my left hand, that is adrenal gland, and I'm going anterior to the adrenal gland. And while doing it, it will be reaching medially the celiac axis and the cranially the left crus. Now I'm making one more trocar for helping us and a surgeon to hold. Otherwise, with one instrument handling difficult. Two retractors who can make it up. One is on the left line. Another one can be the epigastrium, but depending on during the process, if a difficulty is there, I make it up. Now this is assisting surgeon will be using grasper. See, now like somewhere some handling will help us so that we can now. So I have my left hand also retracting it, right hand free for a dissection. Now look at, that is a stomach. You can see, yes, sir, that is taking this to stomach from posterior attachments. The vision is going behind, looks very nice vision. Now look at coming to the medially, taking some more attachment of the, releasing the pancreas. While coming laterally, that small arterial branches may come from, and they should need to be sealed. And that branch can be from SMA or can be from the splenic artery. And the splenic artery we don't come across. This level we can have branches from the SMA. See, you can small level. Main branch will be at the closer to the neck. That we are not going to go. That is a splenic vein. My left hand is pushing up. Now we're taking the tissues posterior to the splenic vein. When we see there are also small arterial branch and coagulating, cutting it. When we release the tissues, then the artery will be visualized. Artery can be seen posteriorly or anterior to the pancreas. Both ways. Alternatively, one can dissect also. Last June, and Japanese Society of HBB, they made a consensus and the technical perfections. And that perfection was nicely discussed. These are all the points that during surgery. See, small artery, somewhere it is bleeding.
So we're just going to shift audio for a few minutes to Dr. Pavan Lal, who's showing a fundamental again. We are watching you live on the screen, sir.
Yes.
Yes, sir. Dinesh, can you shift? Yes. Dinesh, shift to OT2, please. Dinesh, shift to OT2, please.
Yes, sir.
Audio.
Yeah, hello. OT2, can you hear us? Yeah. Yeah, hi, sir.
Yeah, hi, sir. Hello.
Yes, sir. Yes, sir. Continue.
Sir.
Sir, we can hear you.
Yes. So we have just started this, the same patient whom you saw the manometry of, and we have 5 ports in position. So there's an epigastric port for the liver. Then there is a left and right hand, which is below the right and the left subcostal margins. There's an anterior axillary port for retracting the stomach, and the camera port is 2 inches above and on the left hand side of the umbilicus.
Take out the camera.
Okay, yeah, we'll do. So, so that's it. So basically, that's the umbilical port. Just show the umbilicus. Yeah, so it's on the left hand side. It's not in the midline. That's a little bit of a change. And then that's the epigastric port. That's the left hand of the surgeon, which is right subcostal, mid clavicular, left subcostal, which is left mid clavicular, 12 mm port, and then anterior axillary, which is 5 mm port.
Would an umbilical port in the middle, supraumbilical midline make a difference?
In the midline, I normally find a little bit problem sometimes with a large falciform. Okay. So that's the reason I've kind of moved away from midline and gone to the left. And also, if you see, when you are on the left, you are actually in front of the hiatus. Yes. Absolutely, yes. Because it is anatomically on the left hand side. Sure. So it works well, and we have
vessel in between.
Yes. No.
It has to happen in the workshop.
The gastrohepatic. Sorry?
It has to happen in the workshop only.
What's that?
Getting a vessel across.
Oh, well, yeah, that's just a little bit of, I'll just put a gauze and settle it up. So anyway, this is the gastrohepatic omentum. Yes. And as always, we preserve the vagal branches which go to the liver and to the gallbladder. So we do not disconnect this whole limb as many surgeons do. And then I also did the dissection of the peritoneal covering over the stomach, and on the left side I have scored the peritoneum partially. Some of it will again come when I move it all around, and just come to the start of the left crus. So then I started the plane between the right crus and the esophagus. That is the right crus. Yes. So this is the right crus. So this is a plane which develops very nicely. Sometimes you may get a small vessel, and if you do not identify it and open it up, and this is the space that has been made already, which is on the right hand side. This is the esophagus, and here now the step is to take the give me a gauze face there. Give me a gauze face.
How much dissection in the chest would you do? Because many people like me believe that lengthening the esophagus, I know we are at 2 ends of a spectrum, but lengthening the esophagus is key to prevent recurrence.
Yes, I would go about 5 to 7 centimeters easily.
in every patient. That's actually
Absolutely, there is no
extremely-
question. There is no
extremely
question about
important
it,
point, yes.
because we have to. The whole idea of a good hiatal repair is to have a good intra-abdominal length of the esophagus, and if you don't have that, then your whole operation has become a bit of a. It won't serve the purpose. You need to mobilize it. Only then can you think of bringing it down. Otherwise, so you can see this. This is nice. You can see the posterior vagus there. Very nicely seen. Can you see? Can you all see the posterior vagus there? Is it?
Yes.
Or is it not?
Yes,
it is. It is the posterior vagus.
Nicely seen.
Yes. And this is the important step of going. So now before we do that, we'll have to create a window on the opposite side. So now I want the traction to go towards my side, which is Vishaka, you said?
No,
Sneha's side. Yes. It's got
Currently,
released.
we have our two best surgeons on vision. Dr. Pallivelu is on half your screen and Dr. Lal is on the other part of the screen.
Greetings to Dr. Palni. Yeah, just go there laterally. Yeah. So we'll keep swapping it once we are making the space, and a little bit of this momentum. And of course, in this operation, we don't need to divide the short gastric. So now come up here, and we see the division of the gastropleural segment of sometimes they call it esophageal and phrenogastric ligaments. And once you divide them, you see the left crus nicely. Just show me here. Yeah. Sorry? Yeah, I always do.
Yeah.
We always preserve the.
And many surgeons do a left crus first approach.
Yes.
Is there any specific surgery?
Hi sir, how are you?
Yes, I'm fine. Yeah,
Good to see you. Good to see you, sir. Good to see you.
Yeah.
Excellent surgery there. You demonstrated.
Thank you. Thank you. So any specific instance where you would go left crus first and not the right one? Or you would always go for the right first?
I always go for the right first, but I do a little bit of a scoring always.
Okay.
And that helps to, kind of.
Okay. Same approach for paraesophageals also?
All of them,
right
sir.
Crus also.
Always. It presents to me first and I handle it first.
Okay. You will just move the audio to Dr. Palli's.
Yeah, sure.
We'll just move, Dinesh, like to move the audio to Dr. Pallivelu's OT, please. Dinesh, can you hear me?
Yes, sir. Yes, sir.
Please shift to Dr. Pallivelu's OT.
Gem Hospital, kindly speak.
Yeah. Hello. Now I'm dissecting at the artery and taken skeletonized. Now you can see a branch going to the pancreas towards the tumor side. So we have to, normal splenic artery has to dissect it adequately. Till now I am planning for a spleen preserving here. I want to see the artery vein, how it looks like. The artery is very clear. And see, I'm using a vessel sealant just to seal the branch. Then I'm again with the ligature, I'm going to divide it. Yeah, this is the branch just to the body. I'm just dividing it. Subsequently, whichever normal artery, we have to dissect out completely. If you dissect arteries involved, then that we can go straight away, clamping the artery in the vein, taking the tumors, distal. Here now look at, and artery has been dissected. Now I'll go alternatively see the vein also free, and now see the artery has to be cleared and put a loop. Anytime bleeds, we can even ligate and control. See, this is not for tying purpose, just for a loop. If necessary, we can use it. We can use the clips. A clip means we control that. We can remove, the artery will get damaged. And this is just for a loop, and we don't handle the artery till if necessary. And this is, can look at artery has been dissected adequate length and put a loop. Okay. So now we pass through this loop and keep it up. Anytime just lift up, it will tighten it. Huh? And so keep it up. And you can make it very loose. Otherwise, no, you can. That's why now, like, don't tighten it. Sometimes it can close. Okay, adequate.
Sir, can you hear us, sir?
Yes, sir.
Many times you have these small vessels that go between the splenic vessels and the pancreas. How do you tackle the small bleeding that you get?
Mostly, now we have with a very good energy sources. And see, one of the artery branch, vessel sealed and divided without even clip or ligature. That branch you would have just shown. No, I'll be showing it again. And these are all these smaller vessels very easily can be seen because of magnified. The vessels will be clear. Now look at. And because of tumor size is a roadblock like. So assessing surgeon is going to give it downward, show the splenic artery. I can take it out.
All is inside now.
Yeah, you can see the vein also coming and pushing anteriorly. And this is a peritoneum. When we go dissect, smaller branches will be seen nicely.
Left hand.
See now, I am taking the peritoneum first. Once taken out, then we can see the artery supplying the pancreas.
Yes, sir. Yeah. Good vision.
Arterial branch, no problem. Only venous tributary from the splenic vein to the pancreas is usually very fragile. Huh?
That's the posterior vagus.
Now you can see splenic artery there.
Yes, sir.
Separating the artery from the pancreas.
They come here.
It comes 2 or 3, nothing else, not more. See, you can see another branch.
Yes, sir.
This is a very good energy system, very sealing and cutting it. Even the whole splenic artery can be sealed and divided without any this one.
They can see this? Yes. There are 2 screens there.
We'll see what the audience is saying. 50% view.
Okay. Oh, right. Okay.
Now we are going towards the spleen, taking the entire artery free. Yeah? And sometimes it may be a marginal type or the distributed type of splenic artery. It branching takes place at one level, must be carefully. Now you can see the branching of the splenic artery, upper pole,
yes,
and lower. It is
Laude.
How many centimeters of
the
artery is key. The particular case, preserving artery is not an issue. Okay.
Yes, the vein is going to be trouble.
Let us see.
Sulk hai? मतलब waste नहीं
rigid, take it. This is where the small leader and yes, and sealing it. Okay. The important lies in the splenic vein now. Always should keep a gas piece inside. Any bleeds and we should not traumatize it. And we should gas piece ideal thing to compress and stop the bleeding. Generally, nothing pressurized more. Will be. Now look at that tumor and the part of tail and the body, normal body of the pancreas also we are dissected posteriorly. That is, and that silk is we put it up, then go posteriorly. Vein already have seen before. So we start that you can show the course of this splenic vein. You can see that is artery. So and artery can be divided and dissected completely up to hilum without any difficulty now. Okay.
So we have excellent audio video. I want to thank Parthasarthi and Pashupati for making this possible. We've been liaising with them for the last 1 week.
Yeah, they always make it up, no? So clarity is okay. I wanted to ask, and then I'm happy.
Yes, sir. Yes, sir.
Yes, sir. That. And we made it that quality little less so that I not to have jumping. Is there any jumping or smooth?
No, sir. It's quite smooth.
Very nice. Okay. So that is a hilum of the spleen, and we can see the tail is going up. That hilum dissection also tail is very important. One can go from medial to lateral or can from lateral to medial, taking this tail separately also, and that towards the tumor.
Come up.
Now look at that is a tail now here. The smaller vessels are here. You can look at that is artery, smaller vessels.
Anyway, let's go back again. I wanted it to be equal rather than.
The artery is almost free now. Smaller attachment that fibrous tissues can be taken. So now retraction to the left side, making it a straightening the vessels, and we can appreciate the tail now. Some more peritoneal tissues attachment is there. We release this is good.
This unnecessarily it's becoming a.
And this is a vessel sealant, and during dissection bleeds also we can seal and go on. Nice instrument. Lens.
So when do you use ligature? When do you use vessel sealer, sir, for this vessels?
Nothing. It is if we have an in-hand, sister gives it, it's fine. And vessel sealant is we can dissect, coagulate, and that one. But ligation additionally cuts. But holding a tissue, bipolar is good. Vessel sealant is not the ligature. Ligature, and you can't dissect like here. You can dissect nicely, seal it. The tip works well. And particularly the ligature which I am using in the curved type, and unless until you hold completely, it will not work, no. But bipolar is not. Just even half closer, it works. That's why harmonic may be a better choice that way, and we can use speed or load this one.
Oh shit! बहुत लंबा ले लिया.
Yeah. Now look at I'm going along the tumor, and that is vein. Now vein is coming. Not good sign. I'm looking for a gas piece and yeah. So now this vein here, this place we have to decide this way, the resected spleen vein preservable or not. This dissection, opening the jaws and making it is easier with the ligature. This one, bipolar. Look at this is where we know the plane. And the spleen preserving is better in case of keyhole approach, either laparoscopic or robotic, than open. Because of cleavage where nicely can be seen.
Sir, when you are using the harmonic and ligature and bipolar simultaneously in this patient.
Yeah, this is a smaller cleavage dissecting like here, because I can tip can cut. Ligature, holding a tip is no curved tip is not a good instrument, and that's why this particular case the demo will show it. Normally we do it without the demo, then we don't use too much energy sources. And of course, we made it all reusable instruments by sterilizing. So it does not add. Some of the corporate hospitals have policies disposable each instrument, they don't use it next time. So like robotic adds more cost. Here, these instruments can be used.
Harmonic doesn't.
So with the permission, we'd like to shift to Dr. Lal,
Yeah,
sir.
please,
2 minutes.
Okay.
On way with you.
Yeah, so I've just, as you had seen, taken
Dinesh
the.
OT2. Dinesh OT2. Audio.
Yes, sir. Yes, OT2 is live.
Okay.
Right. So, if you had noticed while you were watching this, I've taken the posterior vagus with the. No, I have not.
Doesn't matter really, because you can see it, you identified it and preserved it well.
Right.
And the plane is between
Well,
the
it got
vagus and the
lost. Yeah, but we are
esophagus.
not, because it's in a hiatus. I would have in a fundoplication. I would have, but here I don't bother about it. But anyway, just hold it for a minute and let me
The
just show
point
them.
Dr. Lal has made is in a fundoplication, you must identify and preserve the posterior vagus. In a Heller's cardiomyotomy, please look and preserve the anterior vagus. You can
So
see the
that's
posterior
the-
vagus beautifully now.
Yeah, I can say I intentionally left it so that you could see it. So in a normal for a fundoplication which is 360-degree Nissens or a Rossetti, which I do, I would have taken this with my loop and created a retroesophageal window. Some people tend to bring it between this, saying that it becomes more secure. I feel that taking it makes it safer because it keeps the vagus where it is supposed to be and make the wrap come from there. But in any case, this is important. So as soon as you have taken the most important step, I think, is this one. Right. When you take when you go behind the esophagus, because that is where you can do injury to the posterior vagus, give injury to the esophagus itself. So you saw I opened up the space between the left crus and the esophagus, made that window behind the esophagus and then passed it. And as soon as you do this, then you can let go of the stomach traction here, you see, and you must check the stomach traction, because if there is injury, you have to take a little bit of a bite, 1 or 2 bites there. And once that is done, then all the rest of the work is going to happen through this. So this is actually a juicy one, isn't it? You wanted me to do a door on this, but anyway.
So what is your go-to procedure in Manasi?
Rossetti Nissen, 9 out of 10. Okay. Failing, slipping away, the fundus slips away, door. We started with
so never a Nissen.
Nissen, no more of disconnection.
No full wraps.
No, all full wraps.
All full wraps.
Rossetti Nissen is all full wraps, but no divisions.
You don't do toupees at all.
Only very rarely if otherwise at all.
People, ineffective motility.
Yes, all of those will be going straight away for a partial wrap. They would not be for a complete wrap.
And would you be swayed by a pre-op manometry?
They will all be They will all be ones which are having. So if this was the one,
pH studies in all patients there.
Absolutely, it's mandatory. We do it as a protocol. We do it and we have all our. So this is the way. This is where we would do a normal. To get the fundus here and then go for the southward traction. Hold this downward here. Where is the lock?
You can do toupees if you're comfortable with that. I'm okay.
No, I don't want to do toupee. I'll do a door. I'll do what I'm assigned to do. Don't worry. Just come down. Yeah. And then this is what the classical is. This is just for the audience to know the difference about the two procedures. And you see the difference is this is Nissen, but without division of the short gastrics. Right. So when you do division, it becomes Nissen. In the trick, isko niche rakho. The trick in Rossetti is you use the anterior wall of the stomach to bring the fold. So you are buying on the anterior wall, part of the anterior wall, to bring it together. So it does not need to divide the short gastrics here. That's what it is. And my opinion, it is important for the neurovascular anatomy of this area. It becomes a little bit maybe gets affected, and so that is what is the classical one. And now in this case, we are going to proceed to the door, which is our planned procedure here, which is because of the motility issues that have been identified already. It's not a totally abnormal motility, but it's possibly a poorer motility. The contractions were possibly not as strong as they would have been liked. So now we need a vertical. I need on my left side. You need a traction to go on the left side, and I'll now create the angle of his. So I'm okay to go to the opposite for you to go there, and they can keep watching here.
Dinesh, can we shift to Dr. Pallivelu, please?
Hello. Yeah, Gem Hospital. Yes,
okay.
sir.
So
We can hear you.
Right?
Yes, sir. We can hear you, sir.
Go back.
Yeah, and I made up my mind at this stage.
Okay, we are all set
Yes,
now. We are all set.
it looks like not free from the tumor. It is just trace
Handle repair.
attachment is there.
Yes, sir.
And so after the small bleeder, I also distally dissected. Then
Yes,
found
sir.
out. I think I'm planning for making my mind for a distal splenectomy.
And any chair.
Yes, sir.
Needle holder. Needle holder there. So spun karenge hide.
No safety. By chance, if it happened to be anything 5 centimeters plus, you always look at suspicion of a malignancy.
Yes,
so I decided now I'm planning for a spleen. There are two types of ways pancreas can be divided. Like Argentina, other country, Latin America, they include the vein staple together, easier, no, that way. But general teaching is a splenic vein separate, clipping and divide, and the pancreas separate. Huh? So that's why I'm trying to show here. This particular case, since there is bleeding, you can put a stapler, but I want a margin more. That's why still I need some more dissection. I'm doing a dissection of the splenic vein. I want to clip it, divide, then before going parenchymal division. Very soft pancreas, huh? Left hand you can appreciate. That my left hand pushing the parenchyma and going around. If a very too difficult to take the vein, don't hesitate, put a staple together the vein. Huh? That is also accepted. But majority of science opinion is the ligation of the vessels and the division of the parenchyma separate. That's what I'm in here also. It goes like a groove, this particular case. That is the upper border of the splenic vein, the parenchyma. And many times that artery and vein will be close to each other closer. See now almost.
Can you hear me, sir?
Yeah.
Sir, can you hear me?
Yeah.
Hello?
Why is that?
What margins would you like for such, because it's very high suspicion of malignancy, seeing the size of the cystic mass?
Minimum must be 2 centimeters. And in this case, I'm a little more. I'm taking it additionally. That's why I'm dissecting it.
And what color cartridge would you use, sir, for pancreas, being a soft pancreas?
It's this pancreas. I'm going to use a blue. And if it is a very small, thin pancreas, I use a white cartridge. If
Yes,
in South India, many of the pancreas will be firm. If it is a firm, I use a golden.
Okay.
And it is selective. It is not one type of cartridge will help. That's why this is always people talk, stapling this. Now, this particular case going to use, it is a soft but thick pancreas. And if it is a thin, small pancreas, then I may use a white cartridge. And chronic pancreatitis associated, then golden better, not to lacerate. You should not have laceration. And laceration, then we have to overrun the divided end.
Yes, sir. So you'll do the artery, vein, and then divide this.
Yes, separate. Artery vein will clip it and divide it. Now I'm looking at 12 mm proca per stapler.
मेरा ले लिया आपने कुछ, हाँ.
Small blood clot and then that one small vessels will be.
धागा दिखाओ ये आगे.
Now that upper edge also we can be completely released. Section is not that powerfully taking out.
तीन लेना पड़ता है ये. It's slippery. Best handling, but everything comes with a price.
Yeah. It is not coming out proper. Section is not powerful enough to. Otherwise, would have sucked out. Now we will
कि आप दो दिखा रहे हो.
to clip the.
I thought it is a PIP.
हाँ. और उधर तो LED वॉल लगा है.
हाँ. मैं एक बार ये हाइटस खत्म हो जाएगा, एक बार दिखा देंगे, फिर एक बार डोर शुरू करते हुए नहीं, वो भी थोड़ी देर में दिखाते हैं. Give me 5 minutes. Oops. So all my knots are squared. Are you seeing this? It's C and reverse C. I have just made it a point in my life that I will not go for non-squared knots. I just don't know.
Reverse C. Yeah, nice.
Even for that drain, you saw that.
We are enjoying your surgery, and the vision is very good.
Very right. So now you can look at, I'm planning in a division of the artery, vein, all. This, I'm going to divide the artery.
Yes.
And I have a long length. This so initially would have decided by the time would have gone finishing surgery. So much dissection not done, but surgeon should always have an attempt to know what were the best possible. So that's why I tried. Now it's okay. But I told the patient that this patient 60 and then 2/3 I may likely to remove this spleen. So now you look at that short gastric vessels and up to fundus, upper pole of the spleen, we take it out.
Do you use additional clips in spite of having a ligature or something like that, or you would just use a
Short
vessel?
casing, no clipping.
No.
Ligature is very good enough. Artery also, and artery, and like I use put a clave, and ligature is good enough, no problem.
Okay.
But teaching always keep one clip, safety. Otherwise, and
Yeah.
if it bleeds, then that people, particularly distal pancreas, you all know, pancreatic enzymes can be there in 10% of the cases leaking at this division end. That should not digest the sealed end of the artery and postoperatively having bleeding. That's why in Whipple surgery, many times, and that bleeding happens. Nowadays we know why it is. No, we don't see the bleed. That's why I encourage one clip, Absoloc, Hemaloc clips is the ideal thing to put it up.
Okay. But even a liga clip is okay, or you would always want a hemo
Liga
clip?
clip, okay. But additionally, for reduce the cost, you put a regular clip and a distal to that.
Okay.
Because and titanium clip has got a tendency to lacerate the intima of the artery. So the first one hemolock is without intimal damage. So it is good enough. But some surgeon has got a feel it can slip out. And so that's why distally you can use a titanium clip. I'll be showing both. No. So now I'm going to, I divided now, the upper pole is finished. Say that there, just to irrigate and see any small vessels also we can slip. And
do you use a hypotensive anesthesia for this? Because in spite of the vein bleeding, we are not seeing much.
No, it is true if a patient has got otherwise, but generally this is straightforward. It is under control. Now, regular, I don't even talk to anesthetist what I want. This particular situation. If there is vascularity in around the spleen, and I need a control more, particularly associated with then I keep them out. Otherwise, this case straightforward surgery, no need for it.
Routine
anesthesia. Absoloc, hemoloc clip. I should put proximal. No, here, this side. Yeah, I will come back. So this is a traumatic clips like. So no intimal tear. Then subsequently distal do 1 or 2 clips, and I'll be putting a clip over the silk. I have not tied it. And generally nowadays, people say major
mind को बोलना है कि मैंने
cross. They put a clip, particularly liver resection. I will see other resection. I don't clip better than without a silk.
बोल रहा हूँ कि शुरू से ही ना.
I need not tie it.
Okay, then मैंने I'll be doing a square.
You must make sure this. Now we'll divide it because we don't require any other side. No, we can divide it. See, 3 clips are there, safety. It is more than adequate. Okay.
अच्छा.
By the time you finish, 2 साल एक publication आना चाहिए हमारा.
बिल्कुल आना चाहिए.
Now I'll go in vain.
That's her job. 3, 6, 9, 12 months. She's making telephone. She's maintaining a database of all our prospectively.
Very good, excellent. अब देखो ये दिखाओ अब इसमें यहाँ पर ये जो चिंक है ना थोड़ा सा now let go of the traction.
You can appreciate the vein is now pressure is less, collapsing because all arterial branches all divided, including main artery. Now this vein is this one. So now I can use clips. First clip always recommended again here also. And if you use any titanium vein, don't crush it. Very important is tearing. It is a fragile vessel. Once tear, then controlling is very difficult. The trocar is placed between the camera trocar and the left hand, and it comes exactly in the same line. I wanted to clip mainly because I wanted to have normal pancreas more and the resection margin. Teaching is, as Roy asked, 2 centimeters minimum, not less than that. Don't tie closer to the tumor. At this level, I should not have divided with the staple. I should not have gone clipping. See, now I made it a bleeding. Again, I have to control it before. This distal to the clips, spleen, vein, and the splenic and the pancreas can be divided.
Actually, सीधे रखना है, हाँ, सीधे, बिल्कुल ठीक है.
It's a previous one small branch, and it's.
So we'll just shift audio for some time.
Yeah,
We're
go
watching.
ahead. Please go.
Yeah. Dinesh, shift audio to Dr. Pawan Lal, please.
पीछे हो.
Dinesh bhai.
ठीक है, अब इनको दिखा देते हैं, वो पीछे का रिपेयर. Yeah, so are you with me now?
Yes, sir. Yes, sir. Can you hear us?
Yes, loud and clear.
Yeah, so we have in the meantime taken the hiatal repair. I've taken 2 sutures, and here is the $1 million question. How many sutures and how much of this gap? Now, for this reason, people have used bougies, 50 to 60, French. Then they have, various things. But what we have done is with experience only. Either you have a measurement here, and I'll leave it to Dr. Roy to demonstrate it tomorrow. That's suspense. But for me, it is that I have put these 2, and you see now there is this V. It is a V created here below, and it is very juicy to put another stitch like this. It's looking like very nice. Let's put one. But I let go of the traction, and you have to visualize a bolus of food coming down. And you can imagine that this is just about it. If I put another suture, the bolus will have an obstruction here. So this is the visual measurement with experience, of course. It's very, very difficult to make it objective. But kudos to Dr. Roy, who has made an objective criteria also. And he will be sharing that with you tomorrow. And but for me, this triangle looks good to leave. Let go of the traction, see that the bolus will be able to pass, and that's the amount of suture. So in case it's a long one, then maybe we would have put another one, but this is just about it, because this is a pliable structure, and you can see without traction, it is filling up the whole vacant area. And
in a large hiatus, more than 6 centimeters, a paraesophageal or a recurrent.
Yes, in that you will need to go, and you will need to, suture up a bit more, maybe 3 or 4 sutures. But again, the criteria remains same.
Would you ever put a biologic or a composite mesh here?
No, I've given up on meshes. I've had to face a lot of trouble. So even with most of them, very, very rarely in very large ones, we use a mesh. Otherwise, we try to avoid the mesh. Right. And it has been proven by studies that dysphagia after this operation is because of a tight hiatus rather than because of a tight wrap. So we need to be, and this is a very important passage which will start working from today evening and tomorrow. So if you create any problem or stenosis here, you'll run into trouble with the normal swallowing mechanism of the patient. So it's a very, very tender level of the operation. Now, once this is done, I'm going to have the traction passed on to the assistant to the right, so that I can see the left side, and you can see now here, the first step would be to create the angle of his, and then take the sutures between the left crus and the fundus of the stomach right up there, take the wrap up. So I'll just show you how it will look before you go back to Dr. Palnivelu. Give me the
highest point of fundus to left crus to accentuate angle of his.
Correct. Absolutely.
And then you, like a book, take it across.
Like a book.
I'm just going to request you to show us your markings of how you take it to the right of the esophagus and left of the esophagus.
So this is how it is going to come down with the recreation of the angle of his. This is the left crus, which you can see here, the sutures. So the suture is going to come here, then there, then here at the top, and then this is going to come forwards in a very graduated manner, there and there and there, like that.
So on both sides of the esophagus you will suture, and then last
both sides to the crus.
Yeah, but we'll be watching you.
But when you have, so now this is an operation which is made after a, no, just give me this, give me this, is after achalasia surgery. So there you have a opening with the mucosa pouting out, and there 1 or 2 or 3 bites are actually with the margin of the esophagus, with the myotomy on the left side. Here we do not have one, so we don't need to, because that helps to keep the myotomy open.
Right.
So we'll just start.
But I have a question for you.
Sir,
That in essence, we take at least one suture through the esophagus.
yeah, I will be taking it. Yes.
Achha, so here also you'll be taking
Yes,
one?
yes. I will be taking. I will have to take. Otherwise, it will not come through, sir. Suction de do, ye sada nikal lete hain ganda. Yes, please do.
Dinesh, please shift us back to Palnivelu sir's OT.
जो पहले
Audio
वो
to
liver
Dr.
का था ना
Palnivelu.
गिरा हुआ, वो पड़ा हुआ.
Yeah, Gem Hospital, please talk.
Hello.
Yes, sir. We are watching you, sir.
Yeah,
Yes, sir.
I'm applying a blue cartridge across.
Yes, sir.
I'm looking at the upper limit, whether it is includes artery or not. Careful. Otherwise, the clipped artery should not cut. And that silk helping us to
left hand
and long arterial stump. And also, I'm adjusting the staple as laterally as possible.
No.
And this we have to apply the stapler in a graded manner, taking 2 minutes, slowly, gradually occluding that one, and then finally have to. If we go on faster like any other bowels, see, I'm still including more pancreas on the right side.
Any specific stapler number, sir?
Should not be there, and the graded occlusion is
Not a rotation element.
It is 2 minutes
Not-
room, that is we follow.
Sir, stapler number you are using for this pancreatic resection?
Pardon?
Which stapler are you using?
This Ethicon, Johnson, and this 6 centimeters echelon. And yeah, and this is a very good stapler for pancreas. And in case we also as a Covidian, that one you can't occlude and keeping it. As you fire it, you have to fire, no. So that's why this is I prefer for pancreatic division as echelon, and 6 centimeters single cartridge is the best way to cut. Not to, by one cutting it, it will be more. And say I'm waiting it 2 minutes. 2 minutes not to be graded, finally 30 seconds. Now start firing it. And so each fire 2 centimeters, you all know, that is postgraduate level. And finally look at, and some should be without laceration. That is the principle of making it. If no laceration, leak is not there. And laceration, then we have to over. So now you can look at distal end. And the inferior vessel is a cut, it is bleeding. I can put a clip, but pancreas is a very nicely staple. And if we divide like this, and we don't see leak, that is. Otherwise, distal pancreatectomy leak, pancreatic duct leak is more than the Whipple. And that's what the literature says. And now, this is vessels is a clipping it. Oh, it's slipped.
You will not suture the stump, sir?
Pardon?
You will not suture the stump?
No. And laceration, yes, I suture. And no laceration, avoid suturing. And that makes very important. That's why staple technique is the best. Initially, studies say slapling or harmonic division suturing, same pancreatic leak. But if proper apply pancreatic stapling, no leak. That is where now we are. That is very important. See the stump nicely, pancreatic duct, everything is included. And I don't see any cases this duct leak.
So would you ever put a serosal patch with the back of the stomach, sir, in this situation?
You can, that you can do it. Whatever the tomental or patch is there, you can. But no need to suture it.
Yes, sir. Over sewing should not be done as a routine. That is your message.
Yes. No need. But division is the one has to follow very nicely. That principle is more important than whatever you do over sewn or whatever you do omental patch, that leak will be there.
Sir, do you put glue any time after stapling?
Yes, if it is laceration and suturing fine, then I'll glue. But the studies have shown not much. I was using it almost for almost 10 years. I have not used. Previous I have used a few cases. But study says glue nowhere shown difference. That means I buy unnecessarily costly solution for without evidence.
So laceration is your only what you see visually with the
Yes.
magnification.
Yes, magnification, you are seeing pancreatic laceration, then oversue it. Oversue with the patch. And if no laceration, don't do any attempt unless that arterial clipping for the blood vessels.
Okay.
That way, now the technique, both Whipple's and distal pancreas, they have improved. We don't see leak even Whipple's. And that is changed a lot. Technology
Yes.
also helping us a lot way. And
Yes.
this case I would have finished easily in 20 minutes coming out. But just one attempt, and Roy has given a chance to show, okay, the dissection, how that is being preserved. We can be attempted, I had shown, but unfortunately could not proceed beyond. It is not
No, but-
safety. Safety is more important than, that's it.
Absolutely, but it was a wonderful dissection, the splenic artery and the veins, everything. I mean,
Just you want to be sure, no? And trainees are there, they should look at this. So now, hemostasis, we have to check it by complete. My friend Horatio, even don't put a drain. This is, but still, I keep a drain. 48 hours, take it out, send the patient, discharge second day.
Okay, but
Horatio, don't put an even drain. He says no leak at all. Why should unnecessarily that is way?
No, but if you put a drain, do you check the drain amylase before removing it?
No. If unless sufficient quantity is there, why do you want to check it? I'm not getting it adequate quantity nowadays. No need for it. That's why drainage also single incision distal pancreas. I don't put a drain. But now I should do it. But PGs trainees are there. I have to show them drainage too. That is way otherwise. This is a window. Initially we created in the mesocolon. You can see the deflection. This particular case, and also has got a gallstone, and the patient wanted to have a cholecystectomy. And I'll be moving towards the cholecystectomy now. If you are interested and see, you can see. I'll be taking the specimen out at the after cholecystectomy only.
Okay.
And
Thank you, sir. It has been.
It is want to see gallbladder, you can, but it is I will be operating gallbladder from the left port itself.
Okay.
Yeah.
So you're not going to put any additional ports there.
Maybe one trocar, maybe 1 5 I think if I look at gallbladder, then I will.
Now you can
No,
go a
we
little
have
bit
all
on the
enjoyed
left,
this
yes.
surgery and we'll
Now I
continue
have to
watching
see.
you.
See that now if it is
Yes,
one below one, so that
tilting
above
the
this
right side of the
section.
patient has to tilt it now. Still the left side up patient.
Yeah.
I'm
Yes.
trying with the port and
got caught in my.
So in the meanwhile, sir, thank you very much. We have seen this procedure and we'll continue to watch the gallbladder also for some time. And can we ship the audio to Dr. Pavanendra Lal's theatre now?
Very nice. Thank you very much, Roy, and appreciate for all the programs happening it. And I'm also getting the side. I'm able to look at Pavindra Lal the way he is operating it. I'm happy about it. During my surgery, also looking at the other OT how it is going.
Yes,
Very
yes,
nice.
yes.
Good demonstration, Pavindra Lal. And
Thank you, sir. Thank you very much. Thank you. Thank you, sir.
Thank you.
No, needle.
Thank you. Can we ship the audio to Dr. Pavanendra Lal's theatre?
Yes, sir.
So we've just taken 2 starting sutures with the esophagus to recreate the angle of the extentuated angle, which is one of the important anti-reflux mechanisms. And ye kata hua pichla?
So
And
you generally put 3 sutures here.
2. And then we will now start with the crural sutures to accentuate to bring the wrap
Even higher up.
even higher, right up. It will go right up to the hiatus, actually, the upper part of the hiatus. The sutures will go all around there.
But you have never felt the need to take the short gastrics in an occasional case where.
Sir, I started the career with the classic Nissans with division, and I found early symptoms immediately in those patients. with bloating and difficulty of eructation. And I also struggled with the, because you're doing hiatus work and you're doing something else completely. You are dividing the blood supply of the stomach. So you are actually definitely interfering with a large part of the stomach's normal anatomy. So I quickly then, when we read, we found that there is a Rossetti modification available, which preserves. And then very early on in my career, I moved on to Rossetti. And then in the process did Tupe also, did Dor also, published all of them. All our publications are available. The small volume, because we work in a government institution, so they all research happens as part of the is it right? गलत ले लिया क्या मैंने? ठीक लिया ना? ये इसके अंदर आ गया. In a government institution, there is all thesis work which becomes the opportunity to do such research. So the volume is always limited by the number of cases that you can do in 1 year for a particular study. But we continue to do, then OT numbers and the amount that is available for laparoscopic surgery also becomes a constraint. And you don't have the liberty like Roy that you can just keep operating morning to evening in all the theaters and do 15, 16, 20 cases a day. I wish he could employ me here.
Oh, my.
Or actually start a Zen hospital in Delhi.
I want to welcome Dr. Thakur, who used to be professor of surgery at BJ Medical College.
Hi, sir. How are you? Yeah, I know.
Medical College.
Yes, I know.
So Dr. Thakur has been a very close, I won't say friend, but a mentor to me, and he's been coming here for last 10 years for all our.
Oh, wow.
Dr. Thakur, sir.
Hello,
come forward.
Very much grateful that Dr. Raya has been calling for last 10 years. I really see like a Pandharpur Yatra. I am visiting this place. So last year I didn't come, it was not held, but then every year, and I saw to it when I was in Pune, that my all faculties and the residents used to come. So, and a really great feast, lot to learn, and how to see the surgeon growing in their career. And because a lot of medical legal cases and the people are against doctors, I think you should learn the better techniques and try to overcome the fallacies and come out a successful surgeon. Thank you very much, Roy.
So in fact, the person assisting is your student. She's now our FNB. She's done her MS in BJ Medical with you, Dr. Sneha. Yes, now.
Great, sir. Great. Yeah.
So Pawan, talk us through these planning of these sutures on the.
Yeah. So basically, what I'm trying to show is first is just accentuation. So this left side sutures are all accentuation of the hiatus, and slowly you start coming on the anterior wall so that you are able to get a little bit of the stomach to start coming anteriorly, because you have to fold it like a book. So it is for this reason that
nicely shown, Pawan. And you never put a Nathanson's to lift the liver. You are always happy putting a needle.
Yeah, it's because I have made more injuries while putting Nathans. I'm very, very bad at it. I'm very poor at it. Really, I have to concede. We have got all types of Nathans, but Nathansons in our theaters, and then it doesn't. By the time you fix it up, you've already. I take around 15 minutes to put it up. You take 5 minutes, so it's worth it for you.
So we have a question from Dr. Sukumar Maiti from Madinapur. What is the suture material that you're using?
Yeah. Suture material is Ethibond, which is polyester. It is the strongest and the toughest material available to the surgeon today. It has got immense, beautiful handling, which you can see. And only thing is that because it is slippery, it has you have to take multiple knots. You see, I just saw you took 3 loops. Normally you take 2 for monofilament. You have to take 3 to begin with, because otherwise by the tension it will just slip out. And then each throw I prefer to take 2 in one go straight away like this. each throw. So then I don't have to do multiple 5 or 6. I can finish it with 2. So, and you see one thing also that I'm showing you is that I'm using the reverse C loop sequence all the time. And it is just to show all the trainees that it is possible to do this in your routine setup very fast, because you just need to make it a point that you have to do it like that. That's all.
I think the PG should be watching the C and the reverse C. That is the key to suturing. Dr. Mehti has been executive committee member of ACRSI. He's a very busy surgeon in West Bengal. So the person who asked this question.
Yeah.
If you don't mind, can I shift to Dr. Pallivellu?
Yeah, sure, sir. Sure. Yeah.
Dinesh, can we shift to Dr. Pallivellu's audio, please? Dinesh?
Hello.
Dinesh, yes, sir, we can hear you.
Yes, sir. Yes, sir.
Yeah. And I'm working from all the trocar section, 1 5 mm made it extra. Now
Yes, sir.
clipped a cystic duct with the 2 clips, and I divided the artery. I have to put a 1
Ready, yeah. Next 2 already.
We're placing 1 more clip for the junction of the infundibulum cystic duct. See, it is all going from the left side there, hitching.
Pallivellu, sir, Dr. Thakur, Dean of Solapur Medical College, has joined us, sir, as moderator.
Oh, okay. Welcome. Yeah.
Sir, excellent. I was the first trainee to come to you in 1998 from Maharashtra. So 3 of us, we joined you from BJ Medical College, and we still follow your 2-hand technique. And all the trainees we are trained under your guidance and capability. All are doing a 2-hand technique nowadays, sir.
Thank you. So now I'm going to strip the gallbladder from the liver bed and never use a ligature or a harmonica. This is space I already have. I'm using it.
Ye wala.
Yes.
Hook enough. Hook or spatula, that is enough. After taking this gallbladder, both will place in the same bag, and both spleen.
Now the curvature has started.
Yes.
See that? This was an important
Sir, excellent
stitch.
demonstration, sir. All the delegates have enjoyed. We are getting a lot of feedback from across the country and 2 comments from Bangladesh also, sir. Everybody has enjoyed your surgery, and I'm truly grateful for transmitting this surgery to us here, sir.
Thank you, Roy. Thank you very much. Now I have to place in the bag and take it out. Hemostasis of the gallbladder bed is good, and still be irrigated.
So in fact, the next case is going to be by Senthil. He's going to show laparoscopic hepatico-jejunostomy live from here, sir.
Oh, okay.
So, and with your permission, sir, I'll stop the video from Gem and start.
Thank you very much. Thank you. Bye.
Thank you, sir.
And
Truly appreciate it, sir.
Yeah.
Thank you. Dinesh, shift the audio, the video feed to OT1. The video feed to OT1 and the audio to Dr. Pavanendra Lal in OT2.
Yes, sir. OT2, can you hear us?
Yeah, we can hear you.
Yes, sir. Continue, sir.
Another puncture.
OT2 is live.
Yeah, we can hear you. Over to you, Pawan.
Good afternoon, everyone.
खुल गया.
Am I audible?
Which is the छोटे वाला?
Yes, ma'am. Yes.
ये वाला.
Good afternoon. I am Dr. Abha Gune. We have a patient, 30-year-old female on table, who had right iliac fossa pain for the last 3 to 4 months, off and on. On barium study, we found that there were filling defects in the appendix, which was suggestive of appendicitis, and we have planned a laparoscopic appendicectomy for this patient. I'll just tell you so far what I have done. I have put 3 ports, 10 mm umbilical port for camera, which has been shown by Dr. Vishakha, 2 5 mm ports, one in the suprapubic region, 2 fingers above the ramus, and the second port is in the left iliac fossa, 2 fingers above and medial to the anterior superior iliac spine. Now the second port which I put in the left iliac fossa, now this is the method that we usually follow. Ergonomically, this is what I find easy.
We'll use it.
Sectorization.
No
instead of triangulation method.
That is the whole.
What I have done is
ज़्यादा
it is
ज़्यादा
found in the
गंभीर नहीं
bowel
बोलूँगा.
for any pathology in the small bowel. I've seen the uterus. She was a
Yeah.
female patient. I've seen pelvis.
Sir, can I mute you?
क्या हो गया दिनेश?
And
Sir, there is a voice is coming
अच्छा,
from
ठीक है.
OT1.
41, ठीक है.
Yeah, ma'am.
So we'll just shift the audio to OT1 for some time, where Dr. Abha Gune is going to audio 1, OT1 में shift करो ना.
Use, start cauterizing the meso appendix
Yes,
from the
ma'am.
tip. by using a
Ma'am,
bi-
just ma'am,
energy
1 second, ma'am.
Yeah.
Sir, ma'am is speaking something. So let ma'am complete and then I will shift you.
मतलब किसके पास है
I will
ऑडियो?
start cauterization
हवा में
of the meso appendix from the tip by using a bipolar energy source.
ला देखो.
Dr. Abha,
Yes, sir.
these are the ports that you have always worked with, or you've changed with time?
No, sir. I've started using these ports right from the
Right
beginning
from the
when I had a great opportunity to have my fellowship with Dr. Roy Patankar.
Yeah, I know that.
And
He's standing right behind you.
nice, sir.
But if you find a retrocecal appendix, then
I would like to change my port position from left iliac fossa to right iliac fossa, which becomes
But
easy.
do you ever get the need to put a port in the right subcostal region?
Right subcostal,
For
I
a
haven't.
very high appendix going right up till the liver and things like that?
I haven't yet done that. I have never encountered an appendix being subhepatic. But yes, in the literature, it's mentioned that you can put a port there, or else even you can put a port in the epigastric region. ये bipolar नहीं होते.
सोचे कटिंग दो यार, एक काला ये धागा निकालेंगे.
Now, in a female patient, it's always better that you see the pelvis properly, see for uterus and ovaries, so that you don't miss some pathology.
But in cases like this, if you have a very long meso appendix, why not go closer to the base and coagulate there? And
so usually what
you
happens?
always start at the tip.
I usually do, sir, because what happens if we leave a part of meso appendix on the appendix, then while the retrieval of appendix, it really becomes difficult to get the appendix from the port.
Out. Yeah. Makes sense. Makes sense.
ये लो ऐसे रखो.
हाँ, वो कह रहा हूँ.
लो.
Various energy sources can be used. Now, I am comfortable with bipolar, so I am using this, but you can use a monopolar energy source in case you don't have bipolar at your center. Some people do also use harmonic for doing the dissection.
What is the disadvantage by using the monopolar?
Now, with monopolar, when you come near the base of the appendix, it's quite close to the wall of the cecum, and the lateralization of the thermal current is high. So then you have to be very sure while doing the cautery with monopolar current. So that's the advantage of using a bipolar current.
Excellent.
Scissor देना.
So do you think you should finish the bipolar completely and then go to the monopolar one?
Yes, so that's a good idea. I'll do that.
So that gives you a chance to trim it properly so that it comes out easily. No? Go all the way to the base.
And that will save time also.
मैं ज़्यादा करता नहीं हूँ actually ना instruments actually.
Right.
I would rather take it. यही आ रहा है ना. This is not yet been divided, ना.
Any particular precaution you will take when you move closer to the base of the appendix?
Yes, I'll have to hold the appendix in such a way, so that I can see behind. I should be able to see the cecal wall as well, the posterior.
Anterior is not that important. But yes, it will be somewhere there.
But do you think using a bipolar is pretty
Yeah,
mandatory
I
near
did
the
not
base?
take, did not divide.
It's
आ
not
जाएगा, वैसे आ
mandatory, sir,
जाएगा,
but
जाओ दिखाओ.
what happens is if you are
दिखाओ,
using
needle
a
दिखाओ.
monopolar current, then you will have to give a pulsating current rather than a continuous current and be sure of the cecal wall. Not all the peripheral centers will have bipolar. So
नहीं मैं है मेरे पास एक इससे चल जाता है काम किसी किसी जगह पे we find it
here and bipolar
that
only
it
at the base
is required otherwise
for the sake of speed
लिवर
or
ऊपर
something
करो यार
like
लिवर
that?
मेरे पास हाँ लिवर नहीं आना चाहिए प्लीज नहीं 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 हाँ, देखो
yes,
नहीं,
sir,
थोड़ा
it can be
रिलीज
done.
करके दोबारा से आना पड़ेगा रिलीज करके रिलीज करो स्लाइड करो इधर को लेफ्ट साइड में लेफ्ट 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 नहीं नहीं इधर इधर हाँ ये वाला हाँ, इसको उठाओ शाबाश
Nothing wrong. Good technique.
Now slowly you have to move your left hand down so that you pull the appendix properly up as you're coming close to the base of the appendix. Make sure, ask your assistant to turn around the camera so that you can see the posterior side as well.
नहीं आप पे यार ये लिवर ना ठीक से नहीं आ रहा है यू आर ड्रॉपिंग इट डाउन टू मी ना हाँ ऊपर उठाओ शाबाश यस चलो ये नीचे रखो ये वाला हाथ नीचे रखो हाँ
Sometimes you can go straightway near the base, make a window and clip the vessel. Some
Yeah,
people like some surgeons do that. That is one technique that you can follow.
one
Harmonic is also used by some surgeons.
one one
So we are very close to the base now. Just a little bit of mesoappendix.
यही है ना
Very nice. Now this is the fold of trees. If you're using a Maryland, then change the grip so that the tip is downwards and the base does not touch. The base of the Maryland does not touch the cecal wall.
Dinesh, can you hear me? Dinesh bhai?
Yes, sir. Yes, sir. I can hear you, sir.
Do we have Goa online now?
ये कौन है
Please check if Goa Medical College joined us. They were to join us at
यहाँ
1:05.
हमारे
Just let me check, sir. 1 minute.
Yeah, Jude Rodriguez was to join at 1:05. Just check and
Yeah,
tell us.
sir is already joined. Sir is already joined. You can talk with us. Sir, just can you
Give him
unmute
audio
yourself?
rights. Let him ask. Dr. Jude Rodriguez, can you hear us?
Yes, yes. Dr. Roy Patankar, how are you?
Very well, Jude. Nice to have you online. And thank you for getting your department online at GMC. For the sake of the audience, Dr. Jude Rodriguez is professor and head of surgery at Goa Medical College in Bambolim. It's one of the most busiest departments in Western India. We've had the pleasure of having two of his former registrars, Dr. Suraj, Dr. Jimmy, and Dr. Vardhan, working with us, and they've been excellent fellows with us. Jude, I hope you have good audio and video transmission.
Yes, yes, yes. We have got an auditorium which is relaying whatever that is going on. We have about 40 participants, means 40 people who have come, 44 people who have come for watching your surgeries. 40
Wonderful.
surgeons, 44 surgeons. Yeah.
Our next
Dr.
case is
Patel is here along with me.
Okay.
Rajesh is with you, Rajesh?
Yes, yes. And
Dr. Jude, feel free to ask questions to either of the two surgeons.
yes, yes, yes.
So our next cases after this, one will be a difficult gallbladder, one will be a laser hemorrhoidoplasty by Dr. Niranjan Agarwal. And in the third OT, we will start a laparoscopic subtotal gastrectomy for a CS stomach. After that, we have a completion proctectomy with ileoanal pouch done laparoscopically.
Dr. Roy. Hello.
Yes.
I
Yes.
I just want to ask one very technical question. We've been doing Nissen fundoplication for a very long time along with toupee.
Yes, Rajesh.
What is the role of doing a heels fundoplication or adding a heel to a Nissen? Something like a hybrid procedure.
Yeah.
Because almost 2 decades we have seen that migration is becoming quite common with Nissen. So would addition of 1 or 2 sutures to the paraesophageal bundles like a heel stitch would further
I think for the sake of the PGs in the audience, what Dr. Rajesh Patil is referring to is a paper published in the American Journal of Surgery calling it the hybrid Hill Nissen repair, where the OG junction was reconstructed by suturing the phrenoesophageal ligament to the crura. This is originated by a surgeon called Lucio Hill.
Yes.
Critics of the Nissens believe, as Rajesh said, that there is a concern with. I always feel there is a trade-off between the power of the operation versus the morbidity. Like the Nissens is the best anti-reflux operation, but has gas bloat and dyspepsia as a possible problem. So the DOR probably is a weaker anti-reflux operation, but has the least morbidity. So the trade-off is between efficacy and morbidity. So there was a group of surgeons who actually advocated combining a Rossetti Nissen with a Hill repair, where you take sutures between the phrenoesophageal ligament and the crura. But we have tried doing this for a short while in 2011 and 12, but really gave it up because we didn't find much benefit. In our department, almost 70% of our patients are two-phase fundoplication, Rajesh. 25% are Nissens and 5% are DORs.
Yes.
For the sake of the audience, Dr. Rajesh Patil is a very busy laparoscopic surgeon in GMC. He's a professor of surgery at Goa Medical College in Bambolim. Thank you for joining, Rajesh. We can see you here from this side. You and Jude, both seen. Nice to see you guys.
Thank you.
Thank you. On the right hand side, we are seeing a Karl Storz. Which instrument is on the for the traction? Used for the traction?
That's it's a Karl Storz instrument and it's a home surgical instrument. I'm a poor man, Jude. I can't afford Karl Storz. I only use home surgical.
Oh.
Another question is on IPOM. No? Nowadays we are doing IPOM Plus and it's considered almost a gold standard. Hello.
I think the jury is out, Rajesh. I'm going to ask Dr. Pramod Shinde this question. Next to me is IPOM Plus the gold standard. Is the question asked by Dr. Rajesh Patil, who's professor of surgery at Goa Medical College.
But because nowadays after 2 decades we are seeing certain complications of deformation.
Yeah. See, IPOM Plus. So IPOM surgery has been the gold standard of ventral hernia repair when in the last decade, but IPOM Plus has now come into vogue and it is now on its way to becoming the gold standard, because the whole hernia fraternity and all surgical fraternity is now going towards actually the abdominal core health as a concept. So therefore, although according to guidelines, less than 2 centimeters defect need not be closed and you can do an IPOM repair without closing the defect, but the world over is moving on to having an intact midline, and therefore IPOM Plus, especially the plus part, is on its way to becoming a gold standard now.
Okay. In the meanwhile, we have
I answered the question?
Yes, sir.
Are you able to hear?
Yes, sir. Very clear and loud. So, but where do we place
Dr. Abhay is also wanting to say. Yeah, tell me.
Where do we place a retrorectus repair and an IPOM Plus?
Okay, I will answer your question, but I think Abha also wants to say something, and she's already demonstrating putting a loop around the base. Anything you wanted to say?
Yeah, I just wanted to say that we have made the loop from catgut, and we are now going to ligate the base.
Nicely done.
Thank you, sir. Thank you.
You use Vicryl also sometimes, or you mostly use catgut only?
So I use Vicryl if I find that the appendix is gangrenous or the base is a bit friable. In that cases, I do use Vicryl.
Okay.
So
and
we have
any
a
occasion
question.
you use suturing? Yes, tell me.
Yeah, so we have a question from Kaivalya Sauji from Belgaum. Can we use a suprapubic camera port instead of intra-umbilical port for vision?
Sorry?
Can we use a suprapubic port rather than a supraumbilical port for camera?
Yes, you can. Yes, that is a way you can do that. I'll show you how to tie this knot. So first is you form a loop and take the short end of the loop, of the thread through the loop. Keep adequate length of the short end so that you can turn it around as required to form the knot. So one loop that you formed, then you will turn the short end thrice around this knot. This is 2 times, and the third time. 4th time, I'll pass it through one of the ends of the loop and take the knot out so that I lock the suture here.
This is a classical Roder's knot.
Yes. Yeah. Now, very important is that you first try to slip it here up and down so that you know that the knot will easily pass inside and get tied up. While using catgut, it's always good that you apply a bit of lignocaine gel at the tip of the knot so that it slides well inside.
As she's loading the suture, I'll answer the previous question of ETEP. Now, ETEP, the ETEP is an approach for a retromuscular mesh placement. And again, here the world is again moving towards placing the mesh more and more in a retromuscular or mesh outside the peritoneal cavity. Okay. And that does not mean that IPOM and intraperitoneal meshes are dead. It still forms, the majority of the world is still doing surgeries, ventral hernia surgeries by using dual meshes. But now, with more and more research coming into play and more techniques having been evolved, the world of hernia is moving towards placing the mesh outside the peritoneal cavity in so many planes that are available, right from onlay subcutaneous to a retroperitoneal mesh. And the retromuscular mesh has been shown in many RCTs and meta-analysis to have a better profile of outcome when the mesh is in the retromuscular plane. Although not yet termed as gold standard, it is on its way to becoming a gold standard again.
So now I'm putting my second loop. Ask your assistant to hold the appendix upright so that you can easily put the loop. And I'm done with this loop now.
How much is the distance you would keep between the two?
At least 2 to 3 mm.
Okay. And would you be putting a distal loop, or you would divide between the two?
I'll not put a distal loop, sir.
So single rotor is sufficient on the
sir. I'll
patient
be
side?
putting 2 on the patient side.
Okay.
On the specimen side, I'll not put a loop.
Okay. Nice.
So we have a question for Pramod Chinde sir from Dr. Sachin Jama sir. For the case selection, depending on whether to go for IPOM plus or the retromuscular or retrorectus procedure. How do you
repeat? Can you repeat the question?
How do you select the cases preoperatively between IPOM plus and retromuscular or retrorectus repair?
See, small hernias which are 1.5 centimeters, 2 centimeters, up to 3 centimeters. IPOM plus is what I would do, because doing an E-tip axis is too much of a procedure for a small hernia. But for smaller hernias, we also have other options. But in case if I have to do a laparoscopic approach, rather than E-tip, I would choose an IPOM plus for a hernia which is less than 3 centimeters. But in that space of 1 to 3 centimeters, we have many other procedures, including a preperitoneal repair, laparoscopic, okay, robotic. We also have subcutaneous repairs, and obviously you've seen Vishakha do an a ventralate patch also. But for me, E-tip will be taken up for larger size hernias, at least 4 centimeters and above. Because E-tip entails a longer time, a more extensive dissection, and not really worth it doing for a very small hernia. Have I answered your question?
Yes, sir. We have a question for Dr. Abha. Can we use a Hemlock clip for ligating the base of the appendix? It is from Dr. Kaivalya Sauji from Belgaum. They say that they do it on a routine basis in their institution.
I haven't done it, so I won't be able to comment on it, but I've seen people using a stapler. I don't know about hemoclip. Maybe Dr. Pramod Shinde sir or Roy sir can.
I think general thinking is when you have a organ which has motility and peristalsis, you wouldn't want to put any kind of clip. The Americans and Europeans, for very bad appendicular stumps which are wide, do use laparoscopic staplers to close this. But I really feel if it's a very wide stump, we should transfix it or tie it. I would not advise using Hemlock clips or staplers on this as a routine. I think I just want to also place on record my gratitude to Mr. Dinesh Pal of Digital Info Media. He's done an excellent job. We have feedbacks from almost 35, 38 centers with excellent audio video quality being transmitted. Dinesh, take a bow. You've done an extremely good job, but you have a lot of hard work in the next 2 days.
Thank you, sir. Thank you. Thank you, sir.
So I think Abha is almost finishing a procedure. I'm going to ask Dinesh to stop transmission from OT1 and shift that camera to Dr. Niranjan Agarwal in OT3. Stop the video from OT1 and shift to OT3.
Okay, sir. Done, sir.
So audio can go to OT2 with Dr. Pavninder Lal, who's just finishing his door, and stop the video from OT1 and start OT3, where the laser hemorrhoidoplasty is being demonstrated by Dr. Niranjan Agarwal.
Yeah, OT3, you are live. Just unmute yourself.
Thank you, sir. नहीं पार्टी नहीं मिल सकती और एक मुझे टाई ये लेना पड़ा.
OT3, we can hear you. Continue.
From OT3?
Yes, sir. OT3, sir. We can hear you, sir.
So just to add a little flavor to the workshop, we decided to have 2 laser cases in anorectal surgery, and demonstrating this will be Dr. Niranjan Agarwal, who is a close friend of mine, is part of our team. He is also president of the Association of Colon and Rectal Surgeons of India and a senior consultant at Bombay Hospital. And today we are going to show a laser hemorrhoidoplasty, and tomorrow we'll show you a laser fissurectomy and sphincterotomy. So welcome Niranjan to our Zen workshop, and he's going to show you a laser hemorrhoidoplasty for a patient with 3rd degree hemorrhoids. We'll be using a BioLitech machine, and I'll let Niranjan talk to you about different kind of lasers and what type, radial, bare tip, what to choose.
Good afternoon, everyone. Am I being heard? Yeah. Good afternoon, everyone. At the very outset, I must thank Roy for making me part of this workshop. It is always a great show from Zen Hospital, as I call it. Table upar karna thoda.
Haritha, you have good audio video of the hemorrhagic case?
Yes, sir. We can hear. We can see the clearly, sir.
Excellent. So you have large hemorrhoids which you can see here. So first, I'm going to ask you a controversial question. Narendra, this patient, you would do a laser hemorrhoidoplasty or you would do a stapler?
So, Roy, the choices are very open. You have to discuss with the patient. This is actually a grade 4 hemorrhoid. If you see, it's a prolapsed hemorrhoid outside. In such kind of hemorrhoid, your options are: one, your conventional hemorrhoidectomy; second, you have a stapler surgery with you; and third is a laser surgery. Each has got its advantages, disadvantages, but the long-term recurrence rate with staplers are quite high, and therefore most of the people across the world, they usually try to do conventional surgery for grade 4. Now laser is a new baby which has come in. People are showing more interest, and there are slowly more studies coming in which are showing recurrences, normal recurrences in grade 3 and grade 4 together with laser are slightly higher compared to conventional surgery. But the short-term advantages of laser are definitely much more in terms of being minimally invasive, early return to work, being lesser painful. Yeah.
So there is a second question I'm asking you is, are you going to do a standalone laser or you're also going to ligate the hemorrhoidal artery?
So standalone laser is not a good procedure. In fact, it causes more recurrences. If you mix laser with a hybrid procedure like a hemorrhoidal artery ligation, then the results are much better. So what I am going to do is I am going to do a hemorrhoidal artery ligation combined with laser ablation of the hemorrhoidal masses. So the first step what you do is you put in a gauze piece and withdraw, so that here actually you can see it is grade 4 already, but otherwise if there are smaller hemorrhoid under anesthesia, they prolapse out when you do this procedure, and thereafter give me a proctoscope.
So what we do here is we digitally feel the vessel.
Yeah.
And previously people were using Dopplers for identifying the artery. Yeah. What is your take on this?
So there has been a study and published also by Dr. Kamal Gupta and Dr. Ramakant, where they have said whether you do a Doppler guided ligation or you do a finger guided ligation, the results are practically same. It's no difference between the two. So I will be doing a finger guided ligation of the hemorrhoidal artery. I will show you how to palpate them. So these are the three big masses which you can see. A half cut proctoscope can be inserted.
Also, there is a lot of hype about all these various types of lasers, 980, 1470. There's a new one, the 1800 something. How do you think there is an advantage or disadvantage of each of these lasers, Nijanjan?
So the best laser for proctology is 1470 as of now, because the depth of penetration is around 1 to 2 millimeter, and also it uses water as the evaporation medium and not blood. The 980 uses blood as the evaporation medium. So 1470 is the ideal one which you should use for cases in proctology.
I'm going to ask the biolitech person in OT. You have recently launched a new laser with a higher wavelength. What is your take on that?
It's 1940 nanometer wavelength, and it has penetration depth of only 2 millimeters, whereas in 1470 penetration depth is about 5 millimeters. Yes, 1470.
So today we'll use a conical tip fiber. There are various fibers possible with a laser.
I'll just show the anatomical landmarks.
Show the anatomy first, yeah.
So this is a mucocutaneous junction, one can see. This is the dentate line. These are the hemorrhoidal tissues, and the artery will be palpated just around 2 to 4 centimeter above the hemorrhoidal tissues. You can see over there. My assistant can palpate and confirm.
Yeah. Niranjan, just give us a minute. I'm just going to shift the audio to Ponandal Lal for 2 minutes.
Sure.
Dinesh, shift the OT to OT2, audio to OT2, where Dr. Lal has finished his procedure. Let him have his final comments, and we come back to the laser hemorrhoidoplasty.
Okay, sir. OT2, you are live, sir. You can speak.
The last bit of the doors. This is the the crust which we had repaired. This is the repair of the entire stomach being brought anteriorly. I'm just sucking out a little bit of a wash I had done so that I can show you from the little ooze that we had from the liver.
Yes.
So I hope you have been able to see it while we were doing it, that we went. That's the whole door. So we created the left angle. Then we came, there is something on the screen, camera. Can you just clean it for a moment? I'll just stay there. Please give me a minute. I'll just wind up in a minute. Just cleaning the scope.
Excellent job on what is the post-op protocol on these patients? Riles tube, feeding, liquid,
Yeah.
solids? How does it
No
work?
riles tube ever.
Okay.
And we start them always after the next next day morning.
Okay.
With clear liquid.
Okay.
And they go home after 2 days on clear liquid diet for a week.
And post-op propped up position, antiemetics.
Absolutely, absolutely. All antiemetics is a must. So you see this was the right side, left side done. Then we brought it up over the crus and then to the right crus. So I think it looks like a
Excellent job. Excellent. Very
satisfactory job. Thank you so much.
Very
Thank you everyone for your patience.
Thank you. Great. Thank you, Dr. And we can now shift the audio to OT3 where the laser hemorrhoplasty is being demonstrated. Over to you, Niranjan sir.
Yeah. So I just ligated the left branch, left posterior branch of the superior humeral artery, and now I'm palpating the right posterior one. You can feel the pulsation over here. It is not mandatory that they will always be at 4 o'clock or 7 o'clock. You may find slight variation here and there in the location. Switcher, please. So this is finger guided ligation. One can use a Doppler, but it has been shown to be of no extra use. Hold this minute.
So we have a question from Dr. Suneet from Nagpur. He wants to know if there is any need for any additional procedure after the hemorrhoidal artery ligation is done.
We will be doing a laser hematoablation, no?
He wants to know since the after the arterial ligation is done, the hemorrhoids are bound to shrink. So wants to know if the additional procedure needs to be done.
Yeah, see, the hemorrhoid has got two components within it. It is not only the hypervascularization, there is an element of prolapse also. So this ligation will only reduce the hypervascularization. For the prolapse, you need to do the laser. Okay. So for the prolapse, you need to do the laser ablation, which will fix the prolapse cushions to their bases and lift up the cushions. Doing only hemorrhoidal artery ligation, or whether it is Doppler guided also with the DG Hall machine, we have all seen that it has got a very high rate of recurrences. You know, in fact, only they added RAR to that afterward for the prolapse element, but with laser around the fixation of the prolapse cushion is much better than just doing a mucopexy. So third is the 11 o'clock hemorrhoid. Same procedure what we did at the other two. You can find one or two extra pulsating vessels which you may ligate.
Sir, Nitish Jawar here.
Yeah, Nitish. Hi.
Would you combine a RAR procedure with this also after you have fired the laser, or you don't do it?
So it all depends upon how much the prolapse is remaining. You know, many a times you don't find the piles to shrink immediately on table. They take some time. But if the prolapse is too huge after laser, also you can do mucopexy in such kind of patients. But that's very not too many of the patients.
This is not something which we do always, right?
Always, right? Yeah.
So we have a question from Dr. Naresh from Surat. Sometimes there are incidences where the hemorrhoidal artery runs circumferentially rather than vertically. So how would you tackle that?
circumferentially, but still the three cushions are supplied separately. What we are main interested in ligating the vessel which is supplying the cushion. So you palpate those and you ligate those and ablate, then that should be enough. However, all said and done, because of the anastomosis and the circumferential vasculature, recurrence rates are whatever recurrences you get, whether it is because of the conventional hemorrhoidectomy or whether it is laser or even stapler, is because somewhere some vessel is being missed, which is kind to hypervascularize the whole tissue again. You know, many collaterals do open up. So on table you decide what you can do and how much most you can do. There is no thumb rule for one and all. Take this. So
this suture, first suture is slightly superficial and the other is slightly deeper.
So we try to take a figure of 8 sutures. When we take the first suture, we pull it up so that the mucosa.
But that is only mucosal, no? The first stitch.
Mucosa as well as submucosa, sir.
Okay,
it is not only mucosa. And then we go slightly deeper so that some part of internal sphincter may be coming into it.
Okay.
So I am trying to feel the other arteries if they are available.
But in case if we also catch a part of the internal sphincter, then would it increase the pain or something like that?
Even if it is part of the internal sphincter, that will be a very small part.
Okay.
So it's unavoidable, sir, many a time.
Achha.
On table, you can see the piles have shrunk to some extent only with ligation itself.
Okay.
They were all prolapsing out earlier. Now they have shrunk. Now the next step will be laser ablation. I am not able to feel any other vessel which is I should be ligating. Jelly.
So we have a question. We have a question from Bridge Banga from Hisar. If the patient has a very large external component along with the internal hemorrhoid, what should be done?
So a very large external component means, again we are saying it's a grade 4 hemorrhoid. So that's what I said at the beginning. You need to discuss with the patient the pros and cons of all the available procedures and let him make an informed choice. Whatever he wants is best. We must explain the recurrence rates of all the long-term benefits, the short-term benefits, etc. So before I go for the laser, let me explain about the machine.
Niranjan, just one more question. In case the patient says, you decide. So what is the best procedure in that scenario which Dr. Banga has asked? Large external with, grade 4 piles. In your opinion, what would be the best procedure?
Sir, if the patient is unable to decide or he asks me to decide, again, I would like to take his family background, his financial background, etc. and the available facilities at my center also. You know, depending upon that, if it is a grade 4 and the patient is a worker, he doesn't want to spend more, he cannot afford a recurrence in future, I would offer him a conventional surgery. If the patient is a worker, he is an office going person and he wants to get back to work faster, he cannot miss. You see nowadays in Bombay, we get a lot of these white collared people. You know, they subah karke sham ko they want to attend work. So in such kind of patient, if they are ready to bear a little extra recurrences, I don't mind offering them a laser surgery. Give me the, show me the machine.
What are the choice of fibers you have for this?
Yeah, that's what I'm trying to tell you.
Yeah.
So in laser in proctology, we have got basically 3 kind of fibers. This is a conical fiber, which is conical at the tip, you can see over there. And this is mainly used for hemorrhoid. The other fiber is a bare fiber where it's a sharp cutting fiber and you can just cut with that fiber. That is usually used in fissure surgery and that will be demonstrated tomorrow to you. And the third is a corona radial fiber, you call it. The tip is quite radial and smooth in front. That is used for continuous delivery in the fistula patients. The mode of current also in this biolytic machine, they have got 2 modes of energy delivery. One is a signal mode, the other is a continuous mode. The continuous mode is mainly used in fistula and the signal mode is for hemorrhoid surgery. The other machines also have called something called pulse mode. In pulse mode, the energy gets break at a particular setting, like for 6 watt, 3 second pulse, then it will stop and then it gets automatically regenerated when you press the pedal again.
Here they have replaced it with signal. There will be a beep after a particular use of energy, and then you will know that so much energy has been delivered. Now the point of these are about the three different fibers. We have already spoken about the wavelengths. Now about the entry in the hemorrhoid cases. Usually people try to enter in the intersphincteric plane. But when you enter the intersphincteric plane, you have to cross the internal sphincter and then go to the hemorrhoid. So while withdrawing, there are chances that you may burn the internal sphincter and destroy it. The best place to enter is at the mucocutaneous junction. Now, why mucocutaneous junction? Because the external hemorrhoid and the internal hemorrhoid do have some kind of communications, vascular communication at the level of mucocutaneous junction. So when you are inserting and withdrawing it from that point, you will be taking care of the vascular anastomosis at that level also. So, chashma lagao. Sorry. Second is how much energy we should be using it after puncture. During puncture, you need a 6 watt 1 second pulse or whatever signal intensity they give. And after that, you introduce your fiber inside, and it has to be a smooth walk. You shouldn't have to be pushed inside. If you are pushing it inside, then there is some obstruction somewhere. If it just walks inside into the loose areolar tissue, you know you are in the right plane. It will be obstructed by the suture which you have taken, so that you don't go it above that. And you must fire the laser and slowly withdraw, so that in the pulse one, 3 second pulse, every 3 seconds the energy get disconnected, and you have to repress the pedal to reactivate it, so that while you are withdrawing, the energy is delivered, and the loose areolar tissue and the hemorrhoidal tissues get ablated. If it is a large hemorrhoid like this, you can go into a fan shaped manner and try and ablate the entire hemorrhoidal bulge which is there. Never ever spray current or laser on the surface of the hemorrhoid, because that will burn the mucosa and cause more problem, pain and ulcerations. Right? Should I proceed?
What about the wattage, sir, in this?
Sorry?
What the setting of the laser?
I said 6 watts.
6 watts.
And we should never use more than 180 to 200 joules together. So there's 6 watt, you can show it over there. Yeah. Okay. And they have set the first setting for the signal at the 60 joules. So I am going to puncture at the mucocutaneous junction. I have got a pedal on my feet which I am going to press. So this has been punctured. I am inside the pile mass. Sorry. Reset kara. Sorry. Okay, I'll hold the fiber. So now my fiber has gone up there. You can see the light. ऊपर का light बंद करो. Then can you see the light over there, everybody? And it's not going beyond the suture I have taken.
Right.
So now I will be ablating it with 6 watt. Again, you are giving 60 ka this thing. Yeah, 60 joules cut off. So as you fire, you withdraw slowly every 2 to 3 millimeter. And you can see I am going in a fan shaped manner. 60 joules have been delivered according to the signal. Now, if the light is too bright, that means you are very close to the mucosa and you may burn it. If it is too deep or not, then if it is not seen at all, then it may be too deep and you will burn the musculature. So it has to be in adequate like this, what you see. And slowly keep on withdrawing. How many joules have gone? So that is maximum what one should be using it, and we have finished it all. Light on. We have to apply this ice because there is a latent heat which is released by the laser, which gets converted into thermal energy, and to neutralize that we need this ice.
Any specific time?
No, after post surgery we leave the ice pack for 20 minutes. Intraoperatively there's nothing which it should be for minimum this thing. You can see it is quite significantly reduced. But one should not expect that whole thing will disappear immediately. This will take some time. The energy coagulation will take some time, but it has already been regressed up. You can see that.
So sometimes we see that when we withdraw the laser fiber, it starts oozing from that particular hole. Any tip to avoid that, because many people face that problem when they are coming out.
If you just press it for a second or minute, then that oozing will stop. Otherwise, you can laser itself is like a cautery. You can use it or reinsert and fire and come out. Yeah. So that was the biggest one. This is the second biggest one. We will be ablating now. थोड़ा सा जेली लगाओ इसको थोड़ा सा ठीक ये ऊपर पकड़ म्यूकोक्यूटेनियस जंक्शन so this is the site of mucocutaneous junction. Ready?
Top light off करो. चालू कर दे. Top light on.
Yeah. So you can see it has reached the tip. Now you can stop the light up.
Light up.
60 joules. So now I am firing in a fan-shaped manner and slowly withdrawing. You can see the light inside.
Yes, sir. Beautifully seen.
Nitesh has always been very kind to me. Light चालू कर दो.
Light on. Top light.
फाइबर डायरेक्टली दे दो मेरे को टाइट नहीं हो रहा है तो. मेरे को पेंसिल के बिगड़ दे दो वो बार बार विड्रॉ. हाँ मेरे को बेर दे दो हाथ में. ये स्लिप हो रहा है उसके अंदर फिक्स नहीं हो रहा है. The internal portion slightly still seems to be pending, so I will reintroduce. Now it will become difficult because the proximal portion, you can see the light over there now.
Yeah, well. It is seen, sir.
Off yes. Light off.
Top light off, karo, please.
You can see it very well. So I am going to deliver some energy there. That fiber was slipping through the pencil there. So I have taken it directly in my hand now. How many gone? Total for this hemorrhoid? Okay, पहले वाला काउंट नहीं किया तुमने. पहले भी किया था ना. You can on the light. OT light on करो. So there's no oozing. The pile mass seems to be completely ablated. Now the smallest one.
So sometimes we see that one of the hemorrhoids may not be that big.
Yeah.
So can we not fire the energy and just ligate and leave it that time? Because
Fire the energy where?
if we avoid doing laser to that one, if we find that one is very small than the remaining ones,
Then
can
at
we
least
just
use a
leave that?
at least use a sclero for that patient.
All right.
You know, because otherwise the fixation of the
shrink.
prolapse tissue would not be there.
Will not be there.
Now, hold it like this. I want to see that. Are you ready? Huh? So I'm puncturing the third one.
So we have a question from Dr. Rajiv Kumar Chaudhary from Bijapur. What
How
would
do
be
you
the anesthesia that is used?
So this particular patient is under spinal anesthesia. You can do it under saddle also, and sometimes you can do it under local with sedation also. If you are used to doing it under local, you can do it under local.
Okay.
So can you see this light now?
Yeah.
So I'm just firing now and withdrawing at the same time. You can hear some crackle sound. That is when the bond, water bond is being broken. You get those crackle sounds. So Nitesh, you are talking about bleeding. So while you are withdrawing,
Yes,
if the
sir.
energy is on, usually that gets
Yes,
coagulated.
that gets stopped.
Light on, please. Yeah.
So nowadays we see that most of our patients, they are coming asking for laser. So
Yeah.
any particular thing which you decide that this particular patient, you will not do a laser, even if the patient is insisting, because I'm sure that most of the people
You are
are
talking
getting this
about
request from
hemorrhoid, or you are
patients.
talking about fistula and
No, I am
fissure?
talking about the use of laser in general, like considering hemorrhoid and fistula both rather.
So see, hemorrhoid, I have no reservation in using laser. I do it left, right, and center, and I have found good results with that. And only thing is the recurrences which the patient has accepted and explained. In the other, especially the fissure ones and all, you know, I do explain that there is just a small cut with a knife tip, or you cut with a laser. The difference is not going to be much. But if he still wants to spend, it is all right. But I will be very honest with them and tell what the extra advantages are. In fissure, probably it is only the hemostasis of cutting the internal sphincter, which you do blindly with a knife or you do with a laser. Probably the hemostasis is better, but as far as the patient come, like painless surgery चाहिए उनको,
Right.
pain नहीं होना चाहिए. Now that is, it is pain less. It is not without pain. The pain is less. That is the only thing. And that also in the fissure one, it is not so completely. So I give a choice to them. Regarding the fistula, it all depends upon what kind of fistula they are. If there are recurrent, multiple recurrences, which I get, most all those fistulas are recurrent fistulas, I have to offer them complete excision with primary sphincter repair. Because, yeah. So otherwise, just have a last look over here before we this thing. Give me a speculum.
So when you will use the stapler?
Speculum.
Sir?
Stapler is most indicated when there is a circumferential hemorrhoid mass. In those cases, in grade 3, you can use a stapler, because this is the last look. There is one small hemorrhoid over here, secondary or accessory hemorrhoid. You can just ablate this fiber dena.
So we have a question from Dr. Naresh from Surat. Would you consider using sclerotherapy after digital artery ligation instead of a stapler in small multiple hemorrhoids? Or
You
stapler is
can
the way to
use,
go?
but there is no double-blind trial which says that sclero is better or laser is better in that. Both has got the same function of fixing the prolapsed tissue.
So there are some people, particularly some people in Calcutta, I have seen go in the intersphincteric space.
I just
and then
mentioned Roy about
sorry,
that.
I missed that.
Yeah, we
So
just discussed
how do you?
that.
Is there more morbidity in that?
Yeah, because one, you have to cross the internal sphincter before you.
It just
reach
shows the red
internal
light.
sphincter.
We always see the red light when you're going, just to see the depth of penetration. Can I ask the top light to be turned off? Just turn off the top light so that the red light is clearly seen.
Yeah, can the camera focus, external camera focus on that? You see the red light that is seen. If it's very dark, that means he's in the muscle, he's burning muscle. If it's bright red, that means he's too close to the mucosa. This is the optimal depth of penetration. Niranjan, tell us more.
Yeah, so we have finished talking about all those, right? Yeah. No issues. Yeah, I know you are a busy man today. Actually, it is his efforts. Like this is the 11th one, and I have seen him. After attending his workshop, I have independently gone and done so many laparoscopic surgeries back at Bombay Hospital. You know, so they are so precise and so well educative. I can understand he's too busy today running around.
Niranjan, yes, all of us have seen some disastrous complications from people coming to us with burns of the mucosa.
Yeah.
And I have some 5 or 6 patients with terrible complications. So tell us how to avoid it.
So as we said, the energy use has to be defined previously. We don't use more than 180 to 200 joules per pile mass. Secondly, as you just now pointed out, that if it is very close to the mucosa, you should avoid. And you should avoid if it is very deep also. The intersphincteric space insertion should also be avoided, because if you insert from there, you are bound to damage more internal sphincter while withdrawing, burning the internal sphincter. So all those things should be avoided, and never go behind sinking the pile mass on table. They may take some time. If they have not shrunken, don't keep on delivering more and more energy, because that is going to cause more damage. So 180 to 200 joules a bit here and there is more than enough and should not be delivered in the hemorrhoid per hemorrhoid tissue.
Very important message here. On table, you will see nothing happening to the hemorrhoid by firing the laser. So don't expect it to shrink, to get blanched, to get congested. Many times nothing happens. I'm going to ask Dr. Nitish Jawar. Dr. Nitish Jawar is a colorectal surgeon at Apollo Mumbai, who also has a fairly large experience. And then Dr. Rajan Modi, who is part of our team, for their little tips on beyond whatever Niranjan has said. Dr. Nitish Jawar.
Like sir said, that whenever we are using the fibers for hemorrhoid surgery, we should stick to radial fibers, because we have seen some people using a bare fiber, which will have more of a cutting effect rather than the coagulation, and that can be disastrous in hemorrhoids, because if you end up making an opening towards the mucosal side, it can lead to a fistula formation later on. And the other thing, like Roy sir was mentioning, that if there is no control on the amount of energy you are going to fire per pile mass, or if you set the wattage too high, then it can cause the necrosis of the mucosa, and it can again lead to the inflammatory and infective complications. So these are the two things we should keep in mind, that don't try to achieve the results on table, because sometimes we become greedy when we start seeing it shrinking in front of our eyes.
So one last thing, which we inject xylocaine sensorcaine mixture solution in the perianal area for pain management post-operatively. This is what I'm doing here.
Dr. Rajan Modi, can you do this under local with sedation, or you always require a saddle block or GA?
It can be done under local anesthesia. Obviously, you need to give a pudendal block, and then it can be done. But the ideal would be spinal anesthesia, saddle block.
Anything different to add?
Yeah, so there are two types of ways the local anesthetic agents can be infiltrated. One, you just saw me putting a perianal ring block, and the second is the pudendal block, which my friend Rajan Modi just spoke about. Just for the sake of demonstrating, I will demonstrate the pudendal block also.
Please do.
So this is the ischial tuberosity. You see, this is the center of the anal canal. The midpoint of this line joining, you have to just pierce and direct your needle towards the tuberosity. This is the tuberosity you feel. Aspirate, there is no blood. Inject while coming out. That will block the internal pudendal now. Similarly, on the opposite side. So this is the pudendal block Rajan was talking about. So in surgery, you can use both. You can use one. Some sedation is required for this patient because the lithotomy position becomes too inconvenient for most of them. But in a lean and thin patient, cooperative patient, surgery and the local is good enough.
Niranjan, apart from this pudendal block, you also give a circumferential block around the anus along with that, or only that?
No, I do the ring block first. Yeah. I don't give the pudendal block very routinely.
And what is your post-op protocol in this?
So post-op, we give them antibiotics for a day, or the routine antibiotics, which intraoperative they must have given. intraoperative one dose and the post-operative one dose, that is more than enough. Analgesics are required for this patient for a day or so, and laxatives are must, because you should ensure that the patient doesn't have to really strain. First motion is the most difficult or painful motion, mainly because of the fear rather than anything else. So with
Sometimes,
laxatives,
post-op 48 hours, you get one edematous pile coming out after a laser. How to prevent it and how to treat it?
so the edematous pile which actually comes out, initially we are giving this ice pack for the first 20 minutes. That will take care of the latent heal and help in reducing the edema because of the damage over there. And even if it comes out, usually they subside over a period of time if they have been ablated properly. If the surgery is not been done properly and it keeps on prolapsing, then probably they may require some fixation procedure.
Any role of flavonoids in these sort of patients?
Yeah, flavonoids, the micronized purified MPFF studies have shown that in the post-operative period they cause some less bleeding and less congestion, and thereby they improve the wound healing. But the evidences are not very robust, but they are there definitely.
Right. So you will now shift this patient out to recovery with this ice pack in place for 20 minutes, where Dr. Vineet, our colorectal fellow, will pull it out afterwards.
Yes.
Is that correct?
Correct.
So that's an important point, that the patient must go home with this ice finger, go to the recovery. And 20 minutes later, take it out. And just tell us, how are these made actually? Just show the camera the ice finger and tell us how it is made.
So,
good idea. One idea is not to drop it down. I'll show it here. Camera.
So we have finished, so we can hold it here. We have already finished the case. So these are the finger gloves which are used.
इसको देखा light नहीं है सर. हाँ बेटा इसको दिखाना. हाँ इसको very good.
So these are fingers of the glove which are cut and filled with water and then put in a deep freezer where the ice gets formed. There are already a long thread which are tied over there, and on table we bring it. You saw me inserting it, and these two threads they separate. We put in a gauze stick so that it does not get retrieved inside the rectum.
So we make these kind of things and keep it ready in our OT. So depending on the size of the anus, and we'll put this post-op.
Yeah.
So we have a question from the audience. How do you make this ice finger sterile so that we are using it?
It is not sterile.
It's not. Don't really need to make it completely sterile. Anal canal with so much stool coming.
Is anywhere full of shit, literally.
Yeah. Or you may just dip it in betadine solution at the most.
I don't think that sterilizes it. It colors it brown. That is a good placebo, but doesn't sterilize it. Why would you want something sterile in the anal canal?
Yeah.
It's full of stool anyway.
We have a question from Bangladesh. What is the post-op management in this case? Post-laser.
Post-op management, as we just discussed a few minutes back, this patient will be on diet after a few hours of that's 4 hours after final anesthesia. If he is under local with sedation, maybe after 2 hours, so you start with water, and if he doesn't vomit, gradually we shift him to soft diet. The next day morning, this patient, or the same day evening, this patient can go home. He goes home on analgesics and laxatives, and instruction to take his bath the next day. That is what we advise this patient.
Excellent.
Roy sir.
Start shifting the patient.
Roy
Yes,
sir.
Yes, Anjali.
How this can be made sterile? What we have done is we take every time a new glove and put with non-touch technique. We put the ice inside, and that can be used.
Excellent. For the sake of the audience, Dr. Anjali Dawle is president of Nanded Surgical Society. She doesn't look so old, but she's very senior in her work. Anjali, how do you put ice with non-touch technique into a glove?
Sir, somebody else will put it. We will stretch the glove at its max.
Okay. See, I always learn something from you every time I talk to you, Anjali. Thank you, and I look forward to meeting you in the evening. Our next two, thank you, Niranjan, for an excellent demonstration.
Thank you so much.
And our next two patients have just been induced. The first is Dr. Thakur, who is head of surgery and dean of Solapur Medical College, is going to show you a difficult cholecystectomy. And the other OT, we have Dr. Chaudhary, who is senior consultant GI surgery at Tata Memorial Hospital, who will show you a laparoscopic D2 gastrectomy. In this OT, after the hemorrhoids patient is shifted out, we will be starting a laparoscopic proctectomy with ileoanal pouch. So at any one time, we hope to show you one basic procedure and one advanced procedure.
we'll plan to end the transmission at 5:30 today. And then there will be a symposium at 6:45, which will be on fluorescent imaging. We have speakers like Dr. Randeep Vadawan, Dr. Pawanand Lal, Dr. Nilesh Doctor, Dr. Anil Herur, followed by whoever is in Mumbai and Thane are welcome to join us for our faculty dinner this evening. The transmission again will begin tomorrow morning sharp at 9 a.m. We have again a good list of cases. Today also there is a hepatico-jejunostomy still to be done this afternoon. We'll see how the day progresses. But we will continue transmission even till 6:15 if we have enough people online. And currently we have almost 4,000 people watching in different centers across the country. And thanks once again to Dinesh for an excellent transmission. Dinesh, shift the audio to OT1 where Dr. Thakur is doing a cholecystectomy. Dinesh?
Yes,
Okay,
sir.
sir.
I'm on. Thank you. Good afternoon, everybody. I think you are all lunch. A nice lunch by Dr. Roy and the feast of all patients. I think this is what I do. Varies always. I'm trained in that. But there are a couple of approaches. You can use an open technique for first trocar entry. And morning, Dr. Dharaf, my colleague, Professor Head of Surgery, Nair Hospital, also explained the way a lap chole should be done. It's a first surgery, I think all practice in their laparoscopic era. And a safety is extremely important. And I always tell my fellows, whenever you are planning a laparoscopic cholecystectomy, you should be trained in handling the biliary injuries, the vascular injuries, or any sort of injuries, because what we get patients are very complicated patients, and we rarely get the simple patients. So anytime any calamity can happen, and you can land up in soup, and you cannot say that I'm an endoscopic surgeon. I don't know the open surgery. So in my mind, I think open surgery is extremely important. So whenever you practice a laparoscopic surgery, you should have a good experience with the open surgeon, because anytime the things can go wrong, and you should be able to tackle the things. I think somebody should explain this. Is there any history, patient's history? Going? Yes? Maybe very slow. Sort of slow. So the distance between the umbilicus and the xiphoid is less. You can use this supraumbilical. I had used transumbilical, but a couple of patients had a bad infection and ugly scar. So I have stopped the entry, first abdominal entry through umbilicus. So either I go supraumbilical or infraumbilical. Okay.
Thakur sir, what has been your experience using ICG and fluorescent imaging?
I think 2 years before, 4 years before, in 2017, I think you demonstrated rectopexy, anti-rectopexy, I remember, and that was 1588, and I was very fascinated the way you started your surgery and how you protected your ureter, and I can bet as of now, if you use this imaging, you can definitely reduce or prevent biliary injuries, because one biliary injury can stop the surgeon career and patient will land up in soup, because you have two ureter. You can, you cannot afford an injury, but one ureteric injury can be acceptable, but there is only one CBD. So when I was in AIMS for the training, I was told that only one commonwealth, try to protect as far possible. And to do an intraoperative cholangiogram laparoscopically a bit difficult. If you have an ICG, I think it's a very safer way, because there's the only way you can protect the biliary injuries.
Thakur sir, Dr. Shekhande would always tell us you have two eyes and two ureter, but only one CBD. That's a famous statement that he used to make to us. Then Dr. Thakur is assisted by Dr. Ameya Thakur, who is his son, also a surgeon, and Dr. Ankur Patel, who's a consultant at Ahmedabad. Moderating is going to be Dr. Prasad Bhukkebag and Dr. Mahadev Garale.
So first is always blind entry. You must always see is there any injury happen. Always be safe, because I am even a paranoid like Roy. Always very careful about all these cases, because one injury you will lose your career. And now this is an obese patient. So normally I use a 5 mm telescope supraumbilical, and 2 5 mm in the right hypochondriac region, and 1 10 mm to put a clip. And this is what the second port. I will come through the right of the falciform ligament.
Any specific point where you come on the right of the falciform ligament, sir?
Yes.
Any specific point where you
Because
come
it does come in your way of operating. So I always prefer, see this what.
I mean, at the level of the
Yeah,
edge of the liver.
yes. Now it's not a, but I see to it that go in the right maxillary anterior axillary fold to retract the. You hold with the left hand and just hold that grasper, one Maryland. Maryland and
So this is a 3-port laparoscopic cholecystectomy.
No, I will do conventional. I am an ordinary surgeon.
Okay.
So I don't do a fancy in my life, because safety is important.
Yes, absolutely.
So this, I will put another port. I have done all sort of fancy things, but come to a conclusion that I want to be a normal person, and I'm a normal person and do not require.
What is your opinion on single incision laparoscopic cholecystectomy?
We used to do it, but took me a long time because I didn't have a cord instrument, and couple of patients had an umbilical hernia. So the incision hernia, and then I stopped it. But if somebody demands, I don't mind doing it. A grasp and harmonic. Now, this is a hand or foot? Okay. There are different ways of doing a lap pulley. You have seen Dr. Dharav did in the morning. Now, first thing is that you have to give me one grasp for Gruchis. टेबल खाली घेणार का एकदम can you एकदम टेबल खाली घ्या see this is can you see that this is reverse circus can you see you don't have a circus, you just draw a line to the quadrant lobe like this and do dissection above this. Now there are anterior posterior, this is where you should move. Now what I do like this. I try to do a posterior dissection.
You always use harmonic, or
I use only harmonic.
But we are from the government institute, we prefer to do.
Yeah, I maybe see to be honest, it doesn't cause bleeding, and I'm more safe. And see, once this is the posterior way you're doing a dissection, just go this up to.
The left hand traction is extremely important.
Yeah, extremely important.
So it has to
be
changing at all times.
Get the gallbladder out.
So he's going to dissect till the 1/3 of the gallbladder is lifted up.
Yeah.
And then
this is now this.
Now the anterior fold of the peritoneum.
Yeah, I'm doing the anterior fold now. This is the. Now I go. Yes, this is what.
So again, the anterior fold comes to the same level.
Yeah, same level. Yeah, that's what I do.
And then you see it.
Yeah, this is what. This is a fatty liver. Very.
What are your tips in regarding a patient with a cirrhotic liver and where you are undertaking a
laparoscopic cholecystectomy?
Once you have to really see the coalition disorders because
I want to welcome Dr. KGMU from Lucknow has joined us live. Dr. Manish Agarwal, who's there, can you hear us there?
Yes. Thank you. Thank you, doctor. Just one question pertaining to this. What are the precautions that we take during the first port, umbilical port, in a case of portal hypertension?
because it is expected there will be collaterals over there. So I do a lot of precaution. Number one, get an ultrasound done, see whether how much splenomegaly is there. Because if I try to put a blind port near the umbilicus, the chance of bleeding are very high. So if there is, I mark with the ultrasound and try to do with the Palmer's point and then do under vision. Because I have seen even they bleed during this because of portal hypertension. The umbilical port also can bleed, and you have to mark whether this spleen are there or not.
So carrying on with Dr. Manish Agarwal's question, any particular tips for operating on cirrhotic patients, sir?
The coagulation profile has to be checked because I have landed up a couple of times in soup. Innocent gallbladder, I don't touch if it is. If there is really needed cholecystitis, then you have to take a call and then do it.
You also will check the INR, the platelet count.
Yeah.
What about varices in the gallbladder fossa, sir? Sometimes
I've
there'll be-
seen, So you have to be very careful and you should be able to suture it rather than try to clip. It goes into the liver. See, that is what. This is the critical area of safety.
Dr. Manish, any questions from KGMU? Dr. Manish is assistant professor at King George Medical University in Lucknow, and the department has joined us online. Dr. Manish.
Yes. The first point, as the sir told, that we always have to go from the Palmer's point rather than going from the umbilical port because the chances of the variceal bleed are very high from the umbilical point. That is really the one part, that the tough part. We really faces this in our routine practice. Last week only we have done a case of the portal hypertension, and there is the varices near the umbilical part. So putting the first port is very important part, and the second is that always we uses the clips because the bleeding during these anterior and posterior dissection are very much. So we always apply the clip and use the bipolar for the dissection.
Can you see now? This is the liver. I think it takes 30 minutes, 30 to 40 minutes. The liver they excrete this IC dye, and this dye will come into the gallbladder, and then through the cystic duct will come to the CVD. Can you see this CVD is marked? So this is where you can enjoy. When you do this is really important when you are doing a CVD stone or a biliary stricture, choledochondrosis. You can really see the even with the overlay mode. You can see this is a hepatic artery over here.
Yes, sir.
Can I start? Now.
Hi.
Thakur sir,
everyone.
with the
This is
in the
overlay
mode. Yeah,
overlay
mode.
I'm a GI.
Overlay mode. Can you have overlay mode?
Oncosurgeon from Tata Memorial. And we will
prefer
be
to operate like this, sir?
demonstrating a laparoscopic radical
So
subtotal
with the
gastrectomy.
advent of ICG and fluorescent imaging, what is the role of introp ICG? Introp cholangiogram now?
I don't think there's hardly any role of ultrasound now. Get an intraoperative ultrasound at the most, and then this really helps you excellent. I think I'm very fan of all, and safety is extremely important. I don't think you have to be heroic for all the time.
We have a question from Dr. Pratik from Mumbai. If in a difficult gallbladder there is a duodenal injury, is there any way to diagnose it on table, and what are the protocols for that?
Duodenal injuries.
Yes, sir.
You can put in a methylene blue
To the right tube.
to the right tube, or else if an endoscopy you can do it. But methylene blue can really help you because I'll tell you one incident. There was a VP shunt migrated from abdominal cavity to the pylorus, and I could to find a hole was difficult for me. So I did the methylene blue injection, and it worked. So I think this is an option where you can. This is a duct, this is artery. And
So can you tell us a little bit about critical view of safety, sir, for the
I just
youngsters and the
say, yeah,
audience?
4 hours, 3.5 to 4.
From here, I should see. Can we
Xenon
watch
करोगे
this?
परत?
हाँ, थोड़ा सा.
Xenon कर.
Sir, you prefer all these dissection with the harmonic or you use the hook also?
See, I'm not comfortable with the harmonic. So, hook, I think, is a good option. Can you see this vessel?
Yes.
This has to be protected. Can you see? Otherwise, the hook can go here. So, you have to remain here.
So,
Oh, correct.
Dinesh, can you shift the audio to Dr. Chaudhary in OT2, who's just starting a laparoscopic
Okay, sir.
gastrectomy? Yeah.
OT2, now you are live.
कैसे रखोगे कुछ है क्या रखने के लिए जगह कुछ तो
Yeah.
ऐसा हाँ ओके ठीक है Hi, welcome all of you to OT2. This is Dr. Vikram Chaudhary from OT2. I am GI and HPV surgeon from Tata Memorial, and we will be demonstrating a laparoscopic radical subtotal gastrectomy with D2 lymph node dissection here. I have a good team with me. My colleagues, Dr. Vikas Gupta and Amit Gupta, will be joining me for this case. Acha. Okay, so I thank Dr. Patankar for inviting me for this workshop. So we will be demonstrating a laparoscopic radical subtotal gastrectomy for a distal gastric cancer, and there will be a D2 lymph node dissection. I have a good team with me. My colleagues, Dr. Vikas Gupta and Amit Gupta, have joined me. And Dr. Patankar and Dr. Reena Singh are my anesthesia colleagues here who will help me for the case. So we are just getting the access now. We will be going live in next 10 to 15 minutes. Thank you. Can we just go for the case capsule? Yeah. So he is a young 29-year-old male. He has no comorbidities. He was a chronic good chewer. There is no significant family history of cancer. He had a good performance status of ECOG 0. He had some non-specific complaints since last 15 days and for which he was evaluated. Tumor markers were essentially normal, but upper GI endoscopy showed, next slide please, showed an ulcerated lesion with elevated margins and edematous surrounding mucosa in the distal stomach. With a suspicion of malignancy, he came to us. Initial biopsy was negative, but when we redid the biopsy, it came out to be a signet-ring cell carcinoma. The ulcer looked very small. In fact, if you can see, the CT does not show any lesion at all. The lesion was only seen on endoscopy and endoscopic ultrasound. So we did the endoscopic ultrasound, which confirmed that it is an early T1/T2 lesion, and therefore we planned him for laparoscopic procedure and upfront surgery. So we will be starting the case in next 5 to 10 minutes. Thank you.
You have two Guptas with you.
Both.
So are there any patients, Vikram, that you won't offer a laparoscopic approach?
So in my practice, even at TMH, I am not, as of now, offering it to locally advanced tumors. So obviously, bulky nodes, large primaries, T4A or T4D, I don't usually offer laparoscopic. Only the patients who have incidentally detected small ulcers, T1 or T2 and endoscopic ultrasound, who are not candidates for neoadjuvant therapy. Probably they are the patients where I'm more tempted towards offering a laparoscopic approach. Does not mean that I won't be able to offer the same radicality in locally advanced tumors. But as of now, as we know that the evidence is still evolving as far as the advanced tumors is concerned. So my preference is to go for relatively earlier tumors.
Is it your practice to routinely do a on-table laparoscopy before proceeding? But for an open radical
so most of our patients,
T2, T3 growth.
Yes, so the most of our patients are almost 70 to 80% of our elective gastrectomies are performed after neoadjuvant therapy, and therefore most of them would undergo a staging laparoscopy as a primary staging procedure itself. So we may not do it at the time of definitive surgery,
the progression rate after having done a primary staging laparoscopy is hardly 3 to 4%. So at the time of definitive surgery, most of the times we don't do it, but it has already been done during the primary staging.
And any experience with pre-op endoscopic injection of ICG to pick up sentinel nodes? A lot of literature now coming on that.
So yes, but frankly speaking, I have not used it in my practice in Tata. But I know even in gastric cancer, I don't know whether it is used to do a selective lymph node dissection, but it definitely helps in identifying some extra nodes, and maybe completion of lymphadenectomy can be proper if you use it during
what is the protocol? When do you inject it?
So I have not used it, but I am aware of the procedure.
So generally, most articles say 24 hours prior endoscopic injection submucosally. We have tried it. We have done only 2 patients. On table, they light up well. More for a completion lymphadenectomy.
Agreed.
I think we use it routinely for colorectal more. We don't do much upper GI actually. Most
So
of our work
I
is
have
colorectal.
I have seen few Korean surgeons use that approach, and actually I agree with you that the lymphadenectomy can be really improved with that. But as long as you are doing a radical lymphadenectomy, it should be okay. But I understand the benefit of the technique. Yes, I
So
agree.
with your permission, I'm now going to shift the audio to
Sure.
OT1 to Dr. Thakur, and by the time your ports go in,
Sure.
you can shift
I
back
think
here.
we will take 15 to 20 minutes.
Great,
Definitely.
great.
Thank you, sir.
So
Thank you.
Dinesh, OT1, Dr. Thakur, Lapkol.
Thank
Yeah,
you.
OT1, sir. Can you hear us? Please speak, sir. Sir, can you hear us?
I can hear it. मला हे दे, मिलन दिला ना. Audio माझ्याकडे. हाँ. This is what I am doing now. I have taken the cystic artery with the help of harmonic. I always take, and now I am suturing the CBD with the help of a Wycliffe suture. I always see, because I have seen a couple of getting slipped.
So, sir, in Solapur, all ducts you will transfix?
Yeah,
Never a clip?
no clip. My unit, we don't use a clip anytime.
Right, sir.
So this is an option. This is what this Roy was pointing. It's just safer. टेबल थोडं वरती वाटतं का जरा?
खाली करायचं? टेबल नीचे लोएस्ट आहे.
ओके, ठीक आहे. हां, ठीक आहे. नाही, काही इश्यू नाही. मॅनेज.
Youngsters need to focus on how sir made the C loop and how it was taken through. These are small points. I think I want you to watch all the senior surgeons operating today. Those PGs who are watching this, please see the C loop and the reverse C loop. I think this is an important learning point that all of you have to focus on.
See, because because the way we are getting patients, they're all bad patients. We hardly get a silent gallstone. Right. So invariably there is a dilated cystic duct, and then putting a clip, because we hardly have a hemoclips. So it is better to suture, and then you get a practice of suturing also.
So we have a question from Main Uddin Mahmood from Chittagong. What is the ideal cystic duct stump length?
It is approximately 2 to 3 mm. It should not be one thing. It should not be flush to the CBD, because any handling might lead a stricture. So
I think this point is extremely important, because previously, I think 10 years ago, I think we used to cut at the junction of Hartmann's pouch and cystic duct. And then we had a spate of patients who came to us with cystic duct stones. Sir, have you ever encountered this problem? Patients referred to you with cystic duct stones?
I have taken out.
So then how would you manage those patients, sir?
I have just cut flush to the CBD and on a T2 I sutured that.
So these are troublesome situations, because ERCP may not be helpful, because your guide wire doesn't go into the cystic duct. We do attempt with the spyglass, but many times it's not successful. So now, as sir mentioned, you can see the CBD there. Can I एक मिनट IR करो
IR
just see the length. I think since this question has come, you can see the lateral wall of CBD, and you see where sir has put hardly 2 or 3 millimeters above that. This is a safe distance, yet you have a good amount of cystic duct above it, and you can see beautifully the CBD getting tented there. And you see the large window that sir has made. So this is the critical view of safety as defined by Strasbourg. This is extremely important. So any biliary anomaly, you are safe.
See, is a right head duct. Here's a hepatic artery, and then I cut it. And here's the scissor there. Put 2 clips and I'll out.
Just wait for moving the liquid.
Sir, in a case of chronic cholecystitis with a very frozen Calotte triangle,
I try to do try to dissect the callots, but if it's not possible, I do subtotal cholecystectomy and close this heart one with the help of a 20 Vicryl or PDS, whatever. Matter कुठे गेलं ते Vicryl? टाकू मला लक्षात. Give me clips and put.
so only one, the proximal one you actually transfix it. The distal ones are all clips, right?
Or only clips, and then I take out with the clips. This is what I do it.
Okay.
Can you see it's gone?
Yeah, it's gone across.
One more clip on
Maybe you can place one more.
Yeah, clip. Safety.
Yes.
You have to be very safe.
Yeah, safety is paramount.
Scissor there. The harmonic.
We do encounter sometimes hepatic venous bleeds when dissecting the gallbladder.
And then I just pack it, and then with the about 30 PDS, we suture it like this.
Okay. So, using a bipolar is also an option.
Bipolar,
if it is fairly superficial.
Suturing is extremely important. It should be master in suturing, and then the lot many salt. And
I think the placing the table properly for suturing is extremely important. Because
so there are 2 ways of suturing. One is people use a triangulation, ipsilateral suturing. I think you should be comfortable where you train and then do it.
Yeah. So practicing laparoscopic suturing is one of the basic aspects.
I always tell my fellows.
Any laparoscopic surgery.
Yeah, definitely.
And suturing in these angles
is tough time because
there's no triangulation here.
Yeah. Always you see it's not a silent gallstone. Always there is some sort of inflammation. There are a lot of cases are there. Previously, I used to use a monopolar, and now I'm more comfortable with the harmonic.
Okay.
And I think
we tend to use basically a monopolar cautery. Only if it is extremely.
But what happened? We should have a safety. I think a harmonic, if you are using properly, I think you are safe and you are through. And
what is your usual technique of taking out the gallbladder? And which port do you use?
Normally, I use a 5mm port, 5mm camera.
Okay.
So with this,
so you take it out with the
So normally I use 3 5mm. I have a 5mm telescope which is having an ICG.
Okay.
So.
And do you place it in an endo bag and then take out, or
if it's there? Otherwise, in a government setup, if I operate in a private setup, we do it. But if it's in a government setup, it's not possible. And if it's infected, I put a saline bag and then manage like that, or a plastic bag of saline and IV set, and it can be done.
Okay.
But this is a nice camera. and
very
good
nice.
assistance. Both two stalwarts are assisting me and helping me. And see,
Yeah, it's all the
I'm
teamwork. It's all the teamwork.
yeah, the
So
teamwork
every
and
member of the team is important.
first of all, thank you, Dr. Rai, to giving an opportunity. Whatever he says, we operate. And for last 22 years, I'm practicing laparoscopic surgery, and I'm more comfortable with using a harmonic. And I'm really gadget. I want the best possible. Rather than even in a E-tape, I use a balloon, and I'm more happy with the balloons. Rather than because we don't want any bleeding in the retroperitoneal structure.
I agree with your points.
So if the best, give me bipolar.
The
Yeah,
best
give me
gadgets
bipolar
available to you will actually help you.
And I always keep a drain because bipolar, but because we don't want any issues.
Even if it has been a simple gallbladder?
Yeah, I'll keep a drain because I have a protocol. I always keep it. 5 minutes hardly makes matter.
And when do you take out the when do you take out the drain?
Within 24 hours.
Okay.
24 hours.
Okay.
करू अरे बायपुर चालू नाही रे बेटा करंट होते काय हे माझ्याकडे ना सक्शन द्या मला सक्शन द्या मला बायपुर दे बेटा मला व्यवस्थित कोई इश्यू नाही This is the way of suctioning because the air doesn't leak. Suction चालू है क्या? Suction चालू केले? नाही होते बेटा. Suction चालू है? Suction चालू नहीं बेटा.
नहीं सक नहीं हो रहा है.
हाँ सक्शन नहीं हो रहा है हो रहा है ठीक है जी बायपुर नहीं give a pressure if there is the instrument failure always give a pressure most of them it does stop and wait till your bipolar comes Gosby is a better option it just give a pressure and it stops करू is working
yeah
okay I'll just try it
you can try
झालं बेटा give me this
check करो
दुसरं बायपुर घे नाही तर मग तोपर्यंत मला ड्रेन ठेवायला द्या I have seen people doing a wonderful dissection with the monopolar bipolar. I think whatever equipment you use it properly, judiciously. I don't think there is an issue. But hello, तेने हार होने के थे हाँ होते
whatever if the bed is slightly oozing, do you prefer to place a surgery cell?
If this is available, you can cauterize it. A lot of good with snow and all, everything has come. I think it does work, but a cautery bipolar, I think, is good enough.
Yeah.
But sometimes the patient have a portal hypertension. You might need a real good glue or all sort of thing. One thing which table has to be enough. मला हे द्या आरटी देता जरा
14.
Yeah. This is the way. For now, what I'll do, I'll just put here one my, and I'll give me one Ellis forceps, and can you do one thing with this? You just take that gallbladder off with this forceps. And give me this is Ellis, no?
No.
Chalega. Give me a rice tube. I'll put a drain. No. With this, no. I'll put a rice tube from here. With this, first you return the gallbladder. Correct.
Okay.
Half. Give me a rice tube. Do you have it for the drain? Because it's my safety. I am a safe surgeon. So 5 mm incision, you keep it. Hardly, there are a lot of papers. They say that you don't keep a drain. But I am a little paranoid. They'll always keep a drain and observe for 24 and they'll take it out. Can you put an ICG again? This is the mode. You can see it again.
Overlay mode.
Overlay mode. Don't worry. I mean, this is what my don't mean. Okay. 1 minute. ते हे लावून टाका एक. दे मला हार्मोनिक. And I'll just knock the gallbladder. I'll always keep a drain so that easy. This is my always.
What are the options if you suspect there's a CBD injury on table?
The ICG will always tell me this leaking and badly. I'll immediately suture it with the help of a 2030 PDS. And if I have a doubt of a stone remaining, then I will do immediately open the CBD, take out the stone. If otherwise, I usually use a ureteroscope, and because I have a bronchoscope also flexible, so I use that, and I do a corticosteroid.
What do you advise younger surgeons who are operating and they suspect a CBD injury on table? They might not be really good at laparoscopic surgery.
Put in a CBD, put in a T-tube and come out and refer to higher centers.
I think a larger drain.
Yeah.
Sending to a higher center.
Give me a grasper. Take out a gallbladder. Hey, Diana, gallbladder removal there. Where's the gallbladder? इथे लाव. इथे लाव. हा. Switzerland dissection. याच्यामध्ये टाकलं लगेच. You have done fellowship here?
Yes.
Okay, very good. When did you finish your fellowship?
2008.
2008.
I was there here for 3 years.
3 years. Good, good, good. So you are where are you practicing now?
Ahmedabad.
Very nice. Good training. एक कार्ट्रिज आहे जरा मला.
The bag is full of stuff. We have to remove.
हे कापून आपल्याला जर काढता तर बघूया याच्यातून तो गॉलब्लॅडर फोर्सेस तर पाडू नका ते.
ओपन करून सक्शन करून
हाँ उसको अगर निकालते हैं.
This was foreign studies, no? Good morning, already.
नहीं
What is it? Take it. So you want this?
हा काढ बरं ह्याच्याने त्याचा ऑप्शन अदरवाईज तर पडतात त्या शाळेला दिसत नाही मला काय. हा हे सगळं व्हेरी गुड. माझं चुकलंय मला माहिती असतं अल्ट्रासाउंड रिपोर्ट ना मी आधी डायरेक्ट करून घेतलं असते. थोडस वाढवा लागेल ब्रेडने. कॉस्पिस काढलाय ना सिस्टर? हा थोडं ब्रेड देतो बेटा. ट्रान्सफ्यूशन घेणार तुम्ही?
So what I have started doing is I put in a swab holder. I dilate the
ग्रेट वेळ ट्रान्सफ्यूशन कराल तुम्ही आता? थँक्यू व्हेरी मच. संपतो.
Come here. Future passer है ना brother? Future passer and Vicryl 20 ready रखो. 30 हाँ चलेगा. No, that's fine. Come here. ठीक है. So the crust we can retract now. Come here. See that up? Come close. Transmission जब हम लोग OT में video is on but they won't come unless we call them. Okay. बाद में देखते हैं. Come here. चलो. I'm okay, sir. I'm okay. The disease looks okay. Pylorus is free. I had a concern here about the tumor, but it's okay. It's fine. I'm okay. थोड़ा left accessory आहे, but mostly it is accessory. So we'll see whether we need to sacrifice it or not. But later, not now. ठीक. Okay. चलो. Vicryl. नहीं. Middle holder. मिडलच्या जवळ पकडायचं. माझ्याकडे. They are there, sir. दुसऱ्या हातामध्ये ग्रास पडले. लेफ्ट हँडचा आहे का रे ब्रदर? लेफ्ट हँडचा निडल होल्डर आहे तुझ्याकडे? नाही नाही. अच्छा ठीक आहे. ओके. हां चला रोटेशन नाही आहे. ठीक है. विल सी होगा. हाँ just I'm taking it on the crus for the fixation. आता असाच घेऊन टाक. हाँ हाँ घुमा के लेंगे. तो पकड़ना ही मुश्किल हो रहा है मेरे. थोड़ा अलग है. थोड़ा अलग है. आई नो बट अभी इसको यूज टू नहीं है ना. कितना भी अच्छा रहेगा तो. हाँ ठीक है. थोड़ा रिवर्स स्टैंडबर्ग चाहिए तरी ना. रिवर्स स्टैंडबर्ग एंड बस बस. हाँ डेवलप नहीं. और थोड़ा रिवर्स स्टैंडबर्ग चाहिए. ठीक है आप करो बस. ठीक है. थोड़ा राइट अप. थोड़ा राइट अप बस. ठीक है. थैंक्स. है ना, मिडल ऑर्डर मेरे को यूज टू नहीं है. है ना, दिखा, कम बैक. हाँ नहीं नहीं ठीक है, बट दिखा ना, ऐसा होएगा. हाँ आएगा आएगा, ये देख. ठीक है, 2 मिनट रुकना. ब्रदर सीजर रेडी करो. 30 मोजलं होतं ना. Come back. Come back. Show me here. This area. Okay, it will come. हाँ, सीधा करो कैमरा. Okay, brother. ट्रांसफर दे, ठीक है. आहे माय. थांब. सीजर दे. सीजर. निकालेगा. ठीक है, मैं निकालता हूँ. मिडल ऑर्डर. ठीक है, शो. अडकते का याच्यात. ओके, अजून एक ग्रास पर दे ब्रदर. राइट साइड वाला पहिला करते. ग्रास पर तुम्ही. शो शो. ले ले. Don't do anything there. Okay, Vikas, ready? दिखा ना अमित. नीमो जा रहा है. नीमो इज गॉन. नहीं निकल गया गैस. वहां मत लगाओ. अप्लाई टू योर पोर्ट और माय पोर्ट. कम बैक. जा रहा है, नीमो आ रहा है. ओके, शो मी हियर. retract this. बस ठीक है, चल ले. पास फ्यूचर पास. एक मिनट रुकना. हियर अमित विकास. थोड़ा नीचे. बस बस. सीधा जा. जेंटल. शो मी. और एक मॉस्किटो लेकर. पहले राइट का देख लेते. हाँ, लेफ्ट साइड का देख लेते. ओके, शो. मिडल को निकाल दिया ना, छोड़ दे. हाँ निकाल दे. शो. एक मिनट. दिखा palpate का दिखा नीचे दिखा retraction is correct ठीक है correct चल देखना ठीक से very good come perfect open come on go out careful take careful केयरफुल 1 मिनट रुकना नहीं तो पुल मत कर मॉस्किटो दे ओपन टेक इट केयरफुल ज्यादा ट्रैक्शन नहीं गॉज ब्रदर 2 गॉज चाहिए फुल साइज गॉज नॉट कट गॉज बस करेंगे पहले इसको फिक्स कर देंगे ब्रदर अजून एक केली दे अजून तू अजून दे तिकडे उसको गॉज दे ओके आई थिंक वी आर ओके ना रेडी विकास टेक द ग्रास पर पीनट चाहिए ब्रदर गॉज टू मी 1 गॉज टू पुट इनसाइड हाफ गॉज दे दो ना
ये 2 इधर है गॉज
चलो थोड़ा लवकर दे यू नो इधर गॉज डालना गॉज प्लीज अच्छा ऐसा देंगे नहीं मैं इसको देना मेरे को डायरेक्ट हाँ ये मेरे हाथ डायरेक्ट है हाँ थोड़ा दबा के रख दो 5 मिनट कम है अमित सीधा हाँ यस फोकस vascular ठीक है come back don't rush सीधा सेंटर
Dinesh bhai, can you hear me?
हाँ
Dinesh?
So yes sir, we can hear you sir.
Have you had a joining from Bangur Hospital, Calcutta? Get them online. Dr. Makhanlal Saha is waiting to join.
come here
Okay sir. Yes sir, he's there. You can talk with him. Yeah,
Dr.
hi
Saha,
sir.
good afternoon.
Sir, just unmute yourself sir, we can't hear you sir.
come here
Dr. Saha, can you hear us?
No sir, basically he's adjusting his mic, we can't hear sir.
So the bowel is
No sir, still we can't hear.
Give a head
From
down.
Bangur Hospital we can't hear sir.
Steep head down.
Am I audible?
Yeah, now you are
Sir,
audible.
you're audible now.
Yeah. Dr.
Good
Rai
afternoon, Saha,
Pratanga,
sir.
thank
Good
you very
afternoon to you,
much.
sir.
Thank you very much for the nice show since morning. We are enjoying with me is our senior surgeons here, Dr. Dubojyoti Bhaumik, Dr. Sandeep Rai, Dr. Madhumita Mukherjee, Dr. Bishwarup Bose, Dr. J.D. Roy, Dr. Pritin Bera. We are all here along with our all PGs. We are enjoying the whole program. It's a very nice transmission and good audio also.
Yeah, hi, Rahul, how are you?
Dr. Chaudhary, what is the structure? Is it the accessory left hepatic artery?
Okay.
Yeah.
So this is the accessory left
Sir,
hepatic artery.
कौन
Yeah,
सा?
this
That
one.
Harmonic. हाँ वो किया मैंने.
can you hear me?
Yeah, I can hear you.
Okay.
10 घंटे वाला.
So I could not open the wall of the lesser omentum. Otherwise, my
ये 10
strategy
hours वाला. हाँ,
usually
दोनों use किया मैंने. उसका
to hang
7
the
mm
left
वाला,
lobe of liver.
5 mm वाला,
I
दोनों पता है
completely
मुझे.
open the lesser sac and completely open the
नहीं, ठीक है,
crura,
मुझे use किया
the
मैंने.
celiac origin. However, because of the significant size of this artery, I have not divided this, and I have just divided part of this lesser omentum and hang the liver with the right crus.
Okay.
So this is what I have achieved. Now, because I am on the right side, my next step is to also isolate the right gastric artery and probably isolate the level 5 lymph nodes here. And when I finish the right sided dissection, initial dissection, then I will go to omentum and the level 4 and level 6. So as of now, I will be focusing a little bit on the porta and level 5.
Dr. Saha, you have good audio video quality there?
Yes, very good. Very good. Nice
The
transmission.
next case is just being induced. It's a patient that we had done a total colectomy earlier for polyposis coli. She's for a laparoscopic proctectomy with laparoscopic ileoanal J pouch.
Okay.
In the third OT, we'll have a hepaticojejunostomy for a CBD stricture.
Okay.
Raja.
Yes, sir.
Good afternoon. This is Sandeep.
Good afternoon,
fantastic
Sandeep.
show. Fantastic show. We are all
Thank you,
enjoying
sir.
from here.
Yeah, Roy, this is Dr. Bhomik.
Hi, Dr. Bhomik. I can see you. I can see you clearly. And do you have a video feed?
No, it's
from the
really a good
second
show,
OT?
and especially the audio video transmission quality. I must congratulate you.
Thank you, sir.
Yeah, it's a very good effort, Roy. I'm Dr. Bose over here.
Yes, sir. I can see you, sir. Good afternoon.
Very nice, well organized thing.
Actually, Dr. Vivannu Basu was supposed to join, but suddenly he has got some cardiac issues, so he could not come.
Hepatic नहीं दिख रहा ना? Right is not seen, na? But anyway, common hepatic is not seen properly. There is no hint of it also. Peanut घेतला? Take peanut. Take it out.
The sponsor has done a good job. The Alkane people are here since morning. They have arranged for us breakfast, good lunch, tea and coffee throughout. So all the delegates are enjoying this great show
So
here.
evening we have a symposium on fluorescent imaging, for which also I'd like you to join. And tomorrow again the live transmission will begin at 9
Tomorrow
in the
9
morning.
o'clock will be sharp here.
The first case I am showing is a laparoscopic radical nephrectomy for a RCC.
Okay.
And the other OT will be a achalasia and a fundoplication.
Fine.
So please join tomorrow morning as well at 9 o'clock.
Sure. More people will join tomorrow, being holiday.
Great, sir.
Yes, वही है वो. Come here. अच्छा और एक है. Come here. Peanut उल्टा पकड़ो. If you are not fine. हाँ, for pancreatic retraction.
So at what point you do dissection up to before you convert?
I would do most of the resection.
Entire lymph node clearance you do laparoscopically.
Everything I do lap only.
Okay.
And even the GJ we will be doing the lap.
Okay.
The JJ part I take a small incision and then I finish the JJ. So most of the specimen will come out only after the GJ.
Right.
So I have a slightly different reconstruction technique which I will demonstrate. Come here, please. Now we are slightly, the anatomy is unclear. You can see obviously that there is a accessory left artery. Pull, please, pull.
Dr. Saha, you are seeing the video from the second OT also, where there are a lot of adhesions due to previous colectomy, and he's taking the small bowel down.
Yeah.
Was there any previous surgery?
Colectomy.
Sorry, sir.
This was total colectomy earlier.
We had done this patient had a polyposis coli with a descending colon malignancy.
Yeah.
So we had done only a total colectomy with the end ileostomy earlier.
Yes.
Now completion proctectomy with ileoanal pouch.
Right.
There are polyps in the rectum also?
Sorry, sir?
There are polyps in the rectum also?
There are polyps in the rectum also, sir. tomorrow morning also we have a CA rectum or a laparoscopic AR.
Yes, Dr. Ashwin is coming for that.
So today what we'll
Yeah,
do
I'm
is once we
connected.
come again, sir.
No, I'm just wondering, Roy, am I connected? Can I be audible?
Yes, Randeep, we can hear you. Go on, please.
Yeah, so hi and good afternoon to all of you. And
you have a meridian?
at the outset, I'd like to thank Dr. Roy Patankar for inviting me here. It's absolutely wonderful, except a lot of additions in this case. But great show, Roy. And we've had some excellent cases since morning, and including a master class from Coimbatore. It was absolutely a master class that we saw. Great case by Dr. Roy himself, a bilateral TAPP, and then Professor Pavan doing doors fundoplication. So excellent cases. So this, Dr. Roy has already informed all of you that this is a case where this was a FAP, a familial adenomatous polyposis, where total colectomy has been done. And in this, of course, a completion proctectomy along with ileal pouch anal anastomosis is what we intend doing. We know that these patients turn into malignancies, and so a completion proctectomy is to be done. More often than not, we find that in these patients, actually, they turn into malignancy by the age of 40. This is a 51-year-old lady. So probably that's the reason it just got, she must have got delayed, because I understand the biopsy at that time did show a malignancy. And yeah, so we intend doing a completion proctectomy along with ileoanal anastomosis, pouch anastomosis. So she's got a midline incision, so probably midline was given to take out the specimen, and large specimen, so maybe that's the reason the midline incision would have been given at that time, and she's got the adhesions all around that. We'll just get these adhesions down, because in any case we'll need to get them down to make the ileal pouch. So all this adhesiolysis needs to be done in any case. And so then what we intend doing, if we can complete the adhesiolysis laparoscopic, then we will probably just give a phenensteel incision to actually make the pouch extracorporeally, and thereafter do a anastomosis by a circular stapler. So that's the intent. Otherwise, if we don't get these adhesions down, we'll end up with another midline laparotomy, which I don't want. So I would do a complete adhesiolysis here. And the trick in this adhesiolysis is, because generally you would get these adhesions, when we are doing all these hernias as well, the trick is to go as nearer the anterior abdominal wall as possible. It's better to leave a piece of the sheath or a peritoneum over it rather than a piece of bowel on the anterior abdominal wall. So if it's stuck to the peritoneum, I'll just go a layer above that. So that's the intent. And if you can actually appreciate, most of the time, I have not used any kind of cautery or energy source. It's all it's all a sharp dissection with the scissors, cold scissors. And I would prefer not to use the cautery here. And so this would take a little time when I'm doing all this adhesiolysis, because this needs to be completed before I actually move towards the rectum.
Hello, here Dr. Biswarup Bose from Kolkata. This is a good demonstration for the youngest surgeons and the students that in adhesions, it should be a sharp dissection rather than with any electrosurgical devices to avoid injury to the guts.
Absolutely, sir. Extremely essential, and you need to see what's behind, and thereafter just do a sharp dissection. Don't try to pull it. Don't try to use an energy source here. You'll invariably have a inadvertent enterotomy. You can still have one, but you need to be careful and do it with a sharp dissection.
Here the rectal stump is there, na? So
yes, sir. The recurrent stump is right
here. Rectal stump
yeah. So we'll, once I release these adhesions, I'll probably get to the stump, and then it shouldn't be that it shouldn't take that much of time. We'll probably just do a complete proctectomy and go on right till the anal canal and fire staplers there.
And then
This part obviously will take little time because one can't hurry it up.
and pouch to anal anastomosis, will a stapler or hands-on?
No, it would be a circular stapler. So what we'll do is I intend making a Fenton steel incision. I'll have to, this lady is on a ileostomy. So she already obviously has an ileostomy. I'll take that down, make a pouch and a J pouch. So I generally make a J pouch here, which would be about 30 centimeters, 15 efferent limb, 15 afferent limb. And thereafter, I'll do a circular anastomosis with the anal canal.
And then you'll create a new diversion?
Yes, sir. Absolutely. Because there's some data which is suggesting people are getting away without doing it, but I'm not very comfortable.
It's quite safe to have a diversion. It's quite safe to have a diversion.
Absolutely. Have a diversion, even though you can get that down in about 4 to 6 weeks, but I would still prefer to have a diversion there.
Yeah. Very reasonable.
So you can probably go on to the next side. I'll just take a little while before I get these additions down, and then we'll go quickly to the rectum.
One should see how to get about the additions being lysed in a
Very
nice
good
way.
learning of additional lysis. Because even if you have an injury with a sharp instrument, it can be detected immediately rather than an electrosurgical equipment.
Correct. It can be detected, and you'll probably just require a stitch there. And but at the same time, it should be avoided as far as possible. Giving a gentle traction, and the abdominal wall is giving me the counter traction. And again, the ports are not the ports which I would generally make for a proctectomy. I would make my first port generally is just supraumbilical and to the right side of the patient. That is my first port where the camera port goes in. And my subsequent ports are, one second, my subsequent ports are actually on either side of the umbilicus, depending upon the habitus of the patient. If the patient is relatively thin patient, I would go a little down, and so I'll make 2 ports on patient's right side and 1 for retraction on the left side. So I'll make about 4 ports, but here the ports are completely different. My first entry was at the Palmer's point, safest area to go because of the midline incision which was there. And thereafter, I've made 2 more ports. Both the ports are on the patient's left side in the flank, so that I can complete this adhesive lysis. Thereafter, I'll see what are the other ports I need to make just to complete the proctectomy. Get back here. We're almost there. This is the. Okay. Sorry.
Is there a role of any hydrodissection in open surgery? I used to push some saline.
It's still, the adhesions are not very tough. You can find a plane. I generally find the hydrodissection making it a bit messy. Okay. I prefer this sharp dissection a lot better.
Very dense additions all around.
Yeah, so which is expected because the patient had a
colectomy and ileostomy.
Yeah, so 1 second, let me just see which is the. So,
No artery here. अपना D2 थोड़ा easy हो गया. टोटल वेन दिख गया ना.
হচ্ছে হাই ভলিউম ডাটা মেমোরি বুঝতে পারছো? তাহলে রায় তো রায় ভালো পেয়েছি রায় ভালো পেয়েছি ওদের তো জিজ্ঞেস করেছিল দুটো উইক 200 বেডের হাসপাতাল বুঝলে 100 বেডের রিং হচ্ছে ফ্রি অফ কস্ট হ্যাঁ
So Sneha is, she has the control. She is assisting me. She's doing a wonderful job. We are doing it with a 5 mm telescope at the moment. I'm not changed to a 10 mm because depending upon where my subsequent ports would be, I would then change to a 10 mm. The vision is very good with us over here. I hope the vision is fine there. So we are doing all the dissection with a 5 mm telescope at the moment.
The picture quality is very good.
Thank you.
এত সুন্দর প্লেনটা বের করছে স্যার এক ফোঁটা ব্লাড বেরোয় এটা চলে এসেছে
I think I'll round it off here.
Just let's see. That is the, yeah. So this is the stoma. So we leave this here. We just need to get the rest of
For
it
the
down.
sake of our audience, you have a very lovely, beautiful vascular anomaly here. Kindly, please highlight and describe
Yes.
about it.
So now, after doing the liver hanging, we noticed accessory left hepatic artery.
Yeah.
However, this is a type 3 anomaly where there is completely absent common hepatic artery. You cannot see any common hepatic artery here. And this is the left hepatic artery. And this is the reverse of the left hepatic artery, which is giving the origin of the right gastric artery.
So this is replaced left hepatic artery.
Yes.
At the 11 o'clock position, you are saying that
So there is a complete absence of common hepatic artery. We have a completely replaced left hepatic artery. Come to the right side. And probably we also have a completely replaced right hepatic artery, which I will not dissect as of now here, because that is not our area of lymph node dissection now for this case. Okay, so it's not a part of D2.
I'm slightly scared here.
you have a segment 4
Here it
artery
is.
there coming out at
Yes.
11 o'clock position going in.
Not sure where the gut is.
So
This is
so
what
we will
is
treat this
bothering
for
me.
all practical
Rest
purposes
I've
as
got
a
the additions down.
artery itself.
This, of
Because
course, is
in
the
some anomalies, this can act as a right artery and
I'll
this
get
can act as a
everything
left
else
hepatic
down
artery.
in any case.
So we are not sure here.
That seems like the hernia there. So probably some incisional hernia. That is where the issue is. If this wasn't there, I would have been halfway through the proctectomy. There is some bleeder here. Okay. Give me harmonic. No. Just hold it, beta. No problem. We'll just take it. One second. Just come near, beta. I can't see properly. Yeah, clean it. Give me a gauze piece also. I'll just put an intra-abdominal gauze.
That was.
It's closed, so there's no problem. Give me the scissors. Yeah, give me the suction first. Just check the suction if it is वैसे तो ठीक है ठीक है okay come here scissors please Lot of additions. Actually, this is because of the midline. If there was no midline thing, we would have been okay. Again, see, malignancy, one can understand. This is what happens. That's the dikhana, yeah. Okay, so that this will also go down. I'm not taking out this one so far. We'll just wait. If I don't take it out, we'll end up with a laparotomy again, because the idea is if I can get away with a femoral steel incision just to make the pouch, okay, come here. Yeah, okay. The thing is, I'll have to make a power the port in the center, the midline, somewhere around the umbilicus. Only then can I go around it. Then let's search for the rectum.
Sorry, give you a bad one.
No, that's okay.
We keep our challenging surgeries for best surgeons. We'd rather not be in that situation.
Let's see how this is. It's fine. Yeah, that's okay. We've almost got it down.
So we have been joined by Dr. Pratap Varute and Dr. Rajendra Shinde, sir.
Dinesh, can you hear me? Dinesh bhai, can you hear me?
इधर नहीं आ रहा.
Dinesh bhai,
Yes,
can you hear
sir.
me? Dinesh bhai?
Yes, sir.
Yes, sir.
Yeah, you said
Yes,
Dr.
sir.
Pratap Borode and who else?
Rajendra Shinde, sir.
Oh, wonderful. Welcome, Dr. Pratap Borode. Dr. Pratap Borode and Dr. Rajiv Mehta both have been president of Maharashtra chapter of ASI. And Pratap is a close friend of mine, also contesting for governing council along with me in this ASI election. Welcome, Pratap.
Thank you, sir. Thank you for the kind introduction, Raja.
Thank you, Roy. Thank you, Raja. Welcome to Zen CME. And I look forward to seeing you both soon. So I think Randeep has done a lot of hard work taking down all the ideal additions. And what next, Randeep?
So once we've released all the additions, we'll go for the rectum then. Yeah, so hopefully that shouldn't be too much of a,
Hopefully that will be virgin territory.
relatively as compared to what this is. But yeah, the first step is to take down all the additions, that's for sure.
So this is a game of patience, and you can see Randeep has done it extremely well. And I was telling him we save our most difficult surgery for the best surgeon.
Nice of you to say that, but I'd be happy to exchange places.
Dr. Rai, you have a lot of GC candidate nominee in the
Yes, sir. Just like West Bengal, sir.
Yeah.
lot of candidates.
Yes.
So how many are contesting from Maharashtra?
So we have 6 candidates for 4 posts.
We are far ahead. We are 7 from West
Yes,
Bengal.
sir.
So Delhi has been a lot better. Delhi we've nominated
Yes.
4 for 4. So there's
Delhi
no-
has been good. We tried
Yeah.
doing that in Maharashtra, but it didn't work. We were trying to avoid an election, but so be it. We are all friends.
Absolutely.
Noida,
Yes, sir.
Sandeep here.
Yes,
Dada,
Sandeep bhai.
Just in your last workshop, you were about to do a tap, and then there was an odd color of the small intestine.
Yes,
and
yes.
you deferred the operation. What was the final pathology and what was
Yes,
the final
surprisingly,
management?
immediately post-op, we took the patient for, on table, we did a
Yeah,
ICG
yeah.
and ICG looked all
I
right.
remember. Yeah, yeah.
So immediately post-op, we did our LDH, arterial blood gases and a CT abdomen with contrast. And surprisingly, it was completely normal.
Okay.
So we actually conserved the patient for 48 hours and then did open bilateral hernia. I didn't have the guts to go back and do a transperitoneal procedure again.
Okay.
So we did an open bilateral hernia 2 days later and sent the patient home in a day. But it was, I still have not been able to figure out why that odd-looking color of small bowel Sandeep bhai.
Right. Okay. Okay.
Just get back.
Thank you.
Just get
But
back.
you remember, I'm impressed.
Get back and let's
Pardon?
get this down.
Yeah, yeah.
Once we get this down,
Remember
we'll get
that.
a
Oh,
port
yeah,
in.
yeah. You are here, na?
Yes, sir.
Yeah, we'll get a port here.
And thank you to Dr. Saha for organizing the Bangur auditorium for us on both occasions. I really appreciate it.
Yeah, it's a pleasure that you can enjoy your live workshop here.
So this is which part of Kolkata?
This is South Calcutta.
Oh, okay.
So Dr. Saha has retired from his medical college and joined Bangur, which is a postgraduate surgical. This is a ESIS hospital, Saha,
No,
sir?
this is a government district hospital.
Government hospital. Okay.
And
okay.
we take DNB students. We have 9
Very
DNB
nice.
students here.
Oh, big department, 9 students.
It seems like a small hernia here.
Yeah. Midline.
Yeah, midline hernia. So I'm trying to
So the
get,
bowel is densely adherent to the midline.
I'm trying to get over it so that because I'll need my next port to be here. Otherwise, my vision to the pelvis will not be there.
Sure.
So I need to get a midline port. And to get a midline port, I need to get this out. And
The postgraduates need to watch how he's doing this. A combination of pressure, dissection, no monopolar current at all till he's very sure where the bowel is. So this is
this is the tricky one. I feel there's a hernia right here.
Yeah.
So we just went a layer above.
Yeah.
So take this down.
So leave peritoneum on bowel, not bowel on peritoneum.
Yeah. So once we get this down, I think it should become a little better.
Yeah.
Because
Good job, Randeep.
yeah, so this is that's the ileostomy which is
Yeah,
there.
yeah.
So we need to leave this here.
Yes.
But besides that, I think we are quite okay. Let's get rid of it down and then make another port in the midline. So we'll make a 10 mm port. We'll change to a 10 mm.
Hello, Dr. Wadhwan.
Yes, sir.
Hi, Dada. This is Sandeep from Kolkata. Absolutely fantastic addition. I see that it takes a lot of patience and not an easy job at all.
Thank you, sir. Thank you.
Particularly in a workshop setting with 3,000 people watching you. I think he's quietly under his breath cursing me for giving him this case.
It's an honor to be here and honor to be amongst all of you.
So you have left Fortis and now in Manipal, na?
That's correct, sir. You remember that.
Yes, yes.
I think last we met was in Bhubaneswar at the IGS.
Yeah, yeah. Actually, I have one question.
Yes, yes, last time we had.
One question. Once you bring everything down, how to confirm that a small enterotomy has not been made?
Correct,
Anyway.
correct. So I think multiple ways. One, of course, wherever you feel that there could have been an enterotomy, you would have, one needs to go and check. I have checked at a couple of places where I was very close to the bowel.
Yeah.
That apart, we still have time. I'm going to be dissecting the rectum and all that. And if there's, we see any kind of greenish fluid coming out, we'll know. That apart, I've not used electrocurrent at any stage. It's all been only cold scissors. So I doubt it if there would have been an enterotomy there.
So beside when you make the ileoidal pouch, you'll be making a small phalangeal incision.
Correct.
We can actually also have a look at that time before doing the stapled anastomosis, sir.
So now I'm going to make another port, and this time it's going to be a 10 mm port where I'll be putting in the camera from there, the telescope from there, so that my visualization of the pelvis is a lot better, because presently Sneha is actually showing me from the Palmer's point.
Dr. Pathankar, Rohida,
Yes,
one
yes,
question.
sir.
Is there any role of ICG in detecting a very small sort of occult bowel injury?
Sandeep, please call me Roy. I'm not Dr. Paran.
Okay.
And ICG really won't help for finding an enterotomy. ICG would have role in seeing vascularity. So if you have doubt of ischemia, then ICG. But enterotomies, I don't think ICG has much role.
Okay.
I hope you are getting feed from both the screens, sir, the lap gastrectomy as well as the. So you see him doing a good lymph node dissection. He has a replaced left hepatic as well as a right hepatic also is replaced. It's a very unusual anatomy in this gastrectomy. This is typically what I call the workshop syndrome. Anything that is unusual will come when you're doing it in the workshop.
Absolutely right.
Otherwise, this was a 28-year-old boy. We didn't expect this kind of trouble.
Probably need to make one more there and then go on I'll go on that side. 5 mm and then I'll go on that side. Okay. I'll need one more 5 mm and I'll go on the right side of the patient. Let Sneha put this and I'll go on the right side of the patient. Yeah, good. No, how's the vision? I probably need to focus. Yeah. We'll use these two.
Sometime. So what I plan to do is to go enter through the momentum here and do the right level 6 lymph node dissection
Happier this way.
and the duodenal stump.
Give me a 5 mm, please. 5 mm. And then after that, once I put this, no, you can clean it up. I'll go from that side. Yeah, just this side, please. You can
So
move
you take the greater momentum close to the colon.
just to the left.
No, can you hear me here from OT2?
Yeah. Yes.
So just for the sake of, we will be taking complete momentum, though this is a T2 disease and N0 disease as per the clinical radiological staging. I will be taking complete momentum just for the ease of dissection at the greater curve and level 6. I'm entering this plane as of now.
Okay.
And when my dissection is complete, I will do the separate total omentectomy separately. So I will hang the omentum on the specimen from left side.
Okay.
I will demonstrate you that in some time. What are they?
Bowel Jasper.
Come here. Because here. Spatula, na? Come.
After laparoscopy,
That is why there is no space.
done well and visualized well only when is সালা এদিক দিয়ে ক্যামেরা দেখাচ্ছে পা উপর দিকে মাথা নিচে
Yes, please. Cutter is not connected.
এরকম করতে হয় না
35.
একজন এক এক সময় ফিক্স লোক নাই সাজে দিয়ে ভালো
Even a paramedic can.
There's no
হ্যাঁ
space.
Be very.
Because down.
You probably need to
The
use
right
one
side,
of these
right.
graspers to just
Push it down and right.
hold the
Because-
bubble.
Yes. Come here. Down,
Make
down.
it 15, please. Make it 15 and yeah, make it 10.
Okay, because no, I will do that. Wait. You just hold up.
Pura placenta. So we've released the adhesions and released adhesions. All. I've released all the adhesion. So now I've made the first time I've made the ports here, and I'm going in now. So I've released all the abdominal adhesions with the more small bowel.
Vertical up, push, bus. Come back.
तभी rectum दिखेगा.
Come there.
So can you hold the bowel like this? From you've got no. These are my ports. Take any of those two ports, whichever you feel comfortable, and just hold the bowel. Just with the mesentery, just hold it like this. Can you hold it? Okay. So what I'll do is I'll just hold it for you and give it to you.
There's a colon appears little stuck here to the posterior
Just hold
surface
it
of
like
stomach.
this, okay.
Some
Give me the
inflammatory
scissors
adhesion.
once again.
Amit, you have to improve the camera from inside left.
Yeah.
Come here. सीधा करो. See my head. Ulta, exactly ulta the way.
Actually, the adhesions with the anterior abdominal wall were because she had a laparotomy. She's got a midline incision, na?
Hold the posterior wall of
midline
stomach.
incision.
Up. Okay. Come here, Amit. Come here.
So I need to have a look at the rectum first.
उसको नीचे से डालेंगे ना तब पता लगेगा Put something from below.
वो देखते हैं अगर वैसे ही पता चल जाता है नहीं तो फिर डालना पड़ेगा. अच्छा. नहीं सिग्मोइडस को स्पंज ऑन होल्डर बहुत है. स्पंज ऑन होल्डर बहुत है. वो तो मेरे दिमाग में था. नहीं होगा तो फिर
Excellent, boss. ठीक है, thank you.
He said that it's not. ये जरा हटा देंगे थोड़ा सा.
Traction, vertical. Come back. Vertical. Harmonic. Come. See that. विकास इधर पकड़ थोड़ा नीचे उसके वर्स हाँ वर्टिकल ग्रोथ नहीं है वो थिकन वॉल है बस जेंटल जेंटल नहीं तो बंद करके पकड़ बस गॉस टू मी शो मी द गॉस ब्रदर वन मोर गॉस प्लीज हार्मोनिक मध्ये दे no wait take it out take that gauze out no out because vertical traction for RC you I can do that wait because can you show this okay come here show from the right side हाँ अभी नहीं है this is just omental adhesion we'll denude the area all the expose the हमें थोड़ा सा end down हो रहा है go back come back हाँ show me from a distance because right में ले जा हाँ show me हाँ show him हाँ hold it with both the so left hand here and the right hand up and push it to the right of the towards lever yes there should be traction here like this gentle थोड़ा ऊपर gentle बस come here now Amit थोड़ा what we are doing is creating a plane between colonic vessels and the epiploic vessel. Yes, lymph nodes will take up with the gastroepiploid. So, थोड़ा सा come back. थोड़ा सा विकास इसको ही पकड़ ले मुझे लगता है तो हाँ ओके छोड़ दे विकास उसको leave everything just hold this epiploic vessel this part which I am holding take it to the left gentle come here Amit Right. रुक जा। अभी पकड़ेंगे। स्टमक पकड़ो, इट लाइक वेसल पकड़, लीव दिस, आई विल टेल यू। स्टमक हियर, हाँ, yes, that is okay, vertical, vertical, and the other hand for the people like vessel, like this, ऊपर थोड़ा, हाँ, ये नोड है, hold it here, hold it here, थोड़ा आगे ले जा सकते हैं स्टमक को राइट में, ओके, अमित सेंटर, can you improve the vision? Vision, pancreas horizontal, pancreas should be horizontal, come back. Center, this should be center, harmonic should be in the, come back. Traction आ गई क्या? बट उस पर ट्रैक्शन आ गई। पिपलाई को उड़ाया क्या वेन को? अभी तक तो मैंने डिसेक्ट ही नहीं किया है। देखता हूँ। नहीं ये नोड है। हाँ यस। ठीक हो रहा है ना अमित? अम्मा ट्रेन है। दिखेगा इससे दिखेगा। सीधा सीधा their imagine their view and my view, but it has to be सीधा। अपने को भी देखना है और लोगों को भी देखना है। आज तो ना वेन मुझे लगता है कुछ तो इंजरी हुआ है। हाँ देखते हैं। नोड बड़े इसका। हाँ है रिएक्टिव बट बड़ा है। ना मैं ले रहा हूँ इसको. Come here. Because actually speaking, I cannot see. Huh? इसको उड़ा रहा हूँ. सीधा कर सकता है. नहीं, उल्टा उल्टा. That side. पीछे आ जाओ. Come back. हाँ. Yes. वेन गया है वो. हाँ. 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 ओके. और डिसाइड करना है सर यहाँ पे. कम हियर. कम पीनट हियर. Clean is this. Clean this. Okay. Vikas, leave the vessels and duodenum vertical. Vertical. Pancreas push it down. चल दे पटकन दे ब्रदर. ब्रदर ठीक है दे. Come on. Fraction is good, Vikas. Maybe we have to define the GD anatomy. We cannot blindly take the vessel. Come back. Traction come on. Good job. Come back. Chal, leave. Come back. Clean. ठीक है. No, we will do because the anatomy is unusual. I am trying to identify the GDA. We will define the GDA, and then we will define that the epiplug is where is it going, how is it a continuation of GDA, and then only we'll take it. Because we don't know whether it is a dominant hepatic artery or not, because the CT was like this. Your vision has to improve. Here. Come back. Yes, perfect. ज़्यादा नहीं, थोड़ा सा विकास. पीनट ले लो पहले. हाँ बस. ज़्यादा नहीं. Okay. No, the vision is not good. Think about the delegates. Straighten it. Sorry, I'm गुस्सा मत होना. मुझे बोलेगा ये साला गुस्सा करता है. हाँ, I will think so. Yes. So this was a branch there. We'll preserve this. Come here. Okay, Vikas, push this down gently. Peanut would look beautiful. This is not looking good. Okay, take the peanut. Take the gauze out of vision. Push this down. Come close. That's okay. Come here. Focus, please. लेफ्ट गैस्ट्रिक आज बचाना पड़ेगा सर. बचा के. हाँ, yes. But I'm through epiploic and right gastric. I'm through. So now I'm ready to take the duodenum stump in next 5 minutes. Come back. ले रहा हूँ हाँ नहीं नहीं गैस्ट्रो प्लग नीचे these are small branches okay come back because can you hold this now this part जा मैंने जैसे गया था वैसे गया था भी चलेगा ट्रैक्शन चाहिए बस हाँ बस कम हियर just no here peanut right lateral traction now that's it goes to me come in sure. Come in best that's okay this foot out come back नहीं ट्रैक्शन ज्यादा हो रहा है तेरा come back वो वाला नहीं नीचे वाला चल दिखाओ दो ब्लीड रोक देते हो हाँ ये है ना हो गया ना कम अभी ले लेते हैं हाँ बहुत हो गया इसका नाटक नहीं कान शो मी हियर अच्छा ले लेता हूँ हाँ ये ले लेता हूँ विकास हाँ अमित इज फाइन हाँ come back leave this leave this come here okay ठीक है show me this come sorry Echelon blue ready हाँ चलेगा कम so I don't think इधर कुछ है हाँ ये ले लेना पड़ेगा चल सीधा कर show me सीधा come back ये नोड लेना पड़ेगा हाँ इसमें जो वेन थी ना है ना मुझे लग रहा है ये लेना पड़ेगा वेन है क्या वेन है वेन जीडी दिख ही नहीं रही है ये एसएमएस से आ रहा है हाँ ये एसएमएस से आ रही होगी ना आज हाँ दे नेक्स्ट कर दे मेरी नेक्स्ट कर दे सीधा करो केमोलॉक रेडी कर स्पेशल में गया क्या नहीं? दे वो नोड एक नीचे है, वो निकालना पड़ेगा, वो नोड निकालना पड़ेगा। हाँ one more. Node separately look, okay? जरा हार्मोनिक क्या दी, गॉस दे तो, गॉस, show me the gauze. इसमें ना एक वेन है, मेन प्रॉब्लम वो है वो नोड में करने नहीं, वो यहाँ से तोड़ी है ना, लेकिन हमने उसको ले रहा हूँ। हाँ? थोड़ा रिस्की है लेकिन ठीक है। टिप ने अगर कुछ लीड करा है तो ही है। हाँ मोस्टली नहीं होगा। मस्त कर लो, जाने दो, कुछ नहीं होगा उसको।
Vikram,
हाँ.
what you have done is inside of audience, you just
Okay, so can they hear us now?
Yes.
Okay, so you
Anish, can you hear me?
Yes, sir.
Hello.
Yeah, so I'm just going to ask Dr. Randeep, there's an unusual finding here. Randeep, do you want to tell us more?
Yeah. So what we've actually done a complete adhesive lysis here, and there was this particular last loop which was stuck to the. So this loop was actually stuck
then we'll describe.
somewhere here in the pelvis. Can you show me the? It was stuck here. It was stuck somewhere here where I released those adhesions, and you can see actually maybe a fistulous communication. And after that, we requested Professor Pavninder Lal to just put in a speculum or a sponge-on holder through the rectum so that we can actually identify the rectum. Now, when he did that, there was actually pus oozing out from the vagina, and this pus was coming in. It was quite copious. So that's when we realized that probably there would have been a fistulous communication with this part of the small bowel onto the vault, and that is why the vagina is showing this copious kind of pus collection. So what we've done is we've released the adhesions, we've taken a swab for culture sensitivity, and we don't intend putting in the making the pouch and doing an anastomosis when the vagina is draining that kind of pus. We will of course bury this particular area of the probably the fistulous communication. We'll just suture it and bury it, and maybe come back later on once the vaginal infection is fine. We'll come back again to do the ileal pouch anal anastomosis. We've seen the rectum is actually just about 5 centimeters from the anal verge. So it's by and large a total proctocolectomy has been done. So it just requires the ileal pouch anal anastomosis. We actually don't need a proctectomy here. Professor Lal has actually measured from the anal verge. It's about 4.5 to 5 centimeters. So it's a complete proctocolectomy which has been done. So now the next step is we'll just close this, call it a day today, come back again, and then do the pouch with a ileal diversion, and to probably do a ileostomy closure at a later date.
I'm just going to ask Dr. Nilesh, GI surgeon with us, who was going to do the pouch, for his comments. Nilesh, how would you manage this and take this forward?
So whenever Roy calls me to do some surgery, make sure I don't wash up, because the blood bank has a problem. But jokes apart, I think this is a very important finding or discovery. At the last time when we were releasing these adhesions, they were very dense, and there was some suspicion of a fistula there. And the moment we saw in the vagina that there was flying pus, we immediately took the decision not to do any surgery for pouch today. The second issue is where we'll have to then confirm after she settles down, that to make sure that there is no fistulous communication between the vaginal vault and the rectum before we actually do the ileal pouch and anastomosis. So we've taken the swab, given antibiotics, and then wait for a few weeks, do a CT with contrast from below to make sure that there is no communication. Here we are observing that this communication could be from the ileum, but before we anastomose the ileum to the
This is the one.
lower rectal stump, we must make sure that there is no fistulous communication there at all. Otherwise, you are going to have problems of the pouch. So we are not going to really do any pouch surgery today and wait for at least 6 weeks.
Thank you, Nilesh. So having done this, I am going to ask Dr. Randeep whether we can shift video to the hepatico-jejunostomy next door.
Sure.
Any final words, Randeep? We'll just have to call you back next month to do the pouch again.
More than happy to do that, because resolysis has been done more than
I think the difficult part we got you to do. Now we'll do the easy pouch later. It won't be as bad as we going
I
again.
hope she doesn't develop adhesions again, but yeah, all the same, I think wise decision.
Excellent job. Good adhesiolysis. Well appreciated by everyone. Dinesh, can you shift the audio, the video to from OT3 to OT1, please?
Yes, sir. OT1, you're live, sir.
Right, Jay. Nathan. And given the audio as well, please.
Yes,
Stop
sir.
the video from OT3.
Yes.
No, you got OT1 and OT3 now. I want OT2 and OT1 online.
So now currently we are at OT1 here.
No, we are still with OT3. I'm seeing both signals here. OT3 को बंद करना है दिनेश भाई.
Okay, sir. बंद कर दिया, sir.
Hello, sir. Am I audible?
ये सूचर भी इधर से जाएगा.
Yes, sir. Can you hear us, sir?
Oh, yeah, very well. So good evening to all. Good afternoon to all. After a long time, we are back with a live surgery with in-person meeting. So for that, we should thank Roy sir and the team for doing a tremendous work in arranging this workshop, Laparoscopy Unlimited. So big thanks to the team for making these wonderful arrangements. With that introduction, I'll come to the surgery as such. What we have done, this is a post-cholecystectomy hepatico-jejunostomy, bile duct stricture with the stones upstream. So we are planning for the stone removal and hepatico-jejunostomy. Initially, the previously 3 years back, it was laparoscopic converted to open cholecystectomy. And now patient had a stricture in the bile duct. The stricture could not be dilated with endoscopic methods. So there is and if you could look at the MRCP, we have nicely dilated duct with our cutoff 2 centimeter below the confluence.
Hello.
It's about
this is the one or the other one?
E3 is more than 2 centimeter, less than 2 centimeter is
Oh, this
E2.
one.
It's about E2 Strasbourg classification E2. And for that, we are planning for a hepatico-jejunostomy. I have done a little bit of mobilization. Here you can see it's a good indication now. Already the liver is showing some micronodular changes. As you can see, surface is irregular. I think high time now we should do a biliary diversion to prevent it
Just
from
hold the
progressing into a
graph from here.
full-fledged
It is
biliary
possible.
cirrhosis. So
Is it possible to hold
initial,
the
because it's a lab converted to open, we have put the first trocar at the Palmer's point using 5 mm scope. Then we transferred
Yes,
the
sir.
camera to the umbilicus and then started doing the
just stabilizing
adhesive
the
lysis. Last half
so
an
that
hour,
I don't have a
I have been doing the adhesive
not
lysis here. And then now we have not reached the porta, but still we are just reaching there. Stomach is adherent. As expected, we can have lot of adhesions in the porta because surgery is already done, open surgery. So now we have to carefully look for the porta and the dilated biliary system. You can see the stomach is getting pulled up here. Probably I may also do it from here. So my take is wherever it is easily coming, we have to go for it rather than have a fixed plan. You are joining us at a very crucial time. So we'll be slowly, carefully, very meticulously, we'll be going there and then say, try to access the anterior wall of the dilated bile duct.
Senthil, I'm just going to shift the audio there.
Yeah, sure.
Before I shift the audio to E2, I want to welcome a special guest, Dr. Abhay Dalvi, who's been a teacher to all of us and is president of ASI. He is in the audience now, and we'll be joining him shortly for the external committee meeting. I also want to welcome Dr. Jaising Shinde and Dr. Jyotsna Kulkarni, all from Pune. Welcome, Madam Jaising, Abhay. Nice. Thank you for coming. And with this, I would ask Dinesh to shift the audio to OT2 to Dr. Chaudhary, please.
Yes,
Dinesh,
sir. OT2, kindly speak, sir.
Okay. So welcome back to OT2.
Okay. Oh, sure.
Can you hear us?
Yes, sir.
Hello. So you can see that we have gone to the origin of the celiac artery here. So
definitely, sure.
Push it down.
ICG, please.
So this is the celiac, and which is giving rise to the left gastric. And now we have connected this left periportal dissection to our crus dissection at the crus. We have also finished level 6 dissection while you were in the other theater. Like this. You can see that this is the last part of the left periportal dissection which is remaining, which we have completely, which will now connect it to the left periportal dissection. So the celiac lymph node dissection, we are connecting with the left periportal dissection, and finally we will reach the right crus. We don't have to go to the, we don't have to go to the right of the portal vein or behind the portal vein. All bus clean, please clean. Come here. Show me.
Just
Here.
take.
Let's show the crus.
Just bury it.
And now this left periportal dissection will be connected to the dissection on the crus and the right of celiac. And this completes this part of the D2. Once this part of D2 is complete, I will go back to the level 6 lymph nodes and will then take the duodenal stump.
Show us to the level 6.
Okay. So come back. Show. Let's show them this.
So you have dissected well there.
Show this dissection. Show this. And ये खत्म कर देते हैं. ठीक है?
Okay.
Just हो गया होगा. So you can see that most of the dissection is complete on this part. You want me to go to the level 6? ठीक है. Come this. And now we are ready here with the duodenal stump. Come, hold this.
Thought we will just bury
I have
it.
already clipped and dissected, so you can see
So
the
that,
completely dissected and bed pancreatic head area here. So all the level 6 lymph nodes have been taken. This is the left border of the duodenal stump. Right gastroepiploic artery and vein have been dissected. These are the lymph nodes, straighten, horizontal, the pancreas horizontal. Okay. And now I am ready to take the right gastroepiploic vein and artery. I think we'll take them together.
Just take one more bite and we'll just tie it. That will bury the whole thing.
So now
Actually,
we
it
have
just
completely
requires a bit of
dissected
stabilization.
the duodenal stump.
What level you are going to?
I still don't feel there is a fistulous communication, but I don't know.
So the desired distal margin is around 2 centimeters. but any negative margin is acceptable. So so approximately 2 centimeters
Actually, I
into
require
D1,
a counter.
something that I will target for a normal growth. If growth is moving towards duodenum, my aim will be to take at least 2 centimeter gross margin on the serosal side. Come back. Show me the back side of the duodenum, please. Leave because
What stapler do you use?
most of the times I use a blue reload of echelon from this side because yes, mostly it would be an echelon. So now you can see that duodenum is ready for transaction. The last the most important is not to miss any lymph node at this level. For a distal gastric tumor, level 6 lymph node and level 5 lymph nodes are very important levels, and completely bearing the pancreatic head is the trick to taking the.
But okay, we've let's closed it completely, isn't it?
For the audience, you can see that he's taken the gastroepiploic vessel right on the pancreas.
So your aim, yes, sir. So your aim should be, so in this patient we had an anomaly. Usually your
Take
limit
one
of
more,
dissection.
but not required really.
Yes, can you hear us?
This is already there.
Okay. So usually what will happen is your aim is to expose the gastroduodenal artery here at the anterior border of pancreas. Because in this patient there is an anomaly, the gastroduodenal artery is coming directly from the SMA, and therefore you cannot see the gastroduodenal artery as a guide to your level of dissection. So when Dr. Mahadev asked me what is your limit of dissection distally, usually adequacy of dissection on the duodenal side is exposure of the gastroduodenal artery. Once the gastroduodenal artery is visible at this site, your duodenal dissection is considered adequate, and then you can see that the complete lymphadenectomy at pancreatic head and anterior to the pancreas has been done. The level 5 I already demonstrated. So now I'll just take my stapler and fire here, and then we are through. Sir, stapler.
Stapler.
नहीं हो गया ना, क्लियर है कुछ प्रॉब्लम ठीक है चलो इशिलान आपको इसमें हेल्प लगेगा so this is a echelon flex 60. This is a powered gun. So we today for a workshop we have the luxury.
What is the advantage?
See the. So leave everything. I will tell. Don't worry. Just a minute. Just let me adjust. Okay, just a minute. Come show me. Show the upper. इसका मूवमेंट कैसे होगा? एंगल इसका एंगुलेशन का थोड़ा प्रॉब्लम मैंने वील हैव टू रोटेट इट ना हाँ थोड़ा स्लाइटली ग्रास्पर टू मी आ जाएगा कम no that's okay not a problem हो रहा है पोर्ट थोड़ा बाहर लेगा no it's okay this is correct okay can you see so we are stopping at the upper border of the pancreas here the stapler can be adjusted angle but today I don't think I need much angle change here okay so once you go in completely you clamp it leave everything and then you see the other side so if you reach the other side and it is not taking परत काढायचं कसं अनलॉक unlock it plus okay so now I am happy with the clamping here come back fire Yes, great. ठीक. So advantage with the powered gun would be there will be no jerky movements which happen when we have to fire the blade through the stapler of the ender stapler usually. So that's probably important when you are firing a stapler, which is as important as a duodenal stump. So let's go to vessel here. So now I have focused my dissection towards the celiac and the left gastric. Today I will have to preserve this left hepatic artery. Therefore, the left gastric artery will have to be preserved. And therefore, these three branches which are giving branches to the stomach, you can see 1, 2, and 3 branches which are going to the stomach. I will preserve all three of them. Harmony. Back here, get peanut here, here, at the origin. Okay. Come here. Bas.
We are going to bear the vessel.
Yes. So all the three branches which are going to the stomach, I will have to bear them. Come close here. Develop. Next step. Next step. बराबर था विकास. Develop ready, brother. Okay, दे हिमोलक दे. ठीक है चलेगा. ठीक है. हार्मोनिक. चल आगे. बाद में लेते हैं. कम हियर. Hi sir, how are you? Oh, Dr. Nilesh Doctor has joined us in theater. So this anatomy was little unusual, sir. Level 3, type 3 anomaly, and I had to be little. Himolak is ready. ले लेता हूँ पहले इसको. हाँ. आर्ट सेट करके. Okay, gauze to me. Come back. Gauze. लेफ्ट साइड का नोड लेना पड़ेगा. सब विकास पीनट हियर. पीनट हियर. बाद में लेते हैं. ठीक है. चल दे हिमोलक. Vision. Not happy. There was no click. देखते हैं. Gross. सीधा करो. उल्टा. Like this. Okay. Because let's go to the left. Huh? Pull the pancreas down and to the right. Down and right. I'll show you. Come back. Yes.
Where is your dissection is going on now?
So now I'm gradually moving towards the audience is with us.
Yes.
Oh, sorry. So now I'm gradually moving towards the dissection and exposure of the splenic artery. So I have
You have clipped small vessel.
yes. So all these branches which were going to the stomach from the left gastric artery have been clipped, and the left hepatic artery has been preserved, and all the lymph nodes which were surrounding the celiac and the left gastric artery have been dissected off, which I will round them off later. You can see that they will go up, come back. These lymph nodes will go from here, they will go to the specimen now. Okay. So all the dissection has been, can you push this down with us? Gentle, just this one. I'm taking this completely. Huh? So now I'm finishing the remaining part of the crust dissection. Come back. Now, no, celiac to the right now. This part to the right. This one. Bus. Come back. Gauze. कैसे निकालेगा? बाद में निकाल. Biopsy force पे brother. Come here close. Come back. Wait. Vessel है? There's no vessel there, no? Give me the cautery. No, it's okay. There is a small vessel there. Straighten, Vikas. This retraction. Gentle. This one. Suction, cigar suction. Yes. So we are done with the left gastric artery dissection and the celiac dissection. Come back. So I will show you the dissected bed. So you can see this is celiac artery, and which is giving, and you can see the completely dissected crus. So level D2 lymph node dissection is complete. We'll have to take this one node here. Okay. Can you hold? Can you hold? Yes. Yes. Okay. Leave. Push down. This is the final lymph node in this area. The new gauze, brother. Wait, leave. That's okay. Gauze. Brother, Adun pasta gauze, please. Leave this. Nodes layer. Okay, take this out. Take this out. Brother, gauze, please. Dha gauze give to. Take this out, brother. Galat. Should be. Most of our dissection is done. 1.5 hour probably total. Yes. GJ is the last step only. And it is a part of the resection only. So that's
Yes. Vascular anatomy elaborate. In sake of audience, we just talk these are branches.
So are they hearing us now? No. Oh.
Hello.
Acha, oh.
Hello.
Hello.
Can you hear us?
Yes, sir.
Yes, sir. There's been no input from the audience, questions and things. We are waiting here.
Come. Peanut, please. Peanut on the gauze. So now my next step is
1 second, sir.
I'm going to complete my dissection along the splenic artery. Come a little away here. Upper border pancreas. Thoda away. Yes. Yes. Sorry. So my next job and the last part of D2 probably, except the level 4, is to finish the splenic artery lymph node dissection now. So you can already see here, probably this is the splenic artery region under vision. So once you start dissecting at the upper border of pancreas, at some point of time, you will get the splenic artery under view. This lymph node along the left border of crura is sometimes left behind. So if you finish the right dissection and then go to the base of the celiac on the left side, then you are not likely to miss that lymph node. But you have to make it a point to take this out. The splenic artery is still not under vision, but I think but we'll get it. So we continue our dissection on the retroperitoneum along the upper border of pancreas and the crus, and eventually you will see that we will have the splenic artery under vision somewhere. Pancreas retractor. Yes, good. So I have some hint now here about the splenic artery. This probably is the splenic artery. So now the trick here is to go directly on the artery. So once you go directly on the artery, you avoid bleeding from the lymph nodes and also from the pancreas. And that also ensures complete, okay. Come. Okay. This is the artery. I think now the splenic artery is under vision, and even the audience must be in a position to recognize its course. This is probably the tributary which is arising. There. Okay.
Yes, sir.
So now I'll disconnect this lymph node from the retroperitoneum. So what a gauze milega, gauze. Brother, gauze, please. Any doubts from the audience? Any questions from the moderators or audience?
No, sir.
This retraction with a gauze in this area so our aim here is to in a subtotal gastrectomy you have to preserve the two posterior short gastric vessels. Okay, upper border of pancreas because upper border pancreas retract like this away. Yes, bleeding recorded. So the dissection limit of dissection here on the splenic artery is towards the splenic hilum, but you have to ensure that at least two posterior short gastric arteries are left behind for the survival of the gastric conduit, which we are going to leave behind. So as I said, if you keep on dissecting on the artery, you will take out all the lymph nodes, and you will also ensure that the pancreas bleeding from the pancreas does not happen. So you have to work on the artery. So except now we will be through the complete D2 dissection in next 5 to 10 minutes. The only lymph node group which is remaining is level 4 or the left gastroepiploic, which we will be taking while we take the momentum. The splenic artery course is very tortuous, so you have to be aware of change in direction of the course. You just can't keep on taking it in one direction. You may end up injuring the main splenic artery somewhere. No, this is just a posterior short gastric. Come here, Chaldikas, there. No, come. Okay, push down. So now you can see that this is a major posterior short gastric vessel. which we will take, and that will be the limit of our dissection. Wait. Hemolock ready, brother? You can see the adrenal under vision behind posteriorly. So if you can see the adrenal on the retroperitoneum, that's the plane of dissection in a patient who has a non-T4 B tumors. Come here, come here. सीधा करो. No उल्टा उल्टा उल्टा. Come here. Here. Press horizontal होना चाहिए. Press should be उल्टा. Yes. Some more. Come here. We'll finish this dissection off. सीधा. Come here. Pancreas. Come back, Vikas. Come back. Vikas, you are pushing. Pull. Yes. Yes. Come here. Here. Come back. Come back. Come back. Can't see. This is a node here. नहीं नोड है छोड़ देते हैं हिमलॉक brother. This also needs to be disconnected from the hilum, because once you start dissection along the lesser curvature, they पहले हिमलॉक दे. You finish the posterior dissection completely and take this dissection to the curvature, lesser curvature of the stomach. Harmonic.
You took the posterior short gastric?
Yes. So there will be 3 to 4 short gastrics. 2 or 3 of them will be posteriorly. 1 or 2 of them will be anteriorly. So this one posterior short gastric you can safely take. You can see that. Yes. No. So I will aim to preserve 2 short gastrics. And now you will see that I will convert my dissection away from the splenic hilum. So you can see the spleen under vision here already. So now my aim is to denude the stomach for and eventual preparation of the condu. Show the splenic artery. So we'll demonstrate the splenic artery to the audience once. So you can see that complete splenic artery lymphadenectomy has been achieved here. And the splenic artery can be viewed here. Yes, and this is the splenic vein. This part is the actual splenic artery hump. But beyond this part, I am not going to dissect the splenic artery any further because this is a subtotal gastrectomy. Gauze to me, please. Gauze, brother. Gauze. Gauze margin here. Liner gauze. So now the easiest part of this resection is omentectomy. So I will see if I can do the level 4 dissection now, and I will finish the level 4 dissection first for the sake of audience, and then we can do the leave that because leave that. No, I think we'll have to do omentectomy first. Huh? Omentectomy. So come on. Yeah. Here. No, this one only. Only this. Up. So fortunately, I could get the level 4 here easily. You can see the anatomy here. This is the lower border of the pancreas. And these are the, show the epiplex vessels. This is the short gastric which I was talking about. Hey, come on, hold. Up. So now I will preserve these two short gastrics. So this is one posterior short gastric. This is probably the first anterior short gastric. So we are going to base our conduit on these two short gastrics, and we are going to take all the remaining vessels from this side. So that's the plan. And now you can see the lower border of the pancreas here, and this is the area where the gastroepiploic artery will be arising, the left gastroepiploic. So at the upper border, at the anterior surface of the pancreas and at the lower border of the pancreas, we'll start our dissection and we'll try to go to the base of the epiploic vessels. Avoiding injury to the pancreas at this part of dissection is absolutely important. Can you pull this down? Pull on. Yes. It's okay. So I have not taken the omentum. So there might be few extra tissues which I have to take. Yes. Thank you. But you can see the lower border of pancreas. So keep on seeing the lower border of pancreas. That's your reference for complete removal of lymph nodes and also to avoid injury to the pancreas itself. Many surgeons do not pay heed to this area of dissection, and I believe many surgeons end up leaving this group of lymph node behind because many of them tend to leave behind a large conduit. A radical operation, you should not be leaving anything more than 30% of the gastric remnant when you are doing a thanks. So when you are doing a gastrectomy for a cancer, your aim is to take at least 70% of the distal stomach, and that's why it is called as subtotal. And only when you take that much of stomach, you are probably going to ensure that you have taken out all the lymph node groups. So that's important. Come here. Another trick in this area is to avoid the vessel which is going to the splenic hilum. So you can see that this branch here of the epiploic is going to the splenic hilum. Come back. Gauze to me. Show me the gauze. Whether gauze. That gauze is for that bleeding there. Come there. Whether how many gauzes are inside? Okay. So you can see that. So come this. Splenic किधर है? We have to continue. So while you take the gastroepiploic vessels, you have to ensure that the branches to the splenic hilum come back. We'll take this node itself. So I'll focus my dissection on taking this node. I don't know if it is appreciable on that screen, but you can see that once you go to the base of this node, you will see the epiploic vessel itself.
Yes, sir.
So I will dissect out this node carefully. Come close. Come close without end on. So what we have to do is to take the epiplike after it takes the splenic hilar branch, so that you avoid splenic polar ischemia. Okay. So this is the short gastric which we are going to preserve. Therefore, we'll denude this area and we'll connect it to the spleen, this part. This is nothing but a vascular plane. Come back.
So we have a question from Dr. Suraj Sundaran from Vellore, stating in a T2N0 disease, what is the likelihood of finding a omental disease? And is it necessary to do a complete omentectomy in the same case?
Yes, so there has been a recent trial, and Japan and Korea, they have moved away from doing a complete omentectomy for the patients who have T1 and T2 disease, and even few centers don't do it for T3 disease. The recommendation till now was for early gastric cancer, and partial omentectomy is a standard of practice for early gastric cancer. But even for locally advanced tumors or T3 tumors, few centers have stopped doing total omentectomy. But in our practice, finding a patient who is a T1, T2, like this patient, is a rare finding. 90% of our patients would be locally advanced cancers. So as far as our practice at TMH is concerned, most patients would undergo a total omentectomy for a radical operation of stomach cancer. Yes, but I am aware of the evidence, and come here. Come back. Come back. I'm not able to take this. So I have dissected the left gastric epiphyseal vessels, and we have taken all the nodes along the left gastric epiphyseal for sure. But I have not yet seen the splenic branches of these vessels. So I am just, as of now, I am not taking them. I think I can take them safely. Huh? What do you think? So this is the lower border pancreas. The pancreas is safe here now. So now I will make window at this level of dissection. This is a vascular dissection. Now you can see this. So we have dissected at the lower border pancreas. You can see the nodes from the base of the epiphyseal artery have been taken. And now we can safely clip this artery here. Harmony. Then come back. Karna again. It's okay. We'll see. Mostly it won't be. Okay. So all the lymphadenectomy is complete. The only step remaining now is omentectomy. This is not the sequence which I always follow, but today it looked feasible. For the purpose of demonstration, I did this, but otherwise I would do the omentectomy in the beginning. Leave everything. So now you can see that there are these two posterior short gastrics will supply the stomach. This and this one. Rest of the dissection is complete. Now the only step remaining is now denuding the stomach of the omentum and the lymph nodes. We finish this? Huh? No, hold it here.
Dr. Vikram, good evening. This is Dr. Prashant Rao from Sion Hospital, Surgical Gastroenterologist, Sion Hospital.
Hi, Prashant. Hi, Prashant.
Sir, meticulous dissection, very wonderful dissection, sir. Very nice to watch it. Sir, my question to you is, sir, is it not a routine to do bursectomy at present?
So now, Prashant, you're aware. I'm sure you're asking this for the sake of audience, and you are aware of the evidence.
Yes, sir.
But I will still answer this. So yes, the large Japanese trial, the JCOG, the initial trial, the Osaka trial suggested that probably the bursectomy is beneficial. So everybody was doing the bursectomy, and you all know that the bursectomy is associated with significant complications in the form of pancreatitis, bleeding, and therefore the bursectomy was always questioned for its oncological benefit. So large trial, I think more than 1100 patients in JCOG trial, which clearly documented that it is only associated with higher pancreatitis rate and bleeding rate, and there is no benefit in the survival. And therefore, for all practical purposes, the bursectomy for non-T4B patients has been given up. So even at TMH, we would do it very, very selectively. For most elective gastrectomies, bursectomy is no more done. It is only complete omentectomy. And bursectomy would be done for patients who have T4A or an obviously large serosal disease, where probably we are still not sure whether this is a selective subgroup where bursectomy can help. Yes, so these are the patients where we consider bursectomy, Prashant. But otherwise, I don't do bursectomy anymore.
Thank you, sir.
Yes.
Which are eroding on the posterior
Yes.
part of the stomach.
So that's what I said. Yes. So T4A, any patient, any disease which is going to the serosa or which is involving the adjacent structures, these are the patients where we would do an elective bursectomy. Otherwise, no.
Sir, your right hand working port is on the right side of the abdomen.
Yes, so I am standing on the right of the patient. I follow this Korean technique. Many patients, many surgeons prefer to stand in the between the legs. My colleague here, Vikas, who is also a fantastic laparoscopic surgeon, he prefers to stand in between the legs when he does the lap gastrectomy. So yes, either you stand between the legs or stand on the right side. My preference is to stand on the right side.
Thank you, Dr. Vikram. We would be now shifting to OT1, where there's a hepatico-jejunostomy going on.
Sure. I think I will call you only when the omentectomy is done, and I'm in a position to show you something meaningful. Next step will be omentectomy only. नीचे से आना, ये तो डिस्कनेक्ट किया है ना मैंने.
OT1, can you hear us? OT1.
Camera straighten करो. Come here. Camera is straighten. Yes, you can.
Let's cut.
Sir, can you hear us? OT1?
Yeah.
Yes, sir.
Scissors.
Sir?
Yeah.
Could you explain us what is?
So you are connected now.
Okay.
So hepatico-jejunostomy is in progress. As you can see,
Right.
the bile duct has been exposed by. Is there anything you want to mention, Senthil, regarding the?
Yeah, I'm
next step?
slowly, carefully enlarging the opening. You can see the stone here.
So we have a question from Dr. Vinay Mendari, sir. Could we do a choledoco duodenostomy in this case instead of a hepatico-jejunostomy?
Yes, we can do. But I'm not sure about the mobility of the duodenum. Curved, please. Curved. One more curve, please. Can you see the stone?
Sir.
Hello?
Yes, sir.
Am I audible?
Yes, sir.
Okay. Every millimeter I'm cutting. Okay, you can see the stone.
Right,
Now, suction please here onto my left.
Can you just quickly orient the audience? They've just come in to,
Okay.
where is the liver and
Right, sure. So now I have mobilized here at the porta duodenum. This duodenum, for those who have just joined, this duodenum was stuck over the bile duct. I have to carefully separate. My dissection was more towards the bile duct rather than towards the duodenum. So now I have removed two stones. There were two stones. One stone I have already removed, as you can see here. Pre-op imaging showed one more stone. So that's you can see it's here.
Right.
I'm just try to take it. We also lost the image. We'll just do the white balancing. As far as possible, we should start at the lower border of the bile duct, so that we all the anastomosis we should do low, and then we go up so that we don't lose a good chunk of dilated bile duct below. So that's the idea. So I think here patient's meticulous dissection is very key, important. And the learner team, suck. It's sucking now. Yes. No, you
so
do.
if you
No,
have a
don't,
long
no,
length
just
of
leave it, yeah.
bile duct, you would not necessarily dissect the hilar plate or.
Yeah, lowering the hilar plate is required. If I don't get adequate space, just this is enough. Adequate space for my anastomosis. Then see, we have to go between the liver and the bile duct to lower the hilar plate. In this case, probably may not be required, as you can see. I'm just nibbling my way. Try to remove it. My opening was slightly smaller. Okay. Still one more stone in the right hepatic duct. You see?
Yes, sir.
Okay. So this confirms the preoperative MRCP diagnosis. Good camera work by Ankur. You can see the. Can you see the confluence?
Yes, sir. Very well seen.
Okay. Thank you. Very good camera work. Come on. Now, in fact, we can go on this side. Maybe I may need to do a little bit of hilar plate lowering so that I can cut it here and then do the anastomosis here. I think I will be doing, you're right, initially my thought process was also, here we can go towards the right or towards the left as we go, because this, you can see, beyond this, fortunately, wherever we have opened is at the lower border. There is no duct below this. This is the stricturous portion. So we are just opened little above, exactly above the stricturous portion. Now I have the option of going on to the left system or onto the right system. I'll just see which
Left system,
is.
you'll get much more length.
Pardon, sir?
Left system, you'll get much more.
Yeah, I was also thinking left system. You see, I can go all the way up to here.
Yeah, you could just lower that plate a little bit
Yeah,
and
yeah.
then.
So this is for the youngsters. This is lowering of the hilar plate. You see, I'm lowering the hilar plate little bit more. Maryland, please, to my left hand also. I'll keep the options open. The duodenum also can come, but nevertheless, for a proper one, I think hepatic jejunostomy should be good. What do you say, sir?
Yes, I agree.
Yeah. So I'm lowering the hilar plate. You see how it's now.
Yes, sir.
So I could have mobilized the duodenum a little bit more, but I don't want to have any duodenotomy. Suction on to my left. Suck. Okay. You see, I have more. So I'm lowering the hilar plate some more. I think this should be enough. Right? Okay. Maryland, please. Dr. Ankur is doing excellent work. Again, I have to commend him for the good camera work in this very narrow space. You see, I can go all the way and divide here.
Yes, sir.
Yeah, hilar plate. I'm blowing the hilar plate. If I don't lower the hilar plate, upper limit I may not be able to see properly, and my suturing may not be sufficient. Oh, yes, just leave it. Just leave this one. Yeah, that's it. We wanted to do at least 1.5 centimeter, minimum 1.5. I love to do a 2 centimeter anastomosis.
There's a little bit of hilar plate on the right side there, where your left Maryland is. You can take that also down. It'll give you space to hold the duct. Yeah.
Yeah. Scissors. Yeah. we are reaching 2 centimeters. The first attempt is the best attempt, so that I'm lowering the hilar plate some more. I'm close up, please. Yeah. Super, thank you. At the same time, we should not mobilize too much also. It will devascularize. I'm cutting more. Okay. Yeah, sir. I want somebody to tell it's very wide. Then I'll stop. Yeah, I think this should be fine. Nilesh sir, it's okay? Yeah.
Yes, it's wide.
Here I'm guided by a learner team. Thank you for all the support. Close up.
So we have one more question from Mendel sir.
Yeah.
Should one do a choledocoscopy to rule out more stones?
No need. We can. I'll do the choledocoscope. Close. Go inside. Yeah, this is choledocoscope.
Right.
Yeah, one more. I'll just do it. Leave. Yeah, we can insert. I'll show it. Why unnecessarily you do a flexible scope? This itself will go up to the confluence, and then we can very well see. A suction, please. Yeah.
Hello. Good evening, Sendhanathan sir. This is Dr. Prashant Rao.
Yeah, very good evening.
Sir, why are you not dissecting the medial, on the left side of the duct, the stomach which is stuck to the liver? Any specific reason you are not touching it, or?
Yes, I don't want enterotomy, I mean duodenotomy.
Okay. And are you planning an cholangiogram now? If not a choledocoscopy?
No need.
No need.
This much wide duct, no need. Clean.
Okay, thank you.
I had 2 stones in the MRCP, one in the bile duct, the other one is in the right hepatic duct. I mean, common bile duct or common hepatic duct to be precise. The other one is in the right hepatic duct. Both we could able to remove. Of course, the other thing is that, just hold it please, Ankur. We have a very wide opening here, more than a couple of centimeter here, as you can see.
Yes, sir.
If you want, we can also maybe do a little bit more. I think I can cut a half a centimeter more here. Scissors, please. Yeah. By any means, I think this should be fine. See, from here, I'm getting up to this. This is almost 2.5 centimeter. I'm measuring outside. The uninsulated portion is about 3 centimeter. I'm seeing I'm at the tip, so it's almost 2.5 centimeter anastomosis. Is it okay?
Yes, sir.
Okay, sir. Thank you. Suction, please. So, suction, please. I'll take a fresh gauze, pack it here, and then I'll go for the hepatic, rule limb creation. Probably what we can do, I can give irrigation for your, since you have raised this question of choledocoscope and the other stuff, we'll give an irrigation. Irrigation, please. Yeah. Okay. Okay, so I'll yeah, I'll suck it out. Don't worry. Irrigation on. So long, sir, it's fixed here. You can see, sir. I'll just see. Why I prefer jejunum? I'm just giving a wash, both inside and outside. Okay. Suck. Closer. I should be taking a bite in the apex. Still, I think if I pull, I can able to do the suturing. Okay. So I'll take a fresh gauze. I'll remove this and then go for a fresh gauze. Suck. Suck, please. Okay. You have stone holding forceps. So first I'll remove the stone. Artery forceps. Yeah. Okay, thank you. One more? Okay. Thank you for pointing. Okay. Suction, please. Okay. I'll use a fresh gauze to pack it and then we'll go for rule limb creation. Gauze, please.
So we'll just switch to the other OT.
Sure, sure. So when you come back, probably I would have created a rule limb.
Yes, sir.
OT1, can you hear us, sir?
Are you with us in OT2?
Okay. Now you can leave it.
Can you hear me?
Yes, sir. Can you hear us, sir?
Yes. So now
Leave it.
I have finished
Okay.
all the dissection. We finished all levels of lymph
Ball
nodes.
holding.
Grasp. Here we go. And now I'm doing a Billrod 2 reconstruction while the specimen is hanging. So we'll finish the stapling part. Hold this. Okay. And then we will cut the specimen. This just no, let it be. This just saves time. So this is a different reconstruction technique which I follow. It just saves time. Take another. Okay, that should be fine. Maryland.
Just elaborate how it is different from other.
So there are multiple reconstruction techniques after radical subtotal gastrectomy. So you can completely do an intracorporeal GJ and intracorporeal JJ. I think with a lot of people with bariatric practice now, I think intracorporeal anastomosis is not very uncommon. But I don't think that much effort needs to be done here. So I think this is a new way by which you can do, where you can do a Billrod 2 reconstruction, and the gastric defect which will remain after the anastomosis, which I will ये rotate हो रहा है, port out please, थोड़ा लेफ्ट में ले जा. अच्छा इसको ओपन करना है इधर. हाँ बस. It's a red. Okay, that's okay. ठीक है. Okay, leave Vikas, leave the stomach, not the jejunum. Come, feed. You are ready? Just a minute. Leave the jejunum. Leave. Wait. Feed it from that side. Wait, I have to go up. Can you feed the jejunum to me? Careful. Leave. So now we can see that we have clamped both the intestines here. This will complete our GJ. Next green to be kept ready. We'll wait for a few seconds. Fire. We have already withdrawn the rise tube towards the esophagus. Okay. So this completes our anastomosis. We will visualize the bleeding points if there is any inside. Give me the grasper. Leave this. So you can see that there is absolutely no bleeding. So we don't have to do anything here. Okay. Green. For this part of the step, leave this of the anastomosis, I will go to the left of the patient or maybe in between the legs, so that I can fire the stapler from the left to the right. Once this anastomosis is complete, we will document, we will demonstrate the surgical bed to you. Grasper. Leave this with us, stomach. So here the advantage of this technique is you can minimize the size of the gastric defect basically. So you don't have to do too much of suturing for the gastric defect. Leave this.
You people are modifying.
Not me, but yes, something which
Learn over the period of time.
learn over the period of time.
Oh, that's good.
Leave this. Come back. I think this is fine. G junction. I think this is enough. Okay.
Great job.
Just a minute. Just a minute. Leave this, Vikas. Leave this. Yes, I will need one more. Okay. You can see that very small defect is remaining now, which will take hardly any time in closure.
Good, good.
This can be easily closed by Statafix or anything is your choice. So next. I think before closure, we'll just document the bed and then demonstrate the bed. Next, please. हाँ एक लग सकता है. Come back. I'll just keep it straight only now. Huh? इधर से हाँ. Come back. Visualize the gastric valve from both the sides. Ensure that the clips and the vessels are free, and then you don't end up firing any. Rise tube is completely inside. 25, na? Last one. Okay. So now once this is done, actually you are through with your anastomosis and you are ready to extract the specimen. So it depends upon your preference whether you wish to close this intracorporally, the small defect which is remaining for the GJ, or you can even do it by a small incision, which we are anyways going to take to do a side-to-side JJ as a part of Billrod 2 reconstruction and a Braun JJ. You can also do a Roux-en-Y reconstruction, but I think this technique saves time, and this is what I do now. Leave this.
Biliary reflex.
So once you do a Braun, leave that Vikas. The issue of the Braun, the Billrod 2 with Braun is as good as Roux-en-Y. If you ask me, as far as the biliary reflex is concerned, there are few advantages which are touted in favor of.
Technically, bronze is a Roux-en-Y, functional
Functional
Roux-en-Y. With its continuity. That is continuity.
ठीक है, बस हो गया. नहीं झालं बरोबर आहे. Harmony. Okay, take this.
We will do a JJ, no?
That we will do with a small incision.
No, I'm telling you. Once the JJ is done, then it is.
Come back. Leave this. Nothing, huh? ठीक है? Okay.
Specimen will take incision where?
So it depends. So if you want to do this closure of the defect by open technique, then the incision will be higher. If you want to do this by intracorporeal, वो निकाल देता हूँ मैं. I will come there. Come this side. So the incision on the abdomen for reconstruction depends upon whether you want to do this defect intracorporeally or not. So if you want to do this intracorporeally, then you probably have to take the incision which is higher. And if you close this extracorporeally, if you close this now intracorporeally, then you can take incision lower for the sake of JJ. So that depends upon what type of reconstruction you are going to do on forceps harmonic.
So in this patient, you are taking up.
I think I'll just take a statafix and we'll. Come here. कैसे रहेगा? कुछ नहीं है. Wall is away. Let's see it anyways, huh? ठीक. नहीं आ जाएगा ठीक है. Okay, let's document the bed. Come on. So now you can see the completely dissected bed of a D2 lymph node dissection and a completed GJ. Can you do the reverse Tenenberg? Team anesthesia.
Reverse Tenenberg. Hello.
Come. Suction, please. Suction to me. Wash connect karo. Bas, good. Thanks. So peanut. Leave this because just retract the pancreas. Come back here. Retract.
Very good.
So you can see the celiac exposed, completely denuded, left gastric and the left hepatic artery, left border of show here. Left border of portal vein can be seen.
Yes, sir.
This is the staple duodenal stump, level 4. And you can see here the level 4 lymph node dissection and the gastric conduit which is hanging on the two short gastrics. So this is a complete D2 lymph node dissection. Harmonic. Okay, sir.
Small node that you can.
Yes. I think that was when I took that. This needs to come out. We could not visualize it that time. Okay. क्या करेंगे? करना है विजिलेट स्टैटिक्स 30 है क्या? वो लाया हमने vlog statistics anything is option नहीं करना है क्या? विकास is not keen. थ्री जीरो दे दो. जेंटल करेगी नहीं करे. हाँ हार्मोनिक दे. हो जाएगा वीलॉग से. मी बऱ्याचदा जस्ट अभी if we do this now ना, then we will JJ कहीं से नीचे लेंगे. It will be more comfortable. चलो, come on, दे. Maryland and middle order and 330 Statafix or wheel or something. So what I will do is I will go from, they are not hearing us now, no? They are with us. So what we will do now is we'll go from one side to the other, and they will and then we will probably come back from there. Yeah.
Right, sir.
Maryland. Huh? Center. Wait. Thanks, Lucas. Perfect.
OT1, can you hear us? Senthil, sir?
I will shift the camera to audio to the OT1. Is that okay?
Sure. Thank you.
Yes. Hello.
OT1? Senthil, sir?
Yeah. Am I audible?
Yes, sir. Go ahead.
Okay. So we have created a rule in clean Pani. Okay. I'll be using mesocolic window above the duodenum. Duodenum is one place we can easily identify the mesocolic window because that will be the one of the shortest route. Garam pani, please. Okay. Come back, leave it to me. So just wait, hold it. Harmonic. You see, this is the third part duodenum. Okay.
Yes, sir.
I'm going to incise the mesocolon there. Yes, harmonic. Yeah, this is onto the right side of the middle colic. You can see the pulse setting. It can be left, right branch of the middle colic or right colic as such. No, you should leave it. Yeah, no, this is okay. Okay, pull it up. Yes. So we should have an adequate window. Lateral, this side. Come back. Yeah.
Please give him middle order. You tighten it first and then you hold up. Tighten it.
You see the film C?
Yes. Now hold up.
Suction. Yes. Come back. So you can see the gauze piece there. A reasonably good window. We'll see whether we need to have some more window after bowel holding, bowel forceps. Yeah. Show the ruling. Ruling. Yeah. Okay. Okay, okay. We'll see. It's not the opening, it's the is this the one? Okay. Okay, yes. Come back. Yeah. See, generally it's going without tension because we have bisected the mesentery. Come here. And for double checking it, I always do show here. We'll follow this and then see whether this is the proximal one. Come back, yeah. Okay, this is proximal. Okay, this is DJ flexure. From there, we are following. And here, this is. Okay. Right. So we'll be doing the GJ. I mean GJ here. See, it's lying comfortably here.
Yes.
Yes. Now we go to the supracolic compartment. Leave this. Head up, right up. So you can see it's already there.
Yes, sir.
Yeah. Head up and right up. Yeah. Thank you. Yes. Now you can leave it. Suction. Suction on. Okay, okay. Come back. Okay. Now you can take the grasper. This is grasper, no? Tooth grasper. See, because we don't have the gallbladder to retract, we have to find some other means to retract. Come back. Yeah. Yeah, right. Okay. Right, leave it. Okay. Suction again one. You see the gallbladder, I mean the duodenum is coming in our way. but
Yes, sir.
nevertheless, we'll retract it. Success.
Sir?
Close up.
ठीक आहे आता आपण संपूया मला वाटतं त्यांना सांगूया की वी आर डन विल टॉक जस्ट लास्ट
So that's
if possible.
So we'll just go back to the other OT. They are finishing almost.
Sure, sure. Ball loading.
So they will be us or what?
Thank you, audience with us. OT2.
OT2?
Hello.
Yes, sir. Can you hear us, sir?
Vikram.
Okay, so now we are just through the anastomosis. Second layer probably we will take when you will be in OT1. So I'll just make some closing remarks. So we are through with our GJ. You can see this.
Yes, sir.
We'll take another layer here. I have already documented the surgical bed to you.
Yes, sir.
Now the plan would be to just check for the hemostasis, give some wash, and probably give a small incision in the periumbilical area, and then finish off with the JJ by a side-to-side staple anastomosis. So is that okay?
Yes, sir. Very well demonstrated,
Okay.
sir.
Thank you. Goodbye.
Thank you, sir.
Okay.
Thank
Thank you very
Vikram.
much.
You have demonstrated very well.
Thank you.
On behalf of the Zen team, I'm just
Hear the applause, sir.
please.
Thank you. Thank you.
Excellent, Vikram. Fantastic.
Thank you. This will, I think, will take second layer open technique. Chalo. I'm leaving it as it is only. Huh? With the needle. Thank you. Thank you very much. Wash this. ठीक हो गया हाँ हाँ बाय बाय ठीक है कुछ अभी लास्ट टाइम राइट इपिप्लॉइड में ब्लीड हो गया था
Senthil, sir, we are with you now.
Sir, can you hear us?
I may need one more 5 mm trocar. Yeah. Yes. Oh. Yes. Yes.
Huh?
Yeah. Triangle.
I think patient थोड़ा अपना लग
So here we don't know whether there is a fistula or not, but anyhow, I am closing it.
renal rise tube you can make it 40-45
Here?
centimeter so that it is placed on the
Come
stomach.
back.
We'll take out the rise tube tomorrow. Come back. अभी डालना है? देख ये सेकंड लेयर केयरफुली लेंगे अभी ओपन करके हाँ ऐसे नहीं छोड़ सकते इसको अच्छे से
Okay. Can I have one more trocar? Yes. Yeah. Here, sure. Yeah. Definitely. Angles, especially the suturing angles, should be. I'll be putting one more trocar here for my suturing. Come back. Okay. Maryland. Yes. Yeah. Now it will be. Dr. Ankur says suturing should be a fun. No, it's not. Yeah. Now you see the angle is clear. I'm suturing the duodenal, continuous suture. You see here, I'm starting from lower end. I'll be putting a continuous suture for maybe 2-3 bites. come back. This will be, we don't know whether there is a fistula, but there should not be any bile leak post-operatively. And that bile leak, here bile leak will not be there in the duodenum, maybe pancreatic leak will be there because we have already diverted the the biliary system. But nevertheless, we should try and avoid any duodenal. So at the moment, I am not seeing a very obvious breach in the mucosa, but nevertheless, we should try and do it. Can you have different type of Maryland? This is angled Maryland, not a smooth curve. Yeah. Yeah. Yes. Yeah, there is no breach, but nevertheless, it's always we can sleep peacefully. Ankur can sleep peacefully. Importantly, Rai sir can sleep peacefully. Yeah. A tough case, but made reasonably okay because of the camera work. We have to congratulate Dr. Ankur and the entire team here. I'm suturing at an angle, and these vibrations is because of I'm using 12 mm. So obviously there are bound to be some tremors. It's not a senile tremors. Please, closer. Oh. It's okay. That's coming in our way. Okay. 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 Scissors. Needle holder. Okay. Suction again. Yeah, 40 PDS. Yeah. Okay. Ball holding. No. Oh, yes. Yes, super. You hold it like this, correct. Ball holding. Closer. Yeah, single layer. Because I cannot go, I'll be doing this like this. I prefer like this, but because it's affecting the duodenum, we'll go like this. Come back, and it's not working, ma. This. It's not working. No. Yeah. Take a different instrument. Okay, give that Marilla, one more Marilla. Don't bother. It's okay. Come back. Is this maximum equal to? Come back. I need space here. Okay. Let's hold it. Because these additions we can release, but sometimes we might injure. You see, these are not good additions to release. But I think we can do it like this. This will have a kink. Show here. Close up, close up. Come back. Yeah. See, I'm not very comfortable doing the. I might injure close up, injure the duodenum. So far, it's going on fine. I don't want to jeopardize all the work so far we have been doing in this. Maybe I can release this. Scissors, please. Scissors. I want the jejunum to be seated nicely. Pardon, sir? Down. I think now it's okay. Suction, please. Suck. Where is the gauze piece? But there is one more, no? Okay. Give the Maryland, please. I'm very happy about the, jejunum, which is very loosely lying. But to compensate that easy, we have some less space. Okay. We have mobilized a little bit. Come back. Beryl, Maryland, please. There is mild congestion. Probably I might 30 Vicryl you have? 30 Vicryl. I can either cut off this with a stapler or I can suture it. Maryland women, sorry, ball forceps. No, sir. ICG by this time would have yeah, blood vessels will not be shown clearly. Close up. Yeah, Vicryl. 10 centimeter, 10. Wait, you have, but that's only. What do you feel? Huh? You want stapler or? Okay, you have one more white stapler, please. Yeah.
Like this.
Yes. That's a good suggestion. Please. Okay. Thirty seconds over. Oh. Forceps, please. Yeah. Close up. Okay. Come this way. Harmonic. Clean the camera. Close up. Just can somebody hold it? One more bowl of forceps here. Or for the time being, you can leave it. Yes. Okay. Suction. Yes. Yeah, it's from the edge. Okay. Bipolar, yes. Bipolar. Bipolar foot switch, please. Okay. Yes. Okay. I mean, Marilyn. If the audience is with us, you can ask any questions now as we prepare for the anastomosis. Oh, now we can leave. Suture, yeah. You can leave it. Yeah, one. Suture. Oh. Oh. Show the length. Slightly more length. Anyhow, we have to use this one for the anterior layer. We'll use this one for anterior layer. 40 PDS, one more. What is it? Yeah, this is 15, huh? Give 25 centimeters. Yes. And from here, he can suck. Huh? Yes. No, not now. When the anastomosis starts. Yeah. So as we are waiting for the suture, I can answer any of the questions if you have. So this is the lower limit. Probably we'll retract with using the suction apparatus. So, yeah. Suction. Don't suck continuously. It's for you. Yeah.
What is the suture material that you will be using?
I'm going to use suck. 4 PDS. Slightly bigger, but we'll try to cut it. Yes. Close up. Yeah, go inside. Oh. Okay, I will be using my left hand just because I have to come from anterior. If I lose the track, it will be difficult. The apex. No. Okay. Oh, yeah. Maryland, yeah. I have to take exactly at the apex. Pardon? Yeah, because that's yeah. Close up. You see, at the apex I am taking. No, come back. Okay. Suck ma. Okay, super. Now, one more needle holder. It's outside in, then it has to be inside out. Sir, madam. No. For Maryland here. Yes. This has to be done very slowly. Yeah. Yes. I can cut a little bit, scissors, please. Because I'm going to put continuous. Okay. Needle holder, please. Closer. I will also remove. Yeah, cut. Scissors, please. Scissors. Closer. Yeah, it's inside out. No, outside in, inside out. Sir, up. Yeah, from jejunum inside out. Outside in, yeah. Close up. Yeah. Yes. For this, you can leave this one. Yeah. Yes. Open. Just close. I mean lock. Yeah. Up. Show the tail. Yeah. Okay. Now it's already outside. I'll be coming in and then follow the suture. I mean, in close up. Yes. Suck. Good. Yes. Close up. Okay.
inside out and then
Yeah, now it will be inside out, outside in.
continue.
Continuous, yeah. Yes, suck. Close up. Somebody can suck here. Oh. Wait. If it's giving congestion. Look. Come back. Okay. This will be. Hold it. Yeah. Yeah. Wait. Okay. Oh, okay. Yeah. Release this one. Yeah. Release this one. Suck. Okay. Okay. Yes. So come back. Oh. Okay. No. Okay. Hold it. Yeah. No. Wait. Okay. Hold it. And now we can use the suction also. Can you? Yeah. Yes. 1%. Yes. Now I have to take in the bile duct side. Probably 2 bites will be difficult because I have to go very close to the apex. Close. Come back. Where is the pull bus? Yes. Close up. I still feel there is some more. Okay. No, sir, when we come, okay. Oh, there are knots. This will be, once we come to the corner, we'll come always inside also. Closer. There is a knot. Come back. Yeah, it's not. If there is a knot, we can suture it and then we can carry on. Yeah, suction. Suction, please. Give it to me. Come back. Yeah. Oh, yes, suck, suck, suck. Yeah, suck. We can try to undo it also. Suck, suck, suck. Suck. Okay, okay, here, here. Can you see? Okay. Marilyn? Yeah, sir, needle water, sorry. Oh, sir. I should have taken Vicryl 4O. Close up, close up. No, no.
To take this blood out.
Oh, okay. Close up. I think we have to take the needle out. We can take it closer. Come back. No, no, not here. Come back. Now it's okay. Okay. Okay, super. Oh, yeah. Small ball, yeah. Please, everyone keep a tag of what's happening so that we will avoid knotting. I mean, come here. Okay. Leave it. Okay. Let's hold it. Close up. Yeah, you pull. Yes, yes. Close up. Close up, close up. Now leave it. Come back. You are doing good job. Yes. No, no, this, slightly. Okay. Down, down, down. Yeah. That's it. Turn. Yes. Come back. Come back. Closer. Come back. Don't pull too much. Huh? There is a serosal tab. Yeah, that's it. Oh, this needle holder also gone. Yes. That. Yeah. Oh. Okay. Oh, it's turning. It's turning. That needle holder was okay. No, you can screw the straight needle holder also. Yeah, this looks good. Come. Yes. Okay. Yes. Okay. Come back. Leave it. Leave it. Leave all those things. Okay. Closer. Okay. Ball loading. No. Okay, close up. Yeah, now you just keep it like this. Okay. Right. Oh, sorry. Yeah, no, you can take this. Now, no need to go for suction. You can change the suction. Come back. Yeah, just hold it like this. It's enough. Yeah. Closer. Suction you don't have, no? That's no suction is it has fallen.
We'll take it.
Don't have suction, no? Okay, I'll wait. Gauze, please. For fresh gauze, can I get the fresh gauze, please? Yeah. So anterior will be easy comparatively. Anterior will be easy comparatively. Yeah. Yeah, but here slightly because of the narrowed space, it is there, but it's okay. We have almost yeah. Yeah. Suck. Okay, come. Yeah, part below is the structure. Yeah. Now just leave it, man. Leave it. Just. Yeah, you can keep it like this. Okay, needle holder, please. Where are we now? Pull that side. No. Leave it. Okay. I have taken.
You have to take over this.
Okay. Yeah. Lock?
No.
Huh?
No.
Okay. Now I think we should go fast. Now we should go fast. Come.
It was very small. It has become big.
Yeah, big, yes. It got elongated by it. So clean the camera once. Camera clean. but we can adjust. Pull it towards, bus, pull it, you towards, yes, yes. No, no, no. Okay. Just lose a bit, lose a bit. Yeah, yeah, yes. We can adjust it because he's long. I mean, yeah, yes, sir. Yeah, yes, sir.
We need to stop transmission now, Senthil. We appreciated your
Okay.
fantastic surgery, and we can hear the applause that very patiently done and very meticulously done. Excellent
Thank you,
job.
sir.
We really appreciate that, and I want you to join us in the symposium after you are done.
Yeah, sure, definitely, sir.
Great.
It may take half an hour more.
Yeah.
Thank you so much. Yeah. It's. Suck. Okay.
Ladies and gentlemen, we will now proceed with a very short inauguration, and I promise you it will be short, followed by the symposium on fluorescence imaging. May I first request our guest of honor, Professor Abhay Darvi, President of ASI, my mentor in ASI and surgery, and Abhay was a lecturer when I was a houseman, so maybe some of the faults I picked up are his. Please come, Abhay. Big round of applause for the President of ASI.
Oh, okay.
Our second guest of honor is Dr. Pavanendra Lal, who is Professor of Surgery at Maulana Azad Medical College and also the Director of National Board Examinations. I also learned that he's an excellent proctologist today, the way he was fingering us while we were operating the workshop. May I also invite my friend Dr. Randeep Vadavan on stage. Randeep, apart from being a close friend of mine, is also a good surgeon, which is an unusual combination. He's a senior consultant at Manipal Hospital, and Dr. Pramod Shinde, Director of Kaushalya Hospital, Nasik, who showed an excellent IPOM today.
Okay.
May I start with the national anthem, Dinesh?
Suction, please. Or you can put it here, yes. Garam pani.
Punjab, Sindh, Gujarat, Maratha, Dravida, Utkala, Ganga, Vindhya, Himachala, Yamuna, Ganga, Uchchala, Jaladhi, Taranga, Tava Shubha Name Jage, Tava Shubha Ashisha Mange, Gahe Tava Jaya Gatha, Jaya Gana Mangala Dayak, Jaya He Bharat Bhagya Vidhata, Jaya He, Jaya He, Jaya He, Jaya 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 He.
Thank you, ladies and gentlemen. May I request our four dignitaries to come to the lamp, and Pooja, can we help with the lamp lighting? Dr. Nilesh, doctor, can you come up front as well, please? Come, Abhay. Come on.
Yes, this pull. Yeah. Come back. Suck, close up.
Kamlesh, we'll do together.
Come back. Yeah, leave it.
तू पहिले शाल घाल. मी सांगतो मला तरी नाव सांगतो.
Needle slightly.
We'll have a short felicitation. May I request my friend Dr. Vishwanath Shetty to come up front and offer a shawl and
Leave it
Shreeford
now.
to
You
Dr.
can leave
Abhay
it.
Davi, President ASI. Dr. Shetty also has been a student of Abhay's in KEM.
Now you can pull it.
Mariel, Shetty or Mariel. May I request Dr. Ashutosh Pawar to come up front to felicitate Dr. Pavanendra Lal.
Suction.
Recording stopped.
Suck. Pull. Okay. Come back. Ethicon people, they have AV cell.
Ethicon.
Close up.
Ethicon वालों को बुला.
No. Clean the camera. We'll see. Somebody can see the recordings and then they can get back to us. Clean.
Recording कैसे देखो? Viewers.
Because the suture is big. It cannot escape.
पोर्टेबल एक्सरे काढायला कळून जाईल आपल्याला.
Okay.